This question is something that I have felt is so common for all PG examinations, starting from your MS, your DNB, your MRCS, even sometimes your FRCS examinations across your NEET SS. This disease with the staging is always something that you are asked. And a renal cell cancer staging is fundamental for all purposes. So I think we'll proceed now to the next one. Hello, can I proceed, guys?
Yes, sir. Yes, sir.
Now, this is an autopsy specimen. Now, the last one was a post-operative. This is an autopsy specimen. What is your diagnosis? What are the complications of the disease? So this is a male whose urinary bladder has been taken out from an autopsy. It has been opened to show you something. Now tell me, what is this autopsy specimen? What is your diagnosis? Please do not write, this is a melanoma of the urinary bladder. Okay, kindly do not write the melanoma. Don't get motivated by seeing the black spot. Okay, I think this is a very simple one. Can I proceed now?
Yes, sir.
Right. This one is an interesting one and has been given across many examinations, and people have made very common mistakes. This is the reason I took up this. Looks like an undergraduate examination question. Not exactly. You will understand what is this reason about giving you this question. Identify the pathology. What is the nature of the operation that has been done? Complete? Okay. This one is another, if you have worked in your emergency, you must have done this procedure. What is the device that has been shown in, for use in what is the device that has been shown? What is the use of this device in emergency? And what are the complications of the procedure that you have done? Okay. Can I proceed now?
Yes, sir.
Very simple question. So today I have made all very easy. Someone will love that these are again below undergraduate standards. What is the use of this device? What is the sterilization of this device? Okay, I think it is simple one. We'll go to the next one. Right. This was the image that was obtained from emergency radiology in a patient with a pelvic trauma. You can see the pelvic X-ray. Now, what is your diagnosis? What is the classification of this disease condition? Right. So I think we'll proceed to the next one, the 14th question. This one also is something from your little. This is a little bit of advanced, little bit of difficult question. If you have seen such a procedure, it becomes easy. If not, it becomes a little bit difficult. What is the procedure that has been shown? It has been marked by the various pictures A, B, and C. What are the complications of the procedure? Okay. Right. The last one in the series. is something not from urology, but from endocrine and breast. Right? Complete? Right. Okay, I think that we have 15 questions and we'll end at this one. And now let us go to the discussions of all. Right. Okay, ladies and gentlemen, have you finished? Should I proceed now? Hello.
Yes, sir.
Yes. Good. So I think the first thing, how was the set of OSCE is very simple, I think. All of them are very, very easy. Hello. How did you feel like this group of questions? They were easy, difficult, come on. What was the what was the difficulty level of questions? Easy? Not easy.
You
Were easy. Tough. Okay, let us see the answers now. Let us start with the first one. Okay. Now the first question in the day is something called as, so let us start with the first one. And we have a patient in a head neck malignancy. Now, whenever we have a head neck malignancy, what is your provisional diagnosis that you felt? What is your provisional diagnosis? Sir, my provisional diagnosis, which is the first question, is a oral cavity cancer, more specifically anterior two-third or the oral cavity tongue. Which surface of the tongue? You can see this picture very clearly. This is the under surface of the tongue. And this is my first provisional diagnosis. Now, so to start with, as I have said, this is the provisional diagnosis that I have. The reason for this is that the patient is a consumer of oral tobacco. He has a tongue ulcer for 4 months, and more or less when you see about the ulcer, though it is very difficult to see about any ulcer in a two-dimensional picture, it becomes extremely difficult to talk about. But still, I think you can see the very clear margins of the ulcer. You can see the floor of the ulcer, which is filled up by slough tissues. Okay, and this is the margin of the ulcer. You cannot appreciate the age of the ulcer, but definitely I cannot appreciate the duration also. So given the picture that he is an elderly gentleman with a history of oral tobacco, smoking, etc., I will feel my provisional diagnosis is a malignancy. Also, the more important point is the node present is greater than 1 centimeter. That means it is a significant node in relation with the cancer. Now, name to differential diagnosis. Can you name me any other differential diagnosis of a ulcer on the tongue? Yes, ulcer. Leukoplakia. Leukoplakia is not exactly an ulcer, madam. Leukoplakia is a patch or a plaque. Remember, by definition, a leukoplakia is defined as a white patch or a plaque. Now, a patch is not elevated, it is flat, more than 5 millimeter. A plaque is elevated, more than 5 millimeter. Both of them are white in color and cannot be described due to any other reason. But this question is, what are the differential diagnosis of this? Now, the conventional teaching is the essays that talk about in a tongue ulcer. The first one, remember that. What are the other essays that talks about in this one? Now, other, right. So, essays could have been a syphilitic ulcer, where ulcers usually are seen in a tertiary and a primary syphilis. Okay. You could have other causes of sharp tooth, which can produce a traumatic ulcer, particularly in this one. Now, some people said that other ulcers of conditions can include, again, ulcers due to sideropenia, that means something in a Plummer-Vinson syndrome, that is iron deficiency. You can get ulcers, but definitely these ulcers are this. Now, beyond this, other cases are usually an etiology. Example, as I've said, spirit or alcohol is an etiology. A spicy foods are etc. an etiology for an ulcer. If you ask me what is the differential diagnosis of this one, sir, I will have number one, a syphilitic ulcer. Okay. Number two, if you have said an aphthous ulcer, okay, I have to give you this one also because this is a non-healing ulcer. But aphthous ulcers, remember that in aphthous ulcers, the floor of the ulcers are usually filled up by a granulation tissue, which is pale in color, whereas a syphilitic ulcer usually have a wash leather type of an appearance. This is not exactly this kind of the ulcer that you saw in this picture. So this is a necrotic slough tissues that you can see in the floor. So if you have said a differential diagnosis and you have written about the syphilis, okay, and you have written about aphthous ulcer, for definitely the examiner is asking you this vague question about what are the other differential diagnosis, I have to give you on that one. But definitely in a provisional diagnosis, I have to give you on the cancer. Now, what are the staging investigations? So this is something which is a very standardized answer. And I feel that while you talk about this one and what are the staging investigations, this is something that I will be expecting accurately from you, particularly in relation with this patient. Now tell me, what is the staging investigation for this patient? MRI of which region?
MRI of head.
Now, whenever we talk about any of these cancers in the oral cavity, now if you go to the NCCN, remember that the minute we talk about cancers of the oral cavity, first things first, they will require you to do a couple of investigations, which are exactly, remember that as far as NCCN, we are talking about anterior tongue or the oral cavity tongue or the anterior tongue. The first one is, remember, a history and a physical examination called as H&P, which should technically be with the history of a tobacco use. Very important for your clinical long case or short case presentation. The tobacco use needs to be quantified according to the pack years that the patient has smoked. So this is the first one in history and physical. Okay. Number two is that this is followed with a complete head neck examination, which you have already done. And if the patient, and it is always a good habit in all oral cavity cancers and patients using a tobacco to use a direct and an indirect laryngoscopy to look into the larynx and the pyriform fossa. Now, so these are the first of the investigations to be done. The next of the investigations to be done always includes an biopsy. And remember that in cases of a cancer, or in cases of a primary, it is usually good habit to take a punch biopsy to detect what is the nature of the pathology and to avoid a false negative. Beyond this, as you are asked to staging investigations, we should go for a chest CT with or without a contrast. Okay. Number fifth is a CT or a MRI. NCCN talks about CT first, then an MRI of the primary, that means the oral cavity and the neck. You can do any of this. Now, do you need a PET CT? The answer is no, you don't need a PET CT in a primary setting. But if it is a recurrent disease, then you need a PET CT. The next ones of doing are other investigations will include a dental examination or a prosthodontic evaluation. A dental evaluation or a prosthodontic, that means dentists are going to evaluate for the mandibulectomy, and people do nowadays either an OPG or something called as a dental CT. This is a new kind of a CT. So this is usually the type of the evaluation that you are required to do for staging of this patient. So what are the staging investigations to be done? This is a very specific thing. History and physicals, direct and indirect laryngoscopies, biopsy that you have already not done, you need to do that. Chest CT, yes, NCCN has talked about not an X-ray, a CT or an MRI of the head neck region, that is both primary and the node, a dental and a prosthodontic evaluation, preferably by an OPG or a dental CT. So this is usually your question, right? Okay. Any questions or any queries in this question before we proceed to the next one?
Do we need to add upper GI endoscopy?
No, sir. In this one, no. In this one, you have not been told about this part, but as you have raised the question, very, very pertinent one, sir. Remember that if you had a cause or tumor of the hypopharyngeal tongue or tumor in the oropharynx, then it is always a recommendation to add an upper GI endoscopy and along with that a fiber optic bronchoscopy. We are not talking occult primary. We are talking of a known primary, particularly in the hypopharyngeal region. This is not the hypopharynx. This is the oral tongue. So as you have said, remember that examination under anesthesia and endoscopy, yes, should be always a good habit, particularly for cancers which are not well seen by your laryngoscopy. If you have seen them that they are hypopharyngeal, it is better to think about doing an endoscopy. Right? Chalo. Now proceed to the second one. This question is a very easy one, I felt. What is the clinical diagnosis in this patient? Ranula. Yes, it's a ranula. Okay. Now, how do you define a ranula? How do you define a ranula?
Retention.
It is not a retention cyst. This is the first thing to remember. This was a concept. We have moved away from the concept. This is technically called as a mucus extravasation cyst. And the previous concepts were that they came from minor salivary glands or in relation with the sublingual or submandibular salivary glands. So people called it as a retention cyst. Kindly mute your audios, please. Right. So, it is a mucous extravasation cyst. Remember, which is seen in the floor of the mouth. Right. Now, so can you kindly mute the audios? Yeah, right. Now, thank you. So, what happens in the ranula is that an enlargement in the size of the ranula makes a ranula enlarged and split the fibers of the mylohyoid, and one part of the ranula makes a dumbbell-like swelling, one in the floor of the mouth and another one in the neck, usually appears in the submental and the submandibular triangle. The mandibular will be the first one rather than the mental, and so this is the clinical presentation of a ranula. This kind of a ranula that plunges through the mylohyoid are thus called as a plunging ranula. Now talk about what are the investigations to confirm. Now, as I have said, this is a clinical diagnosis. So if you are going to ask this question, sir, a ranula is always a clinical diagnosis. In case in which you want to see the plunging ranula and the communication, it is good to have an MRI for a plunging ranula, which shows you the communication between these two, right? Okay, good. Now talk about the treatment plan. What is the treatment plan for this patient? This is usually, don't say excision, this is by de-roofing. This is by de-roofing of the ranula. So that means this is by de-roofing of the ranula. So the treatment plan of this one is a de-roofing of the ranula. Don't say it is commonly called as an excision. It cannot be excised because, as I have said, now if this is the tongue, this is the frenum lingually, this is the submandibular duct which is opening. These are the sublingual glands, and these are all the minor salivary glands. Now, as I've said, ranula is said to happen because of a pathology in the sublingual gland. Now, the problem is that the sublingual gland sits very closely in relation with the submandibular. So, it is good in the primary setting, if this is the ranula, to go for a de-roofing of the ranula, so much so that at the floor of the ranula, you will get to see the submandibular duct opening, or it will be seen near the vicinity of the ranula. But if it is a recurrent ranula, then the bigger problem starts in the submandibular gland excision. Because people feel that rather than excise this area, excise the whole gland in this area to remove the pathology of the ranula. For a plunging ranula, you have to take a call what should be the approach. Usually the rule of 1/3 and 2/3 goes by. If 2/3 of the ranula is in the neck and 1/3 is in the floor of the mouth, then, or people say that which one is the larger component needs to be, the approach for that ranula is dependent upon that. If the neck ranula is a larger in size than the rest of the neck, then it is good to think over with cervical approach or the neck-like approach. Okay, the incision, as I have said, this is a submandibular region. So the incision is made about 5 centimeters below the lower border of the mandible to avoid the injury to the marginal mandibular nerve. So this is all about the basics of a ranula for a general surgeon. Yes, questions on this area, please.
Sir, when to use the term cystectomy and when to use the term de-roofing?
See, cystectomy or an excision is an old terminology. Cystectomy should usually be left only for mucus retention cysts of the other parts of the oral cavity, like the lips or the undersurface of the lip. In the floor of the mouth, remember that this is a slowly growing swelling. Definitely, I will not diagnose this as a mucous extravasation cyst. I will rather diagnose it as a ranula, given the typical location and transillumination with the pale blue color. So, I will reserve the term cystectomy for a mucous retention cyst in the other parts of the oral cavity, like the undersurface of the lips, etc., or maybe the palate also.
The role of marsupialization.
Sir, this is the marsupialization that I was talking about. De-roofing means, if you think about this part, what is marsupialization? Marsupials are kangaroos. That means what they have is they have a pouch made. See, this is the kangaroo. Remember that this is the ranula which you have derobed. So effectively, you are making a pouch-like structure. That is what is called as a manipulation. You are allowing every material to come out into the original process. Okay, right. So let us proceed to the next one. Now, what is this diagnosis? Very good. This is a very simple one. Phimosis. What are the complications of phimosis?
Recurrent UTI.
Okay, so let us start by one. The first of the complications are it produces a retention of smegma in between the folds of the corona glandis. So let us talk about the complications of a phimosis. This comes commonly as a part of your short case discussions. In a virtual presentation, this comes again as this type of questions. So the first of the complications is deposition of smegma, which can lead to complication number 2, that is balanoposthitis. Balanitis is inflammation of the glands. The term posthitis is inflammation of the inner lining of the prepuce. This can also lead to formation of a recurrent episode of an UTI. Remember that again, balanoposthitis or again recurrent UTI may produce a meatal stenosis, which can be an independent entity also along with the phimosis. And thus, after a circumcision, it is always good to look not only for the phimosis but also for a meatal stenosis. The next of these parts is a retention of urine. Retention of urine will thus be followed by back pressure changes, which are extremely rare nowadays. When it's a back pressure changes, as you can see about that happen as a part of complications. Now, what is the treatment that is advised for this patient? Alright, very good. Okay, so it is circumcision, which is no, absolutely not, because the question has not shown you a picture of a meatal stenosis. Neither have they given you any question of a meatal stenosis. Now tell me, this is what an undergraduate would mention. What about the term called prepucioplasty? What is your opinion on this as a part of the treatment? What is prepucioplasty? When is a prepucioplasty done? Now see this picture and understand the picture. In this picture, I hope you will appreciate that there are these white lines, isn't it? What are these white lines, or what is this white thing that is present in this? Okay, exactly. Now see, not exactly BXO, because what is the age of the patient? 4 years. In a 4 years, sir, I will not be very happy talking about or using the term called BXO, balanitis erotic obliterans. But definitely, I will say only one thing that I hope every one of you will agree is a scarring of the prepuce. If the prepucial orifice is scarred because of balanoposthitis, etc., definitely, if you think about how is the prepucioplasty done, a prepucioplasty, that means if this is the corona glandis, a prepucioplasty is cut in a longitudinal manner. It is stretched, and then you need to stitch this, definitely with a partial excision of the prepuce. So a prepucioplasty is somewhat of a cosmetic procedure in a particular some religious communities who want to maintain the prepucial skin. On the other hand, the dilatation of the prepucial area prevents any accumulation of any other urine or smegma in this area. So prepucioplasty has been a very popular procedure nowadays, particularly with religious concerns about going in for a complete circumcision. But remember, to do a successful prepucioplasty, The only thing that you should remember is that should not be any scarring of the prepuce. Because if there is a scarring of the prepuce, the pliability of the prepucial skin is lost. Now, another surgical procedure that comes with circumcision is frenuloplasty. What is this procedure and when is this done? Very good. That means the answer for this is a phimosis is defined as a foreskin that cannot be retracted, whereas a tight frenulum is a condition which allows the foreskin to get retracted, but the terminal part of the foreskin is adherent with the corona or adherent with the glans of the penis by something called as a frenum of the frenulum, which is a band of tissue. That means in this case what happens is this is usually the frenulum and the rest of the skin can be retracted except this part called as the frenulum. So the operation for this is very simple. You just have to divide the frenulum. It is always good to go for a hemostatic suture in this area because it is usually the area where the blood vessels are entering. It is usually good to think about a figure of 8 suture in this area to stop the bleeding from the margin because the rest of the surface of the prepuce has a good vascularity. So this is all about something on circumcision. Your questions on this area, please. I took very have seen such patients, must have done these operations in again huge numbers. Any questions on these procedures, please, or any questions on this disease?
Sir, is prepucioplasty and dorsal slit same, sir?
Not exactly. Now see, dorsal slit means you have asked a very important pertinent question. I should have said that. And right. Now, sir, in dorsal slit, the basic idea, when you do a dorsal slit, now the basic dorsal slit, I will show you a picture of this one. This is, let me come to this one and then I will be coming back to your question on a dorsal slit, right? Okay. Now, what is this diagnosis? What is the diagnosis of this disease condition? I have osce number 4 to do, I know that. What is the diagnosis of this condition?
Ram's-Horn penis.
Very good. This is a ram or penis. If you are not acquainted to using flowery names like ram horn, penis, etc., if you do not know what is the ram horn, this is search the Google for a ram's horn. This is exactly that looks like a ram's horn, which is a sheep, and the penis due to a chronic elephantiasis or a chronic lymphedema of the penis is associated with this change called as a ram horn penis. And in this patient, what is the etiology? It has been given telltale. In this patient, what is the etiology?
Filariasis.
Okay. It is called as lymphatic filariasis or again a lymphatic obstruction due to filariasis would have been the better answer for a osce in a postgraduate exam. Filariasis can be in the inguinal region, filariasis could be in the retroperitoneum. But what is the etiology that is producing this one is very simple question, sir. Is a lymphatic obstruction. Now, what are the treatment options? I will be coming back to that penis question. Now, if this patient has a retention of urine and you are the on-call surgeon, what is the operation that you are planning to do if this patient has a retention of urine? Did you understand? Oh my God. Why will you like to do a suprapubic cystostomy? Now see, this is the reason I brought up this picture. Because these are so common scenarios that are usually mistaken for in an examination and in real life. See, suprapubic cystostomy is the last option. One of my urology teachers used to tell, you see, urology is one among the most easiest super specialties. There are 2 operations that you need to master. One is a suprapubic cystostomy. If things go south, this is one operation that helps. And another one is called as nephrectomy. If things get blocked up in a kidney operation, you can do that. Now, no more jokes, important things now. Come on, guys. Very simple. This is the point that you do something called as a dorsal slit. Why can't you do a circumcision in this patient? What is the problem in doing a circumcision in this patient? What do you think is the problem in doing a circumcision in this patient? Hemostasis. Okay, anything more serious than hemostasis? Come on, guys, you must have done circumcision in these kind of patients, particularly those who are coming from such endemic areas where this disease is seen. See, the basic problem in lymphatic filariasis is that this is the skin that I have marked in green, which is the pathological skin, and this skin is thick. Why do you think the skin is thick? Why do you think the skin is so thick? Because of chronic fibrosis. Chronic lymphedema always leads to like elephantiasis in the legs, that is fibrotic tissue. So you get a fibrotic tissue. And the fibrotic tissue is associated with an addition between the glands of the penis and the orifice. And so is this area, by repeated infections in this area, you get the glands of the penis which is adherent. Now tell me, if you would like to go for a circumcision, what is the technical danger of doing a circumcision? Like say for example this, you go across this and take out the skin. What is the bad thing about doing a circumcision in this patient? Is you can injure the glands, rarely even the urethra also. So if this patient has a retention of urine, the simplest and the easiest procedure is, this is the 12 o'clock, this is the 3 o'clock, 9 o'clock and the 6 o'clock. Always go in this direction, palpate for the glands penis, and then whenever you have made a cut like this, always stay at the 12 o'clock, cut not in a single go, but cut around 1 centimeter, 5 millimeter, 5 millimeter, until and unless what exposes is this part, and it opens up like a book, and at the depth you can see the glands penis and you can see the urethra. This is called as a dorsal slit. What is a prepucioplasty? The prepucioplasty, the reason we came back to this picture is...
Please explain again.
Right. Dorsal slit again, see. It is good to understand which side of the penis is dorsal and which side of the penis is ventral. This is the urethral orifice. I think I have drawn the urethral orifice, and this is the point urine is going to come into. Now, what is the reason of not being able to do a circumcision? The problem of not being able to do a circumcision is the inflammation or the inflammatory tissues which are adherent between the prepucial skin and the glands penis. Now, as for example in this patient, if there is a dense inflammation between the glands and the prepucial skin, the biggest problem is whenever you are going in for a circumcision, you will never know when the glands has been encountered, or you will go for an injury to the glands which is associated with bleed or a urethral injury. So in this case of a lymphedema penis, what is important is always stay at the 12 o'clock, and hence I wrote this one. Start your incision with a scissors or a knife, and then go centimeter, millimeter, millimeter towards the root. Say for example in this patient, maybe that the urethral orifice is hidden here. So the more you cut centimeter by centimeter or millimeter by millimeter, I think you will gradually encounter the glands penis, and at the center of the glands penis, you will get the urethral orifice. So have I made you understand about this procedure?
Yes, sir, thank you.
Right. Now talk about something called as a prepucioplasty, because someone was asking me prepucioplasty. Now there's prepucioplasty, the first and the foremost requisite of doing a prepucioplasty, and hence this is done at a younger age group when these adhesions between the prepucial skin and the glands has not developed, is the prepucial skin has to be soft and pliable, or technically stretchable. If there is a fibrosis between the prepucial skin and the glands, it is impossible for you to stretch. So what is done in a prepucioplasty is that again you make an incision up till the tip of the glands, the skin will now look somewhat like this, like you have done in a dorsal slit. Now what you are required to do is that you are required to stretch the skin on two sides. Some people give a incision on the opposite side also. So what it makes is that it makes the skin on two sides look like this, looks like an open book like approach. The gland penis is in the center, and then what they do is that they go in for stretching it like this and do an hemostatic stitch at the margin. So the basic idea is that it's like somewhat we do a pyloroplasty. We make an incision, stretch it away, and then we close it in a longitudinal manner. In this one, we open it in a longitudinal manner, close it in a transverse manner. So that is a prepucioplasty. Now, important questions that will again, so this is all about the complications in this circumstance. Yes, any other questions, please? No questions? Good. Let us go to the next one. Okay. Now, as I have said, I could not get your question. Repeat, please.
Sir, for that filariasis.
Yeah, sir, we are coming to that filariasis question once again. Yes. What are the treatment options in this patient? This patient does not have a retention of urine. This patient has presented to you with a duration of 15 years. So, what are the thoughts on the treatment options? Okay. See, as I have said, someone had said that very well. If there is a retention of urine, that is an emergency, then you have to go for a dorsal slit. If you fail in your dorsal slit, which is unlikely, then and then only think about an SPC. Remember, an SPC is the last option to enter or drain an urine. Before that, if you can do other means which are lesser invasive or can be done under a local anesthesia, please try that. Now, talk about the next one. Is what are the scenarios when the patient does not have a retention? The only answer is that you go in for an excision of the diseased tissue. And when you go in for an excision of the diseased tissue, then what happens is that after, if this is the lymphodematous tissue in the penis, at the center of the lymphodematous tissue, remember, you are going to get the penis and the glands. And this whole skin is again the edematous skin that you have seen in this area. So what is the treatment? The only treatment that is done is something called degloving of the skin. That means if you make an incision around the root of the penis or the base of the penis, whatever you call that to be, dependent upon this one also, if this is the root, you can preserve some amount of the skin, make a circular incision, and then just go for a degloving of the full skin. While you go for a degloving, remember that what is seen after the degloving is that you get to see the buccal fascia, and at this you get to see the glans penis with the urethra at this mouth. So this part is somewhat that is bare. So this part needs to be covered, and when you are going to cover this area, it is always good to use a split thickness skin graft in covering this area. So definitely the major problems in this area will always be an urinary tract infection in the postoperative period. But yes, this is the only cosmetically acceptable answer for this. Some people have done some local scrotal flaps also, which they feel that are better because given the thickness of the skin of the scrotum, this makes a better idea. You can go for scrotal flaps also to cover this part of the picture. Okay, right. Any more questions on this one? We'll go to the question number 4. Hello? No more? Right. So let us talk about this one. What is your diagnosis from this patient? 56-year-old postmaster, penile ulcer, 1 year, campus urine, multiple palpable lymph nodes, mobile in the right groin. What is your diagnosis?
Squamous cell cancer of penis.
Very good. Sir, given the clinical appearance, it is always good to think about with a squamous cell cancer of which part of the penis? Which part of the penis?
Distal parts.
Distal part. Okay, distal part. Okay. So I will be more happy if you have said involving mostly the glands and destruction of the prepucial skin. I cannot see a gland's penis, I can see an ulcer. The ulcer is a very typical of a squamous cell cancer. Can you say why did you say that this ulcer is very typical for a squamous cell cancer? Why did you say that this is very typical for a squamous cell cancer? Hello.
Sir, because this is the most common, sir, is the penis and inverted edges.
Very good. Rather than say most common, very classical appearance. This is the margin of the ulcer, the black line. This is the floor of the ulcer, which is filled up by dirty tissues. And this is the, what is this blue line representing?
It
Is the edge of the ulcer. What is the edge of the ulcer in this case?
inverted.
Is everted edges. So if you have not seen an everted edges ulcer, this is the classical appearance of an ulcer with an everted edges. Right. Now tell me, what are the differential diagnosis of this disease? What is the differential diagnosis in this patient?
Syphilis, comatose ulcer.
Very good. So again, another question today on this point. Okay, so let us talk about what are the other ulcers that can happen. Okay, and what are the differential diagnosis that can happen. Just a second, please. Now, when I talk about differential diagnosis, the number one that I have is a syphilitic ulcer. Okay, when I talk about a syphilitic ulcer, what is the typical appearance of this syphilitic ulcer? Hello. Right. Can you tell me what is the typical appearance of a syphilitic ulcer? Quickly. We need to be fast now. Which location of the penis has a syphilitic ulcer more common?
Over the glands.
Okay, it is both in the glands and in the shaft of the penis. Okay, point number 2 to remember. After this, is a syphilitic ulcer painful or is a syphilitic ulcer painless? What is your opinion? Very good. A syphilitic ulcer is mildly painful. Please remember that. Okay. So what I will do is that to make your things simple is I will make, when I talk about a penile ulcer, and you are asked about this question as a part of a differential diagnosis of a penile ulcer, then how do I say that? The first one is an ulcer without a lymphadenopathy. Can you name a penile ulcer which is without a lymphadenopathy? What produces something called as pseudo-bubo and pseudo-elephantiasis of the lower limb. What is this ulcer? So this ulcer is something called as granuloma inguinale. Remember that in a granuloma inguinale, the floor of the ulcer, what is the color of the floor of the ulcer? Is beefy red. The typical description is a beefy red appearance. Is granuloma inguinale. Now, the next one is talk about a painless ulcer, and this painless ulcer, or you may say mild pain also, but there are multiple inguinal nodes which are bilateral and the ulcer is indurated. Can you name a disease where the ulcer is indurated? there are multiple ulcer, there are again bilateral nodes and the ulcer is mildly painful and the floor has a wash leather appearance. What is this kind of ulcer called as? This is a classic syphilitic ulcer usually seen in the glands of the shaft. Okay, now third one. The third one in this is a painful ulcer. Now this is not mild, this is very painful ulcer, but with a single node, which is also painful. Do you know about this disease? What is this node? What is this disease? Single node. What is the disease? Very good. This is called as a chancroid. And what is this node in this disease called as? The node is called as a bubo. Okay. Like we had the bubonic plague, that was different disease, but still. Now, in chancroid, remember, what is the ulcer appearance in a chancroid? This is the ulcer that has what kind of an edge? This is an ulcer that is what kind of an edge? Please see that as an undermined edge. The is an inverted edge. The floor of the ulcer is a pale granulation tissue. Okay, let us talk about the next one. The other kind of an ulcer in the penis are now again a painful ulcer, and there are multiple nodes, not one, but there are multiple nodes in that. Okay, this is typically the ulcers are all small ulcers like our aphthous ulcers in the oral cavity. Do you know what is this disease when there are multiple ulcers? Dharma guys always talk about it. This is called as a herpetic ulcer, where there are multiple nodes. Remember that nodes are painful nodes. And finally is a rare group in which the ulcer is painless, somewhat looks like a cancer, but there are multiple nodes. Can you name one such disease? Is something called as an LGV. What is the full form of LGV? Lymphogranuloma venerum. Very good. Now, lymphogranuloma venerum, how many ulcers are seen? The ulcer in the penis is one, but the number of nodes are multiple. Now, where are the nodes present? This was an MCQ in your PG days. Where are the nodes present? The nodes are present on both the sides of the inguinal ligament. So what is this clinical sign that I am trying to show you? What is this clinical sign? Okay, this is called as a groove sign. Why does the groove-like appearance happen? The groove-like appearance happens because there are nodes on either side of the inguinal ligament which make that groove-like appearance. It is called as a groove sign. It is technically called as a lymphogranuloma venerum. So, syphilitic ulcer, I agree to that. The other one should be a lymphogranuloma venerum. Now, if it is a penile ulcer, what are the complications that happen in a penile cancer? Sorry. What are the
desktop screen
cancer? Very straightforward question.
Desktop screen desktop என்ன சொன்ன?
So
retention of
அது இருக்குது நான் இல்லன்னு சொல்ல இது நான் டெஸ்க்டாப் உள்ள போட்டுக்கிறேன்.
If it is a cancer of penis, what are the complications that can happen? Number one complication is
minimize எங்க பண்ணுவா?
of the shaft of the penis. Number two, any other complications? Any other complications? Wait. So remember that lymphadenitis or lymph node enlargement. Very good. What is the bad about the? Why does the patient die? Pardon, please?
Humeral loci.
ஓகே ஐ காட் இட்.
Because the
நான் அது வேற எங்க இது ஆயிட போகுதுன்னு பார்த்துட்டு இருந்தேன். ஓகே, அது முடிஞ்சிச்சு. அதுக்கப்புறம்
femoral artery
எனி டெஸ்கா
is a cause of death because of erosion of the
ஃப்ரீ
arteries,
கேம்பிங்
and that
பண்ணிட்டேன்.
is usually the reason of a torrential bleed sometimes. Okay. Any
இது
more
open
complications? Yes. The other complications are less. That is infection or involvement of the urethra. But remember,
நியூ ரெக்கார்டிங் போடணும்.
where a retention of urine is usually a very rare phenomenon, because the box fascia is
நியூ
usually
ரெக்கார்டிங் போட்.
or the urethral
இத வந்து ஸ்கிரீன் சைஸ் வந்து நம்ம இது பண்ணிக்கணுமா? ஓகே
and so retention of urine is a rare complication. So please remember that. So this completes the description. Now, so we have completed up till this. Any questions in this disease? I can talk about the staging of penile cancers, but today is not the day. Then we will not be ending if we go by that. Okay. Any more questions or queries? No more. Chalo. We go into that. We have not done. Chalo. Now ask 6. 5-year-old boy absent testis on the left side. What is your diagnosis?
Undescended testis left side.
Which one do you think will be the better answer out of these?
Descended.
I could not get your answer, please. UDT or an ectopic? Okay. Why is this not an ectopic testis?
Feel it for the.
Come on, man. I cannot. This is a virtual thing. How can I make you allow to see? We do not have haptics yet. Okay. This is the right testis. I told you, no? You can see the picture so beautifully shown. See the picture once again. What do you feel is this? UDT or an ectopic testis? Very common clinical question. What is the difference between these two? What is the difference? Very good. See that on the right side, the scrotum is developed, as you can see the midline raphe. On the left side, there is no development of the scrotum. So if there is no development of the scrotum, what is this more likely to be? In which condition is there an initial descent of the testes and then later thereafter the testis again returns back to the abdomen? What is that condition called as? That condition is an ectopic testis. Again, we have, oh my God, many terms to remember. I will take a class on undescended testes once. Now, see, the main problem in this terminology is that if you think over in this terminology is called as maldescent of the testes, this is the better terminology that we should all get adopted now. Something called as a maldescent of the testes. Now, the gross things to remember in a maldescent of testes are that there are two groups of diseases. In one, the testis develops and the testis is limp, does come, but is still stuck up at the superficial inguinal ring. Any abnormality up till this point, please remember, is called as an UDT. I will try to be very simple in this. However, if the testis, the minute it crosses into the superficial inguinal ring, then in 90% or 99% it should go up to the scrotum. But sometimes when it does go to the scrotum, it can again come back to the anterior abdominal wall, or it may not reach the scrotum but reach other sides. And hence it is better called as an ectopic testis. So please remember that. Now talking about, so what is a retractile testis then? Now the main problem in this retractile testis is, this is a big area of a confusion. In a retractile testis, remember that in a retractile testis, the main thing in retractile testis is the scrotum should be developed. And when the scrotum is developed, you do all these maneuvers, etc., the Chiat test and also, the testis is again pulled back to the anterior abdominal wall. But when you ask the patient to stand straight, you can coax the testis to come to the scrotum. So that is called as a retractile testis. So you have two kinds, an undescended testes and an ectopic testes. In ectopic testes, remember that the scrotal development is normal. In an undescended testes, the scrotum does not develop because the testes never comes back or never comes to the scrotum. So this is the first part of the description. Now, talking about investigations. Now, as I've said, remember that absent testes on the right side should call you for a clinical evaluation, followed by an ultrasound of the abdominal wall and the ultrasound of the whole abdomen. Even if you have not detected this part, rather than do an MRI, people directly consider doing a diagnostic laparoscopy if you have not located the testes at this age. After the diag you take your decision whether, if you can see the spermatic cord, or that is a vas, enter into the deep inguinal ring, that is then to be diagnosed as a vanishing testis. That means the testis was developed, but then the testis did vanish out because of ischemic atrophy. Or if you did not know vas is seen, that is called as an absent testis or anorchia. That means nothing was developed. However, in 99% of the cases, you get to see a testis at the deep ring. Under these circumstances, it is good to think about an orchidopexy at this age. Now, what are the surgical options for a patient with an undescended testis? We will need to speed up from now. What are the surgical options for a patient with an undescended testis? Depends upon the age. But for all practical purposes, remember that in majority of the cases, we go for something called as an orchidopexy, except in an adult, maybe in an adult nowadays also, in which the testes were not palpable. Under these circumstances, it is good to go for an orchidectomy. Even in adults with a palpable testes in the inguinal canal, there is a big school of thought that always goes in favor of an orchidopexy rather than orchidectomy. Any questions on this area, please?
During the examination,
Yeah. During the examination?
we have
Hello?
to describe undescended testis or non-palpable.
Sir, maldescent of the testes is a correct terminology for all problems of the testes. But with this kind of a picture where he is technically showing you that there is no testes on the left side, I will go for undescended testes as the answer.
What about the
I cannot understand. What about?
non-palpable testis?
Non-palpable, sir, I have not said anything about getting a non-palpable testis. This patient did not have a scrotum that was diagnosed. Now, undescended testes are classified into two types. One is a palpable one that is palpated in the inguinal canal, and another one is a non-palpable one. So, two groups. Right? Chalo. Now, OSCE 7, simple one. What is the diagnosis of this one? This is something called as multiple sebaceous cyst of the scrotum. This is what we surgeons usually tell this to be. Dermatologists have other name for this disease called as steatocystoma multiplex. They have their own peculiar name for the disease, which they say is a benign neoplasm. Whatever it is, both of these conditions are associated with a calcification. They are associated with a calcification. So this is a sebaceous cyst of the multiple sebaceous cyst of the scrotum with calcification. Now, what are the treatment options? The treatment options are only one. You go for an excision of the skin, followed by either the testes are implanted in the thigh if there is an extensive excision, or a new scrotum can be developed Particularly, some people have used a split thickness skin graft, which is not a very good choice in this area to make a new scrotum. But like in this patient, I do not think you will require an excision of the full skin. You will require an excision of some part of the skin of the scrotum. Remember, this is a benign disease, no malignancies or no radical excision of the skin. So this completes your this OSCE. I do not think there will be any questions in this part. We go to the next one. This question is an interesting one. Now tell me, what is the staging of the disease in this one? Bosnia. Bosnia? Come on, man. Bosnia is for the cyst, no? What is the surgery that has been done? Tell that to me first. Then we'll talk about Bosnia. What is the nature of... Pardon, please? Radical nephrectomy. Is a radical nephrectomy. Why did you say this is a radical nephrectomy? Because I can see exactly. I can see the perinephric fat taken intact. That means what I can see is that the fascia of Gerota is intact in the specimen. Hence, this appears to be a specimen of a radical nephrectomy. Now, staging of the tumor in the size of the tumor is 5 centimeter. Okay, in this one, an important question. I hope all of you have recognized that this is the tumor T. Now, tell me, what is this structure?
Adrenal.
Okay, right. So, I'm not very sure about this structure again. So, this is the reason even I am a bit confused about what is this structure, because the fascia of the Gerota, I will take my blue pen to mark out this one. This is the fascia of the Gerota. I do not know whether this is adrenal. Doesn't look like an adrenal because the adrenal should have been present around in this area. Beyond the fascia of the Gerota, because adrenal is always outside the fascia of the Gerota. It doesn't look like the adrenal fat, because the adrenal fat is a different color and the adrenal as such is a different color. Probably this is an upper pole tumor that I have marked for you. This is not the adrenal probably. Now, however, what is the staging of the disease if it is a 5 centimeter tumor? A very quick recon into the TNM staging of a renal cell cancer. Extremely important, AJCC 8. What is the TNM staging? T1 is a tumor. T1A is a tumor which is less than equal to 4 centimeter limited to the kidney. T1B is a tumor which is greater than 4 centimeter but is less than or equal to 7 centimeter. Important words. This is limited to the kidney. Always remember that. A T2 is a tumor or T2A is a tumor which is greater than 7 but less than or equal to 10 but again is limited to the kidney. Whereas a T2B is a tumor which is greater than 10 but it is limited to the kidney. These are things that you have to remember for an exam and this is mandatory to be remembered. A T3. A T3A is a tumor which extends into the renal vein or segmental branches. So number one is vein. Number two is that it involves the pelvic alligeal system. Please mark this area. It involves the pelvic alligeal system or involves the perirenal or renal sinus fat, but not beyond the fascia of Gerota. That means this is something to be understood. If this is a tumor that invades into the renal sinus or this one, but the fascia of the Gerota is intact, this one is a T3A. So what is a T3A? Either the renal vein or the pelvic alligeal system or the renal sinus, but the fascia of the Gerota is intact. A T3B is when it extends into the renal vein and has now gone into the inferior vena cava. This is a T3B. What is a T3C? A T3C includes extension into the vena cava, but now it has gone above the level of the diaphragm. So T3B is below the level of the diaphragm. T3C is above the level of the diaphragm. T4 is any tumor that extends beyond the fascia of the Gerota. It may involve an organ. The reason I asked you what is this? If this is the adrenal gland, and if the tumor is involving the adrenal gland, it has to be considered to be a T4. So this is something that is extremely important for you to remember. Now tell me from this picture, what do you think is the T? Okay, what do you think is the T?
1B.
1B.
T3A.
Very good. Why did you say this is a T3A?
So because it is involving the pelvic calyceal system.
Exactly. And not only the pelvic calyceal system, sir. Look into the renal sinus. Look into this part. See that it is invading the renal sinus and also into the pelvic calyceal system. But it is not going beyond the fascia of Gerota, because this structure, something that I'm marking in green now, is the fascia of the Gerota, and something that I'm marking in blue is the invasion of the tumor into the pelvic calyceal system. So for all practical reasons, though this is less than 5 centimeter, this will be under a T3A, and they have done a radical nephrectomy for that. Okay, right. We will not proceed, we will not, because time is limited. What is this one? Autopsy specimen. I said this was not a melanoma. What is your diagnosis in this one? What is your diagnosis?
The transitional cell carcinoma of bladder.
How could you say that, sir? I said this is an autopsy specimen. Hooray. Come on, man. This is so classical appearance. This is the reason I gave you this picture. What is this structure? What is this structure?
Prostate.
Exactly. See this, see this. And now I will remove. Now I'll remove all. Come on.
Median lobe of
Exactly. Is the median lobe of prostate. Is it? Now whatever name you like to call this as BHP, BPH, whatever name you like to give that to be. This is a benign disease with a benign hyperplasia, hypertrophy of the prostate. So which part of the prostate is this area? This is technically called as, in the older nomenclature, something called as the median lobe of the prostate. And these two were called as the lateral lobes of the prostate. Now by the McNeil's classification, these are technically nowadays not used, but still there is a big group of urologists who will always like to go for the terminology that this median lobe, if you see the picture on a sideways view, appreciate that the median lobe is hanging into which part? Where is the median lobe hanging technically, if you see the picture? Can you see that exactly? Can you see that the median lobe is hanging exactly at the neck of the bladder? Okay. And we will be responsible for formation of something that you feel during a DRE called as, what is this thing that I'm trying to make? Called as a post-prostatic pouch. Okay. So this is what exactly. So what is your diagnosis, BHP or BPH? The question has not been that. What are the complications of the disease that you know of? Quickly. What are the complications of the disease? Oh my God. First of all, come on, man. You can see so beautiful a picture. The complications could be said as array. Complications in the urethra. What is the first complication that has happened in the urethra? Tell that to me. Urethra is elongation of the urethra. Okay, elongation of the urethra is associated with what are the things that are getting blocked? Array. The urethral glands are getting blocked. Remember that leads to an urinary tract infection as a part of urethral secretions, but we'll talk about UTI later. Changes in the prostate. What are the other changes in the prostate apart from a fibromusculoglandular hypertrophy? What is the complication that happens due to a BHP in a prostate? Please don't say cancer. Come on, man. What happens to the prostate? In a case of a BHP, what is the complication that happens in the prostate? Repeated infections leads to acute and exactly acute bacterial prostatitis and chronic bacterial prostatitis. Now talk about changes in the bladder. What is the changes in the bladder that I have? Oh, by the way, elongation of urethra is responsible for a retention of urine. Right. We'll not talk about it. The changes in the bladder. What is the changes in the bladder that you can see in the picture?
Multiple trabecules.
Very good. Number one that I will appreciate is if you use the word thick-walled bladder. Okay, why is the bladder thick-walled, sir? Because of which muscle is hypertrophied? Because of the detrusor muscle hypertrophy. And because of the detrusor hypertrophy, what is the classical mucosal changes? Someone said that very characteristically. And that is also called as trabeculations. Trabeculations are a result of detrusor hypertrophy. Then it will lead to a lot of detrusor problems. Now, you have the problems in the ureter, and now you have the back pressure changes in the ureter and the bladder. Back pressure changes will be there in ureter or will be in the kidney. And you know about what are the changes? Hydroureter, hydronephrosis. So this is the very quick. In the bladder, it will be leading to UTI. Secondary stones will be, and sometimes even hematuria because of the prolonged retention of urine in UTI. So we can write many things, but this is for an OSCE, a quick summary about what is this part. Right. We'll need to speed up now. What is the pathology in this case? What is the pathology? So nephrolithiasis. Anything more? Come on, man. This is a surgical specimen. What is the operation that has been done? Simple nephrectomy. Simple nephrectomy. Agree that your point. Tell me the pathology. Array. Why would you like to do a nephrectomy for a stone? Would you like to do a nephrectomy for a stone? I will not know this. So what is the change, sir? What is the change?
ADPKD.
Oh my God. Someone told an ADPKD. Holy God. Someone who told an ADPKD. What is this one? Array. What is this pathology?
Tag-on calculus.
So, oh my God.
Tag-on calculus.
At least tell me stones, man. I'm more happy.
Tag-on calculus.
Okay, if you say an ADPKD, I will not be very happy. So come on, guys. What is the gross pathology? No one is telling me the gross pathology. It's a hydronephrosis. The examiner is wanting one single word, hydronephrosis. If you have said end-stage renal disease, thinning of the cortex due to hydronephrosis, I will be happy. What is the etiology for hydronephrosis? If we have said a stone, particularly this is an example of a staghorn calculi that is producing an hydronephrosis. Now tell me, why is this not an ADPKD? Because the cyst-like cavities are doing what? They are communicating with each other. That is the reason in surgical pathology you are asked to distinguish between an ADPKD with a hydronephrotic kidney. Remember that ADPKD does not form a staghorn. The stones that are formed are in the parenchyma, and not all the calyces are going to contain stones. If it was an ADPKD, it will be stones that are present in a few of the cysts, but the rest of the kidneys will be affected by cysts of varying sizes. But see that more or less all of these cysts are looking like a calyx and they contain a stone. So what is this disease? This is a stone disease, probably a staghorn like the thing that you are seeing. So this is the staghorn calculi producing a hydronephrosis that led up to a nephrectomy. So this is a very simple, I made it like an undergraduate question, but still do not mention an ADPKD, please. Okay, this one. What is this device? All of you have used this.
SPC.
Very good. So this is an SPC, trocar and only trocar.
Cannula.
This one is the trocar. We call this to be the cannula. Some people call it as a sheath. Okay, like your laparoscopic trocar, etc. What is the use in emergency? To do an SPC. Very good. Everyone knows that. So tell me, what are the complications of doing an SPC?
Bowel injuries.
Okay. Number one, bowel injuries. Okay. So rather than talk about, okay, so very good. Rather than talk about bowel injuries to begin with, I will say that injuries to the posterior wall of the bladder, that is a very good answer. Okay, and injuries to posterior wall of bladder can either lead to hematuria or can be associated with a perforation. Now, perforation is not usually a main problem because it is an extraperitoneal perforation. Now, the next one is bowel injury. Which loops of bowel are injured? It is usually the rectum that is injured, and you need a palpable bladder for this. Apart from this, other rare complications will be a bleeding from the site, and number 4, the hematoma formations. And if the trocar is not been done properly, the puncture or multiple punctures have been given in the space of Retzius, you will end up with something called as a urinoma formation. So this has to be always with a palpable bladder. You should always be happy that the bladder is palpable. It is not any other structure. Even we once had a stomach that was distended in the pelvis and he went into the stomach. We understood it a day later when food started coming out in the urinary catheter. Really, I'm not joking. We really had that. Okay. Right. So this had that. Now, talk about this one. What is this device? What is the use of this device? Tell this to me.
Useful in irrigation of the bladder post-operative surgeries.
Very good. Very good. So this is technically always used for an irrigation of the urinary bladder, particularly in two situations. What? Number one, when you are dealing with a patient of hematuria. When you are dealing with a patient of hematuria. And number 2, in a post-operative TURP or TURBT. Okay. Not only TURP, sometimes also in a TURBT. How will you sterilize this device? Hello. How will you sterilize? Always sterilize. Right. This is the only word that the examiner is wanting is industrial sterilization is done. I know it's a gamma ray sterilization. ETO is not a very good answer for this because rubber goods, etc. in an ETO make some toxic products. So majority of these disposables are always sterilized in batch or industrial sterilization by a gamma ray sterilization. So once you have opened the packet, how can you re-sterilize a Foley's catheter? How can you re-sterilize it? Very good. Thanks for the brave answer. It cannot be sterilized and has to be thrown away. Good one. I really liked it. Good. So please remember, whenever you get a Foley's catheter and the examiner asks you how will you re-sterilize, the answer is please throw it away. It cannot be. Good. Now, this one. What is this disease or what is the diagnosis? What is the diagnosis?
Bladder injury with dye extravasation.
Okay, bladder injury with a dye extravasation. Do you feel this is the bladder, sir? This is picture is very characteristic of only one condition. Please see the picture. What is this image that has been done from the emergency with a pelvic trauma?
Traumatic urethral injury.
Okay, so this is a traumatic. So this is a traumatic urethral injury. I really like it. So if this is a traumatic urethral.
हमारे SIT में यार है कुछ बच्चों पेशेंट भी आते हैं ना.
How could you say investigation is not a retrograde program? It is done in patients with there are some guidelines. There are some guidelines which are directly say that in all patients of pelvic trauma, you should do this investigation before you plan to put in a Foley. There are some who say that no, only patients have a bleeding per urethra. In them, you need to put it this one. However, whatever may be the guidelines, remember that this is the symphysis pubis. I hope you can see that. Okay, guys, please. Now, can you tell me which part of the urethra is injured in this? Can you tell me which part of the urethra is injured in this picture? Which part of the urethra is injured?
Prostatic.
Membranous.
Membranous. What do urologists call this part to be? Remember that they call that anything that is behind the symphysis pubis, as I have mentioned in this picture, and up till the lower border of the and up till the lower border of the pubic rami, this is called as the posterior urethra. Up till this point is called as the posterior urethra. So this is called as the posterior urethra. Okay, just a minute. Whereas anything that is beyond this is called as the anterior urethra. Now, anterior usually means the bulbar and the penile part of the urethra. Posterior means the membranous and the prostatic part of the urethra. So if you see this picture, technically this is into the posterior and this is an injury to the membranous part of the urethra. Now, what are the grades of the disease or classification of the disease? There are two widely used classifications. One is technically called as the AAST, which is a more specific complication, and another one is called as the Goldman's classification, which is much commonly given in your exams. Now, what is the treatment according to the AAST? I like the AAST because AAST goes for the treatment part. Now, under this appearance, like the picture that I have shown, a type 1 will mean, or a type 1 AAST will technically be called as a contusion. Okay. And will mean that the appearance and the thing that goes into the bladder is okay. And it's just a contusion and no problem. What is the treatment that is done? This patient needs no treatment because the urethra is intact. See the picture. A type 2 AAST technically means a stretching, which means that the urethra is stretched up, is elongated, but there is no extravasation. Remember, under this one, it is good to consider an SPC or a per urethral catheterization. Still can be done. A type 3 or a grade 3, not type 3, a grade 3 is a partial disruption. The partial disruption means one wall is intact and another wall is leaking the dye. The treatment again is an SPC, per urethral catheterization, if you can do a per urethral. Okay. Type 4 means a complete disruption where the two ends, so the complete disruption is extravasation is there, like as would have happened in this picture. Okay. And remember that the bladder is not seen. The bladder is not seen, as in this picture. Okay, the bladder is not seen. This one requires an SPC followed by a delayed repair. Okay, and this is by again an urethroplasty. Whereas the last one is a grade 5. Remember that is again a complete transaction, and this complete transaction that has happened is along with injury to the prostate or the vagina, and this again requires an SPC followed later by a delayed repair. So 4 and 5 more or less are understood by this picture. So this probably is a grade 4 or a type 4, whatever you like to call this to be. So this is the urethral injuries which are managed. Okay, the last two questions. What is the procedure that has been shown? I Hello. Right, very good. So this is an ileal conduit and everyone has identified that. What is the complication of this ileal conduit? What is the complication of this ileal conduit? Electrolytes only. Now see, the main group of complications, ileal conduit, remember that, is done after which operation? Right. So that means it could be divided into, remember that, after something called as a radical cystectomy. Now, when you try to divide the complications of an ileal conduit, remember that ileal conduit complications are grossly divided into something that is linked to the bowel function. Okay. Now, something that is divided into bowel functions. Okay. And other complications can be in relation with the conduit and its later complications. Now, bowel functions means the anastomosis that you have done with the bowel that can undergo a leak, etc. So that is a separate complications that we are not required to talk now. Other group of complications that talk about the conduit related complications would have been an infectious complications. Remember that an infectious complication, that means a urinary tract infection, etc. Now, other part of the story, so urinary tract infections are one of this common complication. Remember that the types of complications that can include a stenosis, that can include an extravasation, that can include metabolic complications and stone formation with absorption of oxalate. So these are the multiple things. Some people always also compare that stoma related complications, like example, a prolapse of the stoma and stomal So this is in all the complications of an ileal conduit. Right? Chalo. We go to the last one. Time is short. What is the stage of the disease? T4B. T4B. Stage. Man, I'm not talking about the report. What is the clinical appearance of the skin? Definitely PDO. So what is the T then? At least the T will be T4B. What is the N?
3C.
What is the M?
3C.
M.
1.
Okay, good. What is the stage?
Stage 4.
Stage 4. I gave this thing for one single simple reason, so that I wanted to again wake up and do again repeat the TNM for you. Okay, so this is something that you are required to remember for this part. Important questions to ask about in this area are: what are the investigations that you will advise in this patient? This is a patient with an M1 disease. What are the investigations to do? What are the investigations to do?
CT chest, abdomen, and pelvis.
Very good. So CT chest, CT abdomen. Okay. Now CT chest and CT abdomen plus pelvis should be written at the same time. This is the first one that you are always liking to do. What about your spine? Okay, wait. This is the reason I asked you, sir. very specifically in this question. This patient has symptoms. Remember, this patient has symptoms. Rather than do a bone scan, I will be directly going in for a spine MRI. Okay. Number 2, yes, will you like to do a bone scan? Yes, I will add a bone scan. That means this patient will require both. If it was only an LABC with no clinical symptoms, then I would have omitted out the spine MRI. But in this patient, I will always like to add the spine MRI because this patient is symptomatic because of the pain. So I will require a bone scan and a spine MRI. What about a PET CT? What about a PET CT? What about a PET CT? Remember that PET CT as such will not have a clear-cut role in this one because the spine disease is clinically an obvious disease. So rather than talk about these are mandatory investigations, this will be an optional investigation in this patient. Okay. When will you like to do a brain MRI?
In symptomatic.
Exactly, in symptomatic patients. Very good. This one is the first one to remember. So this is the staging investigations that you will be able to do. What are the treatment principles, sir? What is the basic part of the treatment principle? What is the treatment principle? I know that. Neoadjuvant. So the main treatment policy, the main treatment thing is only one, is palliation. But in this palliation, remember that what is the main problem? The main problem is in a patient with a CA breast with these kind of issues, the first issue is the bone disease is present. The patient is screaming in pain. Okay. So if the bone disease is present, what are the drugs that are added to a bone disease? Drugs that includes denosumab, very good, pamindronate, and bisphosphonate. So this is for bone disease. And remember that beyond the bone disease, the rest of the treatment thereafter depends upon what is the ER status, the PR status, and the HER2 status of the patient. Depending upon that, you need to think over what are the other drugs to be added. Number 2, for painful bone metastasis, remember that radiation is an important modality to decrease the bone pain. So this completes your description about in this case. Remember the question was very specific. Treatment principle are again bone disease, and beyond this, the main part of the treatment is adjuvant. Adjuvant will be started with depending upon the ERPR status. But for palliation, I would use denosumab, bisphosphonates, pamindronate, and radiotherapy to the spine for the decrease of the bone pain. This completes your description, right? Okay, guys. So we had a extensive discussion.
Sir, is there any role of mammography?
Mammography in this one, sir, you can to confirm the disease. You can do a mammography, not for this breast, because this breast, your intention is palliative. Definitely to see on the other breast for a second primary or a metastatic disease, yes, it will be. So that is completion of the triple assessment. But you have been asked about investigations to be done. Yes, you can talk about, I would like to complete the triple assessment by doing a mammography and a coronary biopsy. But definitely you also have to complete about that this is an M1 disease, as we have said, T3B and 3C M1. So we like to complete that, right? Okay, complete. Okay, guys, so that was all about all these 15 OSCEs. So how did you like this OSCEs? Easy or difficult? Much easier than the previous ones. Yes, sir. Not difficult to.
May I ask a question, Ramanuj?
Yes, Sanjay.
What did you do with the suprapubic gastrostomy?
What did I do with the suprapubic gastrostomy? Well, we did a case report. So that was something that really happened. You see, truth is stranger than fiction, and that happened.
I'm
Okay,
sure.
right. Thank you. Okay, ladies and gentlemen, thank you very much. So We'll meet again later with another set of OSCEs. Thank you. Sanjay, sorry for taking in 10 minutes.
No, that's absolutely, it's marvelous.
Okay, right. Thank
Fascinating.
you. Okay, then. Bye, everyone.
Right, you guys want to have a quick cup of coffee and come back in 2 minutes?
Yeah, I think that. Okay, Sanjay, I'll be taking a leave now. Thank you. Bye.
Okay. Thank you very much.
Thank you, sir.
Shilajit, I'll share my screen, but what I'll do is it's 7:11 now. We'll start at 7:30, if that's all right.
Yes, sir.
Okay. So give people a bit of time to grab a glass of water, or coffee, or tea, whatever. Right, guys. So we start off, and what we do is we'd actually go through the process, and as you quite rightly know, that the OSCE format as it exists for the DMB is 5 minutes with 8 marks each, separate answer sheets for each question, and each of the answer sheets has to be submitted at the end of the time for that question. Till date, we have 25 questions, so totaling up to 200 marks. The important thing is, even if you get one wrong, it's only 4% marks. So please do not allow it to fester and spoil the other 96 answers. What we'll do is, just so that you get used to the idea, I think you have an answer sheet ready. With your pen and paper ready, we'll give you 2 to 4 minutes, depending on the question. You will have 5 minutes. On question B, you will have 5 minutes. I think it's a good idea for you to try and answer in 3 minutes so that you get used to the idea of the asking. Right. So, simply man, the poetic control diabetic comes into the
Even now, high na?
lacking of a third too. There's also a suggestion that we pass it to as you can see out here. So how will you manage him? The collection of the loadsome has been managed. What now?
He time like
Patient and angiography shows a mild disease of the knee and a heavily calcified multiple stenosis and including vessel. What can be done?
Zoom class.
So the time starts now, and for this, just to make sure that we have plenty of time, we need to cover quite a bit. So we'll give you 3 minutes for this. Right, guys. So it's time for us. And so let's have a look. What we'll do is we'll go through the answers right now. Careful history and examination assess for neuropathy, peripheral artery disease, and systemic complications. Please remember that he's a poorly controlled diabetic. So you have to mention that. You do an MDT foot team after admission, routine blood testing source for an infected gangrenous area, both aerobic and anaerobic. Remember that this is a diabetic gangrene. You have to do an anaerobic culture. Immediately offloading of the foot, which means you take the weight of that foot and you the body actors. This has to be an urgent imaging, which might be over X-ray start with, but eventually you're going to need an MRI because you need to know the full extent of the abscess and surgical drainage of the septic source, and that is mandatory. Without that, you can't proceed. So post-drainage management, you give a broad-spectrum antibiotic, and you have to continue then guided by antibiotics when the culture. If that's the toe, which is infected, multiple toes, and that's a great toe. If that's the toe that is infected and black, so what you need to do is remember that you're going to give an incision which looks like a racket. It's an incision like that. It goes all the way across out here and comes in again on the top. So that's your incision. You go in. Sometimes you're lucky enough to do a disarticulation between the proximal phalangeal, between the tarsometatarsal joint, and then you can do a reamputation. Sometimes you have to leave the wound open because this diabetic wound actually heals quite fast. So there we are. So that's the principle of a reamputation. And what else would you do? Right, I'll find the same. Yeah. Right. Where the angiography shows mild disease above the knee, but heavily calcified multiple sclerosis. So all the crural vessels, what can be done? You have an option of doing an endovascular balloon dilatation or angioplasty. Can do an open surgical by a bypass grafting from the superficial femoral artery or the common femoral artery or the popliteal to below knee. And if you're crossing the knee, you cannot use an artificial graft. It has to be an autogenous or venous graft because artificial grafts inevitably clot if you're going across the knee. But you may do a hybrid procedure, in which case you do an angioplasty of the superficial femoral artery and the popliteal and a popliteal to mid-calf bypass. So that's the technique of addressing the vascular problems in this patient. Okay, so we thought that, that's the sort of way that, answer and point forms, answer brief to the point. You don't have a lot of time. 5 minutes is quite short. So we go on to the OSCE 2. So this is you're going to have 3 slides. So in your DNA exam, sometimes you have a single slide, sometimes you have 2 slides. So please, if you have data given, please copy it down on that answer sheet that you're given. So what we do out here is 74-year-old female has a long history of constipation, presents with a rapid development of constipation, pain lower left abdomen, and a fast developing swelling in the lower abdomen. She is nauseated, but there is no vomiting. On examination, has tachycardia, blood pressure is normal, looks dehydrated, has a low abdominal tender swelling, no rebound tenderness, resonant, no free fluid, and a rapid bowel sounds, and PR shows ballooning. So what is your diagnosis? Does the sign have a name? How would you manage her? The initial management fails. What would you do then? What are the different methods of surgical management? So we'll start off and give you 3 minutes again.
दिवस शांत बसतात माझे पुढं काय करतील
Right, guys. So I'm sure you know what the diagnosis is. Who's going to tell me? Somebody tell me what is the diagnosis?
Sigmund 1 diagnosis.
Very good. And what is this sign called?
Coffee bean sign.
Coffee bean sign. So it's known as the coffee bean sign. So coffee bean sign. The other eponymous name that you need to remember is the Freeman Dahl sign. Freeman Dahl as in Roald Dahl sign. And the sign is that essentially you have 3 lines traveling down. That's one line, that's the other line, and that's the other line which is heading down into the pelvis. So you have 3 lines heading down into the pelvis. So coffee bean sign or Freeman Dahl sign. Please remember that, guys. And so we'll go to the next. That is, these are the answers. So we asked that question. So how would you manage this? How would you manage this patient?
Sigmoidoscopic decompression.
Yeah, the first stage is resuscitation. Remember, guys, I mean, whenever you must remember that you have to go through the stages. I know it sounds irritating, but we will repeat that ad nauseum. The first stage is resus, okay? And then you would go in for a sigmoidoscopy and go in for a sigmoidoscopic decompression if you can. So sigmoidoscopic decompression. Decompression. If that works, what would you do? Success, what would you do?
The patient LPM and
if you manage to put a sigmoidoscope, if you've managed to decompress it through a sigmoidoscope, you managed to decompress it through a sigmoidoscope, what would you then do? You would actually put in a white bore tube around, passed under guidance of the endoscope so that it doesn't twist, and put her on the next immediate surgical list. Okay? Why? Because otherwise it will twist. So what would you do then? At the operation, what would you do? You have a sigmoid which is fairly long, you know, with a narrow sigmoid which is very long with a bit of a narrow base. So what would you do for this particular patient?
Sigmoidopexy. Sigmoidopexy.
Sorry?
Sigmoidopexy.
Sigmoidopexy. Okay, now that is an operation you're never going to talk about. The reason is, never mind if you do a sigmoidopexy, it always extends and then the patient will be back again. Okay? Remember. So the treatment will always be that you will do a sigmoidectomy. Okay? Remember, guys, you will do a sigmoidectomy and do an end-to-end anastomosis, because remember, you've actually taken the emergency out. So you're going to do a sigmoidectomy and you're going to do an end-to-end anastomosis. The problem of doing a sigmoidopexy and just a moment. You've got a sigmoid which is very long with a very narrow base. Think about it, guys. How are you going to do a sigmoidopexy with something like that? You can't push that down. If you're trying to push that down, what will happen? The inevitable problem is that there are blood vessels which are leading up out here. You do a sigmoidopexy and you take a bite through this tissue in trying to shorten it, your vascularity of this area goes. So please remember, guys, no sigmoidopexy, we will go in and do a sigmoidectomy, right? So if we are successful, if we are unsuccessful, what would you do? We haven't managed to decompress it. This is your twist. And that is hugely distended. Sorry?
Immediate laparotomy.
So you would go in for a laparotomy and then what would you do? You untwist. But be careful when you're untwisting, because sometimes you have intravenous, release of all the cytokines and the inflammatory mediators that have been released into, because this is essentially a closed loop obstruction. So remember, sigmoid volvulus is a closed loop obstruction. Okay, so what are you going to do? Okay, we've derotated it. Now what do you do? If you derotated it, this is one of the conditions where you might do a resection and end-to-end anastomosis. Can you tell me why? Because of this rotation, that loop and that loop is, because it presents very early, because of this being a closed loop obstruction that hugely distends and the patient presents very early, this loop and this loop sometimes have a similar lumen, in which case you can do a resection and anastomosis. The rationale for doing a resection anastomosis is simply because it's a closed loop obstruction. The distension completely is restricted to that loop which has twisted. It is not there in the proximal descending colon, not there in the distal sigmoid. So you can actually do a resection and end-to-end anastomosis. If, however, there's a gangrene of this area with peritonitis, then you have to do something. What sort of an operation? So one of the first options is resection and anastomosis. What is the next option? You've got gangrene. Hartmann's procedure. Absolutely right. You do a Hartmann's procedure. You do a Hartmann's, you close that end up and close that end up with non-absorbable sutures, leaving the tip long and sometimes even fixing it to an area where you can identify it later and bringing that end out as what? As a end colostomy. Okay? Right. And then you can go in later and do a later end-to-end anastomosis. Okay, right. So principle is use line diagrams and finish your answer. Right. Now we'll go on to our next osce. Right. Now we've got a 70 kilogram man in a third post-op day. Following an uncomplicated ventral hernia operation, he has a post-op vomiting of 500 ml, has passed 1,000 ml of urine, has received 500 ml of antibiotics and analgesics. So I want you to calculate how much of fluid will you require, what is his requirement of sodium, what is his requirement of potassium, and what type of fluids will you give. Okay. I'm going to give you 3 minutes for that as well. You realize I'm stressing you, but there we are. Makes for you to do a brilliant job when you actually come up with your exam. So Okay, guys, so that's time. So what is the answer? When you're calculating the maintenance fluid, you have the 150-20 rule. So please, guys, remember that you need to have some system. There's a 4-2-1 rule as well. I find it easier to calculate in zeros. So, I'm a simple surgeon. So 150-20 rule is something that you can follow. 100 ml per kilogram for the first 10, 50 ml per kilogram for the next 10, which means that for the maintenance, you're giving 1,500 and 20 milligram per kilogram for every kilogram over 20 kilograms. So sodium is 1 to 2 milliequivalents per kilogram, 0.5 to 1 milliequivalents per kilogram per day. Chloride is 1 milliequivalents per kilogram per day, and calcium 2 grams, magnesium 300 milliequivalents per day. So since this man is a 70 kilogram man in the third post-op day, by which time his kidneys have started working, he has a vomiting of 500 ml, has passed 100 ml of urine, has removed 500 ml of antibiotics and analgesics. So the total fluid required is 2,500 plus 500 plus 500 plus 1,000 plus 500 minus 500. So that gives you a total of 3,000 ml, which means he requires, in our situation, our hospitals, 6 bottles. His sodium requirement is 7 to 140. Potassium requirement is 35 to 70. So what fluids? So you need to know what is the composition of the fluids that you are using. NS, RL, RS, isolate M, DNS, and 5D. Please, guys, remember one thing. One of the movements away from using Ringer's solution is that osmolality is actually quite low, has been reported to be quite low, that normal osmolality is 280 to 310. That's milliosmoles per liter of plasma. And remember that RS has a very low osmolality. And one of the moves away from using DNS as it exists in India, is that it is very, very, very hyperosmolar. It's 560. So remember that, guys. Right. So the ones that we use is, if you were practicing in the West, they use 4% dextrose and 0.18% sodium chloride, which is actually isotonic. That's 284, and gives you a sodium of 131, a chloride of 31, and no potassium, no magnesium, no calcium. So there we are. So what fluids are you going to use? I've given you that choice. This is the fluids that we normally use. So 300 ml of fluid, 6 into 5, 200 ml bottles. Sodium we need to give 70 to 140 milliequivalents. Potassium 35 to 70. The patient is vomiting. So a mixed gastric aspirate contains approximately 100 milliequivalents per liter of sodium, 120 of chloride, and about 20 of potassium. Okay, so we could give, for a sodium, 2 into RL, that gives you 130, 2 into isolate M, that gives you 36, and 2 into 5% dextrose, that gives you 0. Potassium, if you're giving that isolate M, you're giving 35, plus 5, that is around 40, total of 40. So it's a good idea to have something like this. You have a chart like this, and you can put in the type of fluids with total volume, the sodium and the potassium. So guys, I want you people to do an exercise, just for, we're going to spend a bit of time on this, but I need one of you or anyone, you can contribute. So give me what are the types of fluids that we are going to use. Any takers? So if we don't have takers, then we do that fluid and electrolytes in time later. Let's suppose we use this, something that I've thought out. Given 2 5Ds, an isolate M, a 5D, and a normal saline with ACl, that's 10 ml. and an isolate. Now, two issues. The first issue is that you're very worried about using normal saline and KCl. Can somebody tell me why? Why is it that we are worried about putting KCl into normal saline normally? You do it on a regular basis. Yeah, tell me. We do it on a regular basis, don't we? You know, putting KCl into normal saline. The reason people will tell you don't put it into 5% dextrose because that becomes a polarizing fluid, and you know, insulin will drive potassium into the cells. So you put it in normal saline. If you take the molecular weight, ACL is actually heavier than NaCl. So if you aren't careful, the bottle contains KCl at the bottom and all the normal saline on the top. So you come in, let's suppose you've come in and sister has been late in giving that, and you start shouting at her, sister, why is it, you know, why haven't you given that fluid? So what she does is turns it on. So what goes in as a flush? You're putting in KCl rapid infusion, and you're going to have a patient who will almost certainly have a cardiac arrest. So just be careful. We don't address this in the West. You're never allowed to put in KCl into normal saline. If you have to give KCl, you use a syringe pump. Where does one get a syringe pump in most wards? You don't get a syringe pump in the wards. We work in basic conditions. But see the amount of sodium that we've given. It's about 130, and the amount of total potassium that's given, 55. This is what we normally calculate. But there is a bit of a problem. A bit of a problem is we don't anticipate for the chloride. See, that is the major problem of not having an infusion bottle that has a sufficiently low level of chloride. So, guys, we are actually giving 146 milliequivalents. The usual daily requirement is 1 milliequivalents per kilogram per day. So this is 70. I'm giving this patient twice as much chloride, and that's inevitably what we sometimes do. Usually the kidney takes care of it. There's never usually a problem. Only time is if you have trauma and you're doing massive transfusion, that is when it becomes a problem. You know why? Because if you're giving too much of chlorine, you land up with a hyperchloremic metabolic acidosis. Large volume sodium chloride resuscitation generates hyperchloremic acidosis and a renal vasoconstriction, both of which contribute to unpredictable water retention and electrolyte. In many cases, acidosis can be avoided with the use of solution containing less chloride than 0.9% sodium chloride, such as Ringus lactate or plasma light. Okay. Right. So next,
Sir, I have a question to ask.
Yeah, sure. Go ahead. Ask me that question.
Sir, like while calculating the maintenance fluid, like you calculated it to be 3000 ml. In that, you had added 1000 ml as urine also. Sir, my question is like whenever we calculate this maintenance fluid, as per the Hollider's Seliger's formula, it is 2500 ml that is supposed to give, but that is inclusive of urine, right? Are we supposed to add the urine output additional to that?
Yes, you are, because this actually takes care of your maintenance fluid.
Okay, sir.
150/20 takes care of the maintenance. What is the maintenance? Maintenance is insensible loss. Maintenance is the fluid required for metabolism. Okay, so that takes care. Over and above this, if you do a rice tube, you lost something in rice tube. You have had urine passed out, so that becomes sensible loss, isn't it? This is insensible requirement. Okay.
Yes, sir. Thank you, sir.
Right. And we'll actually do a class on fluid and management on an extensive basis. Okay. That is on schedule for you, because I think that is something that you need to discuss. Right. So the fourth osce, again, a bit of a problem, and again, 3 minutes. So time starts now. Okay, guys. So, what are your answers? Okay, overall change is acid, right? No question about that. It is acid. PCO2 is low. So it cannot be a respiratory acidosis. PCO2 is high when you have, if it's respiratory acidosis, it's low. So bicarbonate is low, so it's contributing to the acidosis. So what sort of an acidosis is it? It's a metabolic acidosis. Okay, that's their way of calculating. The components are pulling in opposite directions. So if bicarbonate is low, if it's contributing to the acidosis and PCO2 is low, why is PCO2 low? Find out what the anion gap is. What is the anion gap? Anion gap is usually calculated sodium minus chloride with bicarbonate. Some people actually also put in potassium out here. Okay, sodium plus potassium minus chloride and bicarbonate. So this is approximately around 10. So it's actually normal. So is the compensation that has been, because it's a normal anion gap acidosis. So let's find out whether the compensation is adequate. The carbon dioxide is low because of the acidosis, because of the metabolic acidosis. It's trying to generate respiratory alkalosis to counteract the metabolic acidosis. So is the compensation adequate? So you use something called a Winter's formula. And again, when we do acid-base balance, I will talk about this. The next osce is also that will give you a small sort of, a cheat code so that, people who are going for the exam don't need to do that extensive class on acid-base and you can get through. So the Winter's formula is PCO2 should be equal to 1.5 into bicarbonate plus 8. For all intents and purposes, take it as 10. Plus 10. So if you actually put in the value, so that's approximately 34. So you see that is actually an adequate compensation for the metabolic acidosis. So that's what you do to use to find out what the compensation is. Right. So let's go to the next, and that is again an acid base, and we have an extensive discussion. So again, for 3 minutes, that is your second acid base problem. A 75-year-old man was admitted with severe congestive cardiac failure. He's been unwell for about a week and has been vomiting for the previous 5 days. He was on a high concentration oxygen by mask. No history of any medications. He was hyperventilating and was very distressed. The emission biochemistry is given. The questions are, what is the acid-based effect? Explain the values of PCO2 and bicarbonate, and explain his anion gap. So 3 minutes. Right, guys. So let's go through the answer sheets. So the patient is alkalotic, hyperventilation due to congestive cardiac failure. The difference of normal more so respiratory. Vomiting could have been contributing to the metabolic alkalosis. The anion gap, if you calculate sodium plus potassium minus chloride, gives you 33.2. So if it's high, you need to exclude lactic acidosis and diabetic ketoacidosis. Right, now I've got a cheat code. Guys, I mean, I've always used this. When you find out what the disturbance of the acid-base balance is, look at the PaCO2. If the PaCO2 corresponds to the change in pH, it is definitely respiratory. So if it's high, if it's acidotic, low, if it's alkalotic, you're talking of respiratory change. That respiratory change is contributing to either the acidosis or alkalosis. If it doesn't correspond to the change, you find out what the base deficit is, and that is your base deficit. Does that correspond to the change? If it corresponds to the change, which means if the patient is as acidotic and the patient has a base deficit and the patient is acidotic, it's metabolic. If the patient is alkalotic and there's a base excess, it has to be metabolic. The problem starts that if it does not correspond, then you're talking of a mixed reaction. So, I mean, I would suggest that it's a very good idea if you can just take a screenshot of this. This has stood me in good stead throughout my surgical life. So just remember that. Okay. The next thing is, what are the ratios? We are often asked, what is the respiration? Is the compensation adequate? If you're given a base excess, the problem is very simple. The change in PaCO2 divided by the change in has a ratio between the change in standard base excess. The change in CO2 over the change in SPE is equal to 5:2. The problem starts, and that is why we use the Winter's formula, because in some places only the bicarbonate is given. If the bicarbonate is given, then you use this. Forget this. You very rarely have to use that. Winter's formula is that if acidosis is present, PaCO2 is equal to 1.5 into bicarbonate plus 10. I mean, 8 plus minus 2 is huge. Just remember 10. Easy way to remember. PaCO2 is 1.5 into bicarbonate plus 10. So, if you're given that, and we were fortunate enough to do this exercise even during the first, even before the first osce was taken for DNB, and thank God we did this because people had acid-base problems. Okay, so remember the Winter's formula. You don't need to remember that formula. It's very, very, very rarely used. Now, what about the anion gap? As we said, anion gap can be sodium plus potassium and chloride. That's usually 12 to 16. Guys, I think you need to mute. Okay, please. So you have a low anion gap, which is less than 6 per equivalent. And usually, very characteristically, either it happens in hypoalbuminemia, where your albumin is quite low, below 2, often or as low as 1.5, or you have a monoglobulin protein. So that is very specific. You have a normal anion gap acidosis. So the normal anion gap is 12 to 16, and this is a mnemonic used very regularly. It's called accrued. So acid load, C stands for chronic renal failure, C as in carbonic anhydrous inhibitors, R as in renal tubular acidosis, U as in uretero, and trust me, you just had a talk on ileal chondri. Previously we used to put it up into the sigmoid, with the presumption that people who, would go into the toilet, pass stool and pass urine just like normal, and they landed up with a normal anion gap metabolic acidosis because of urine being absorbed through the entire colon. E is expansion as in extra alimentation, and D as in diarrhea. So, but you also have a high anion gap. And this mnemonic, I'm fond of using. It's called U mild, U as in uremia, sulfate, phosphate, or urine present. M as in massive rhabdomyolysis, H plus or organic ionides. I as in ingestions, particularly methanol or ethanol poisoning and salicylates. L as in lactic acidosis, so L-lactate or E-lactate. Remember that D stands for diabetic ketoacidosis, and you have beta-hydroxybutyrate and acetoacetate causing high anion gap metabolic acidosis. So remember, guys, I mean, this then becomes, if we go back, discuss, this is patient is alkalotic. The hyperventilation is due to congestive cardiac failure. The difference from normal more so, it's respiratory. So the patient has a respiratory alkalosis. Vomiting could have contributed because of the washout of carbon dioxide. Vomiting could have also contributed to the metabolic alkalosis. The anion gap is high. So you're thinking in terms of either you need to exclude lactic acidosis or diabetic ketoacidosis. So that's the way to approach these problems of acid base. Right. So the next OSCE. A 76-year-old lady presents with loss of weight, weakness in the early satiety, and passage of black tarry stools pronounced over the last 3 months. She's found to be anemic, hemoglobin of 6.7, but coagulation parameters are found to be all right. An endoscopy reveals a large globular mass in the stomach with superficial ulceration and bleeding. And a CT scan of the upper abdomen revealed the following. The histology shows spindle cells with a fair number of mitotic figures. So, questions are, what specific inputs from the radiologist would you see? What special tests would you request from the pathologist? And how would you manage this patient and assess or stroke classify the results of your treatment? You want to treat this patient, how do you assess the treatment? So again, guys, I'm going to give you 3 minutes for this. So there we are.
Sir, can you show the previous slide again?
Okay. Now, the important thing is always remember that you need to pick it up. Yeah, okay, fair enough. I think that's fair enough. So you've got the questions down. So we'll leave it at that. We'll leave it at this slide. Okay. So remember what we are asking is radiologist input. We are asking for the pathologist input. And we are asking you to, how will you treat and assess the treatment? Okay, guys, so we go ahead, and now that we have the questions and you've addressed the questions, so first answer is, what sort of input would you ask from the radiologist? This is obviously you're looking in terms of what is your diagnosis. So let me go back to what is your most likely diagnosis? This is lesion, isn't it, guys? Yeah, that's a lesion.
Say stomach with liver mets.
You probably don't have such a sort of a localized lesion. Of course, I grant you that. I mean, I've been caught out on times. I would think in terms of, yes, because you've seen, I mean, with a CA stomach, you won't find spindle cells. There's a reason that we showed you the spindle cells out here. So you're right, it is likely to be a GIST, a gastrointestinal stromal tumor. Absolutely right. Great. So now the important thing, you would ask your radiologist to actually do something. What is it that you would ask your radiologist to do? Important thing is to measure the distance from there to there, the maximum distance, and compare it out here, because that is very important in your classification and staging of the disease, isn't it? Next, you're going to ask him to whether it's more exophytic or endophytic, because that makes a lot of difference. If it grows into the lumen, suppose you have a GIST, which is, if that's the stomach wall, and it is going inside, that inevitably has a better prognosis than one that is growing outside. The other thing is that find out whether there's a lobulation out there and whether the consistence is not uniform. If it shows you that there are places where, it's sort of necrotic and other places are bright. So in this situation, you've got a bit of a problem in your hand. So that has a worse prognosis. So if I were to tell you what your radiologist would actually, what you would ask from your radiologist, tumors that are larger than 5 centimeters, are lobulated, enhanced heterogeneously, has mesenteric fat infiltration or ulceration, or even regional lymphadenopathy. Now remember that GIST are two variants. Commonly it's spindle cells, sometimes it's epithelioid. The ones that are epithelioid, and particularly ones in children, pediatric GIST, have a tendency for spreading, metastasizing to the lymph node. That is a bit of a problem. And an exophytic growth pattern. So all these on a CT scan tells you that this is more likely to metastasize or recur. Now, what you would ask from your pathologist is that histology, as I said, spindle cells at 70%, epithelioid cells in 20%, often KIT negative, and harbor the latent growth factor derived EGDFRA mutations, and frequently present in the stomach. And sometimes it's mixed. And what you would ask for is immunohistochemistry. And what is the classic immunohistochemistry that we ask for in a GIST?
CD117.
Yes, absolutely right. Anything else?
CD 30. 34.
Okay. What we normally do is KIT mutation, EGDFRA gene mutation, and breast. Also DOG1. It's found in GIST1. That's one that is associated with neurofibromas. PKC theta are two IHC markers that are present irrespective of the KIT EGDRFA mutation status. So that is something that is being taken up in a big way, because you sometimes have KIT mutations in 90%. What happens to the 10%? So this is PKC theta, are two subsets that are always in recently that's coming in a big way, and they are present irrespective of whether they are KIT or a PGDFRA mutation. So remember, KIT, CD117, this is CD117, so right, CD117, or sometimes called CKIT. It's present in 90%, P, G, D, F, R, A in rest. Sometimes you get dog1. You need to mention that because, people talked about dog1 in a big way. Then, unfortunately, what you have is PKC theta. That is, that's 2, 1 and 2, which are present despite, they're present out here and present out here. So that can actually be a marker of the future. Right. So the next issue is, how would you treat this patient? So the patient is going to be treated, depending on the classification. In 2002, Fletcher stratified the risk. Very low risk, smaller than 2 centimeters, less than 5. You're going to ask the pathologist already. I'm very sorry. You're going to ask the number of mitotic figures. And please, sorry, I should have told you that. You're going to ask what are the number of mitotic figures. That's going to be very important, mitotic figures. Per 50 high power fields. So number being X, so you're going to ask the pathologist to report on that. So if the pathologist is good enough to give you that sort of so very low risk, smaller than 2 centimeters, less than 5 per 50 HPF mitotic figures. Low risk 2 to 5 centimeters, less than 5 per 50. Intermediate risk, smaller than 5 centimeters, 6 to 10. 6 to 10 mitotic figures and 50 HPFs, 5 to 10 centimeters are less than 5, high risk interval larger than 5 centimeters, more than 5 per 50, larger than 10 centimeters, any mitotic rate, or any size and any more if you have more than 10 mitotic figures and 50 HPFs, it goes a high risk. But recently what has happened is the DNM classification, related to the anatomical site, because it's very important. There seems to be a difference. You actually can have larger tumors in the stomach and better prognosis, whereas if you have a smaller tumor in the small intestine, so that is very important. So histological type, size of tumor, depth of invasion, and grade, M staging and mitotic index are all being taken. So additional risk factors are related to tumors, presence of KIT mutation site in KIT or PGD-FRA gene, R status and rupture during surgery, whether it's primary or a recurrent tumor. Related to host, I told you about the dog1 being present in neurofibromatosis in type 1, where you have a GIST formation and age of presentation, pediatric GIST inevitably metastasized to lymph nodes. So if R0 surgery is not possible in this lady, these are the ESMO guidelines. You give imatinib for 6 to 12 months. If you can do surgery after that, you go in for surgery. If surgery is not feasible, you go in for follow-up. And what sort of follow-up? Here is where the new thing is coming in. Find out where the type of mutation is. Find out where the mutation is. If you look at the KIT protein, KIT protein is actually a transmembrane protein. So that's the membrane. KIT protein actually exists in 2 forms out here. And when you have imatinib, you have the CKIT sitting out here causing phosphorylation across out here. So in this segment, 11 is somewhere out here, which is the most common, and that is the imatinib. Exon 9 is somewhere out here. So there it is less sensitive to imatinib, and it is actually more sensitive to the second generation sunitinib. So that is something that is going to come in. You guys, we knew nothing about this. You are the chaps who are going to be, going for directive treatment. So that is the new ESMO guidelines. Sensitive mutation, exon 11 mutation, you use imatinib. If it's exon 9, you use imatinib higher dose, 800 milligrams. If there's no response, you switch to sunitinib. Now, I've got to warn you about something. Imatinib being a vascular endothelial growth factor antagonist, you have plenty of patients coming back in with various sort of vascular problems, including venous thrombosis, deep venous thrombosis. So if you can't, if you are using a neoadjuvant where it's not sensitive to sunitinib, you're going for sunitinib and you find out whether there's a partial response or a stable disease. If it is, you continue with that. There's no partial response, no stable disease. This is the newer generation biologic that is used. It's called the regorafenib. If that causes a persistent response, continue. Guys, you need to mute yourself. Mute yourself, please. Yeah, okay, I've done that. So if there's no partial response, no stable disease, then if it's a slow partial slow PD, you continue. If there's a fast PD, you use a TKI re-challenge with imatinib again. So that's the whole spectrum of treatment of a GIST. And how do you assess? You assess by using the RECIST criteria. So complete response is disappearance of all target and non-target lesions without any lesions. Don't use the CHOI. Just remember that there's something called a CHOI. People are using the RECIST 1.1 for any solid tumor. So PR is partial recurrence response, so 30% decrease in the sum of maximum diameters. Stable disease does not meet the criteria for the response. And progressive disease means 20% increase in the size of the maximum diameters of all individual measurable lesions. So unequivocal progression of any non-target lesions or appearance of new lesions. So remember, guys, that this is the best that you can do. So out here, you find that, it's completely disappeared. In that, you have a complete disappearance. In a partial response, there's a 30% decrease down. In a stable disease, it's stable, stays the same. It does not meet the criteria for other. In a progressive disease, you have an increase in 20%. So remember, guys, that is the RECIST criteria and that is sometimes asked. So please remember that. And what you would actually do is remember that for GIST, sometimes you use this called the CHOI classification, but that's used mainly in Japan. And I think what we need to do is just remember that by name. You don't need to remember that. Just remember the RECIST. Okay, guys. So next, osce, and you've got a 38-year-old executive presents with sudden severe abdominal pain radiating from the back. It's 24 hours ago. Patient was found to be febrile and there's interest. The urine color is deep yellow and the stool color was not noticed. Now, there's a history of a long-standing dyspepsia and intolerance to rich food. The patient is para 3+0. The patient has this blood test which shows a hemoglobin of 12 with a total leukocyte count of 24,600. Urine creatinine, everything else is normal, but she has a hopelessly deranged liver function test with a bilirubin of 3.3, alk phos of 689, and a gamma GT of 309, and the ECG is normal because with any upper abdominal pain, you need to ensure that there's no cardiac problem. So that's the ultrasound scan and the MRCP. So I'm going to leave it on for about a minute for you to assess. So a minute starts here.
Sir, what are the questions?
Can I go to the next one?
Yes.
So what is your diagnosis? And discuss two differential diagnoses. How would you classify the disease and how would you treat the condition? And you've got 2 more minutes from here on. And just to make things slightly easy, we'll leave you with that. Right, guys. So what's your answer? What's the diagnosis? Anyone? So if you go back and see that view, showing you the MRCP, and if you notice out here, you've got a fairly large stone out there, and which is compressing the bile duct. The gallbladder is quite distended and obviously infected, otherwise you won't have such a high white cell count. So what is your diagnosis out here? Sorry? So you've got a thing called a Miracci syndrome, isn't it? And these are the types. This is McSherry classification of a type 1 where there's a compression without any fistula formation, and a type 2 where you have a fistula formation. Miracci was described by this gentleman called P.L. Miracci, who was the father of operative cholangiography in 1942. Stone causing obstruction of the common hepatic duct by external compression, and McSherry in 1982 described type 1 as an external compression without fistula, and a type 2 with a fistula. The two differential diagnoses that you must keep in mind is a Klatskin tumor or a carcinoma of the gallbladder, particularly or affecting the neck of the gallbladder. So differential diagnosis has to be a Klatskin and a carcinoma of the gallbladder, which is involving the bile duct. The comprises of 4 components per its syndrome. It has to have a parallel course of a cystic duct to the common duct. Otherwise, it's a bit difficult to get it, because if you have a bile duct like that, and you have a common bile duct which drains low and goes like that, and you have a chance of then having, if it's running parallelly, you have a chance of a stone getting impacted out there at the neck and then gradually, pressing on the bile duct, causing Miracci syndrome. So that is your Miracci syndrome. Mechanical obstruction of the common hepatic duct by the stones or by secondary inflammation and intermittent or constant jaundice and recurrent cholangitis is a feature of Miracci. Right, so, but Sendi's did a modification of the McSherry classification. So type 1 for McSherry was an impression of the CVD without fistula. So 1A is with a cystic duct, 1B is without a cystic duct. Type 2 is 1/3 of the CVD involved. Type 3 is 2/3 of the CVD involved. And type 4 is the entire CVD involved. And type 5 is any one of these with a cholecystoenteric fistula, where you have also a fistula with the duodenum usually, or it could be the colon. It's the other thing that travels across out here, isn't it, guys? So it could be the duodenum as I've shown you in this picture, or it could jolly well be the colon, which is also something else that travels out here. So that is something that you need to remember. That is a type 5 McSherry. Right. So how would you? Yeah, sure. Go ahead.
Sir, I will get 1B. I understand. So 1B about.
Okay, sure. It's a bit of a nitpicking sort of a staging. So essentially, if you have a bile duct and you have a cystic duct and the stone impacting out there, get it? So that makes it a type 1A. Whereas if you have a similar sort of a situation where you have the bile duct and it's almost as if the gallbladder ends out here into that stone, get it? And you can't define a separate cystic duct. That's a type 1B. Okay?
Sir.
Right. So we'll go on with our next line, which was, how would you manage this? If there's an external compression of the bile duct, what you would normally do is you could go in for a laparoscopic or open, do a subtotal cholecystectomy. You have an impression out here because with, either 1A or 1B, and you have the gallbladder out here. So you actually do something, you cut this all across out here. Sorry. So you would actually cut this out here, take the stone out and stitch it up. So that's a subtotal cholecystectomy. If you have a cholecystobillary fistula, which involves less than 50% of the diameter of the CVD involved, one of the treatments suggested is that, it has a fistula tract, and that is the gallbladder out here. So instead of taking it out, what you need to do is to do a cholecystoenteric diversion. You bring up the jejunum and you stitch it up here. Okay, you've taken the stone out. That was the stone that was out there. You remove that stone, and now what you do is you stitch the end of the gallbladder to, or not of the fundus. You don't leave the most of the gallbladder. You remove most of the gallbladder, and you stitch this end to Roux-en-Y loop of jejunum. One of the problems is that you have to have frozen section out there because, there's one disease that is very common with Meritzi associated, that is carcinoma. So you need to be very careful that it's not there. If there's more than 50% of the diameter of the bile duct involved, you would actually end up doing a complete. If the fistula is completely there and that has completely damaged the portion of the bile duct, you remove that portion of the bile duct, you remove the stone, and you remove that portion of the bile duct and that portion of the bile duct, and you then bring up the intestine and do a hepatico-jejunostomy, Roux-en-Y anastomosis. You would prefer to go up slightly higher and do the anastomosis in an area where there's less inflammation around. So subtotal, subtotal, subtotal with a cholecysto, cholecysto enteric anastomosis. And here you do a bilioenteric anastomosis, as I've shown you on the diagrams. Okay, guys, any questions? So we move ahead with the next one.
Sir,
Yeah, sure. Go ahead.
so this cholecystoenteric diversion, what we do, is that a permanent thing or
It's a permanent thing.
temporary?
Very permanent. That's in fact, which is why you need to make sure that you don't have any chances of dysplasia. Even if you have dysplasia, you do not leave that gallbladder in. So it's a must. If you're handling a malignancy, you have to have frozen set.
So then the chances of cholangitis will increase also from the
Why should there be a chance of cholangitis? Usually what happens is you're going to anastomose it, not to the duodenum. Remember, you're doing it to do a jejunum. Get it?
Yes, please.
You're anastomosing that bit end, and because of the inflammation that has normally got, it's probably this too much of inflammation and damage. So the bile actually travels out here into the jejunum, where you've got a ruined Y and you've got a sufficiently long distance away from the DJ flexion.
So what is the interpretation of USG?
Interpretation of USG is that you actually have the USG says that there's dilated intrahepatic bile ducts, dilated common hepatic duct, ending in a large stone. So you see on an ultrasound scan. Let me show you that ultrasound scan. That is, I managed to get it from one of my very old patients. You see that that's the stone. Can you see that stone? That's a huge stone sitting.
The stone is below is there.
Sorry?
Yeah, what is the view? Where is the sticker and where is the CBD?
The CBD is somewhere below out here. You can't see the CBD. In this particular view,
The stone doesn't seem to be within the gallbladder.
it is actually inside the Hartmann's pouch.
It's compressing
We
all
will
the
not get the posterior acoustic shadow.
So that is the, think about it. You have the gallbladder, that's a bile duct, okay? You have the stone sitting out there, a large stone sitting out there, and then you see the gallbladder hanging out like that. So it appears to be outside the gallbladder. It's not actually outside the gallbladder. It is inside the gallbladder, inside the Hartmann's pouch. So you're seeing that end out here. You're seeing that end out here. You're seeing that stone, and you can't see anything down below because that obscures, that shadowing, acoustic shadowing obscures the bile duct.
Okay, thank you.
Okay. Right.
Sir, on MRCP, how do we appreciate it?
If you see the MRCP, it's far better. The MRCP is always far better because you can then see a bit of intrahepatic dilatation out there. Okay? Left duct, right duct, and then you can see that there's a narrowing. The bile duct ends into a narrowing. That's the rest of the bile duct down below. See, and think about it. You said it is seems outside the gallbladder. That's the stone. That is the gallbladder outside. Okay. So it is not really outside. It seems outside because the stone is, impinging on it. So in this particular view, you can see the gallbladder, which is, that part of the gallbladder and that part of the gallbladder probably correlates. Get it? And you can't see anything out here because it is being obscured by the acoustic shadowing. You have an acoustic shadowing going down out here. black. So that is your casting shadowing out here, and probably the bile duct is somewhere out there. Which is why you realize that, this is not a very exact investigation to pick up. It helps because it gives you the impression of there being a large stone at the site of the obstruction. So that is your interpretation of, dilated intrahepatic duct, dilated common hepatic duct, ending in what appears to be a very large stone in at the gallbladder and bile duct junction. Okay.
Thank you, sir.
Right. So next osce, we have a 76-year-old lady presents with pain in the upper right abdomen radiating to the back with obstructive jaundice, pruritus, and non-bilious vomiting. She is found to have icterus, a firm to hard hepatomegaly with an irregular, hard ovoid-shaped upper abdominal lump, which is continuous with the liver and moving with it on respiration. And the CT scan is given out here. So I'm going to ask you, the next question is, what is the likely diagnosis? Can you name a differential diagnosis? And how would you differentiate the two conditions? So give you 3 minutes again. Is that all right? Right, guys. So what's your diagnosis? What's your diagnosis?
Hydrated substance.
Sorry? This is actually, see that is the gallbladder. Okay? I'm just pointing out the gallbladder. Can you see the wall of the gallbladder? That's the mucosa. That's the mucosa. So that is a thickened wall of the gallbladder. Can you see that? It's not very uniform. It's actually pressing on this other structure. And what is this other structure you think it's pressing on? Making it a... What is it? The patient has non-bilious vomiting. So where do you think it's pressing? What is this? Absolutely, very good, excellent. So that's the stomach and that's the duodenum. So you can now see that the duodenum is being pressed on. And you can actually see that there's, in this particular page, there's air in the duodenum and it's not going through. So if you have such an irregular swelling of the wall of the gallbladder, there seems to be not a lot of distinction. There's the interface between the gallbladder and the liver is lost. You see out here, the interface is lost out here. Then you're right in thinking of a carcinoma of the gallbladder. Okay, right? But the thing that you need to differentiate this from is another condition that causes thickening of the wall of the gallbladder, like this. And what is that? What is this condition? Absolutely right. Now the difference is, how would you differentiate it? Is on a CT scan, one of the strongest thing is there's some points, whether in a see, this is a result of why does the gallbladder wall become so thick? Because there's a deposit of cholesterol inside there. So you have cholesterol deposits out there. So in this, you would actually find that you can sometimes see specks of cholesterol deposits. The number two thing is that the mucosa is almost always intact. So you go down, this is a non-contrast, you can see that the aorta isn't filled up out here. The aorta is right out here. The kidneys haven't picked up the dye. Kidneys have picked up the diet. So this is a contrast, this is a non-contrast. Now you see out here, you see these specks out here, there are some calcifications in the wall. There might even be a stone out here. But if you look at the arterial view, usually in a xanthogranulomatosis cholecystitis, you would find a continuous mucosa. Very rarely is the mucosa breached, and you can't see that out here. See? That's not there. Okay. So with this loss of interface, and you can see that there's a complete loss of interface between the liver and the gallbladder. So the chances of this being a xanthogranulomatosis cholecystitis is rather low. Okay. So it's more likely to be a carcinoma of the gallbladder. Yes, you're right. Absolutely right. So the CT, carcinoma involving the duodenum, possible para-aortic and paracaval lymph nodes. Where the paracaval lymph nodes is situated? You can see the small nodes out here. So these are paracaval lymph nodes. Xanthogranulomatosis cholecystitis, as we discussed, and the CT features to differentiate. Right. OSCE 9. And what is it? You got a 32-year-old executive who presents with a severe pain abdomen after an alcoholic binge 8 weeks ago. He had a prolonged treatment at hospital, now presenting with an upper abdominal discomfort, extreme fullness and early satiety, and the CT scan is presented. So what is the diagnosis? What are the differential diagnoses? How would you manage this condition? And for that, I'll give you 2 minutes. So there we go.
Let's go to the next section. Right, guys. So what's your diagnosis? And
And what is the differential diagnosis? How would you manage this condition? What do you think?
Pancreatic cirrhosis.
Yes, pancreatic cirrhosis is absolutely right. And what are your differential diagnoses? I'd like you to give me two differential diagnoses. It could be the other, walled-off pancreatic necrosis, okay, in which case you would have had irregular walls, not a uniform thing. You might have had heterogeneous insides, okay? So that would have been a walled-off pancreatic necrosis. The other thing this could have been is a cystic tumor of the pancreas. So how would you manage this condition?
Cystogastrostomy.
Okay, yes, but when would you do a cystogastrostomy and when not? So initially, conservative treatment for the first 6 weeks, particularly if it's less than 6 centimeters, the rule of 6. If it's less than 6 and you treat for 6 weeks, conservative sometimes they say. If they don't, then you need to do an internal dependent drainage, either by endoscopy or surgery. You're absolutely right, but you need to do a biopsy of the wall to exclude a cystic neoplasm. So ideally, if you have a lesion in the lesser sac, just up to the lesser sac, so which means supracolic, that's the colon, and you have a cirrhosis which is stuck on top and it's stuck to the stomach as thing has settled down, you can try and put in a stent into the distal part of the pancreatic. Not a very easy thing, and sometimes lands up with endoscopic ERCP induced pancreatitis. So you have to be very careful. If, however, nothing can be done, it's best not to do it to the duodenum. And if you have to go in for a surgical procedure, it is supposedly much better to bring in a jejunum and stitch it out here, do a pancreatic or a cystojejunostomy to the lesion of the head of the pancreas. The lesion of the head of the pancreas is one of the worst places to have a cyst, honestly. And you need to take a biopsy because you need to exclude a cystic neoplasm. It's there, it's been present. And drain where, as we've just discussed, dependent drainage, stomach if it's supracolic, if it's intracolic, jejunum. If it's in the head of the duodenum, then you've got a bit of a problem on your hand. It's best to do it endoscopically if you have the technique. If not, then you think of doing a pancreatic or a cystojejunostomy to the head of the pancreas. Okay, so I'm going to rush you through because I've got a few more osce. So number 10. So what are the surgical cause of intracranial hemorrhage? What is the normal intracranial pressure? How is intracranial hemorrhage classified? What is the cerebral perfusion pressure and the physiologic changes affected? what is the Monroe-Kelly doctrine and describe the formation and flow of CSF fluid. So short answers, so I'm going to give you a minute. This time starts now. Right, guys. So short answers, surgical cause of intracranial hemorrhage, extradural, can be subdural, subarachnoid, contusions, diffuse axonal injury. So how is it classified? Sorry to rush you through. The normal intracranial pressure ranges from 5 to 15 millimeter mercury. How is intracranial hemorrhage classified based on the etiopathogenesis and the parenchymatous intracranial hemorrhage? Rapid onset may be differentiated, because it might be in the cerebellum or it might be in the cerebrum. Vascular intracranial hemorrhage, medium onset, can be global, all around. CSF obstruction, rapid onset, can be differentiated, can be, because depending on where the CSF obstruction is, can be at the ventricles, can be lower down if it's right in the lower part, and we'll address that. CSF absorption, medium onset, if it's obviously CSF absorption, it has to be global. And idiopathic intracranial hemorrhage, very slow onset, and it is high, very high, because it's slow onset. The brain has a chance of getting used to a high presence of long-standing intracranial hemorrhage, where over a period of time, so the brain, sometimes the pressures are very high. Right. So what is the cerebral perfusion? What physiological change is affected? Perfusion pressure is equal to mean arterial pressure minus the intracranial pressure. So cerebral perfusion pressure is used as a MAP minus ICP, and MAP is 1/3 of pulse pressure plus diastolic pressure is mean arterial pressure. What is the Monroe-Kelly doctrine? You know that the intracranial pressure is a balance between volume of blood, volume of brain, and the volume of CSF in the skull. So what is the flow of CSF? I'm sure you all know this, so I'm going to rush it through. Lateral ventricles where it forms, interventricular foramen of Monroe, folds down into the third intestine from there, third ventricle from there. That's the structure from which it comes in. From the third ventricle, through the cerebral aqueduct of Sylvius, goes into the fourth ventricle, and from the fourth ventricle, the central canal of spinal cord of Magendie and Luschka, and goes up into this subarachnoid space around the brain and around the spinal cord, and one replacement time is usually 8 hours. So, sometimes they ask about the function. So if they ask about the function, you can talk about nutrition, electrolytes, but please don't forget protection acts as a sort of a barrier. Okay. So next one, yeah, go ahead. Yeah, Sandy.
Answer for first question, the surgical cause of intracranial hemorrhage.
That's it.
So what was the answer?
Extradural, subdural, subarachnoid, contusions, and diffuse axonal injury.
So this is surgical causes of death.
Yeah. Surgical, actually, traditionally, contusions and diffuse axonal shouldn't be ideally surgical causes. So you're all right in talking about the first three. Absolutely right. Okay. Right. So we go to the OSCE 11. 48-year-old executive, heavy smoker and social drinker comes in with this endoscopy report. What is this condition? What are the types? How would you manage this condition? Endoscopic biopsy reveal areas of high-grade dysplasia. How would you manage? So again, for a minute, guys, because we really have to finish quite a bit. So give you a minute for these. These are short answers. Right, guys, so you know what it is. Anyone? Yep, absolutely right. So Barrett's esophagus types are long segment Barrett's esophagus beds, bigger than 3 centimeters, longer duration of reflux syndrome, reduced lower esophageal sphincter pressure, 24 hours pH positive, longer duration, and a short segment Barrett's esophagus, which is less than 3 centimeters. So 3 centimeters is the measurement that you need to remember. Have a shorter duration, normal, often a normal lower esophageal sphincter pressures, often. It's not always. 24 hours pH positive for a shorter duration. So the treatment is GRD, treatment for GRD, stop smoking alcohol, hot and spicy food. PPIs are used, but there's no definite evidence that it causes regression. What actually improves it is all that environmental, cut down on environmental problems of smoking, because nicotine in any form reduces the low esophageal sphincter pressure. Surveillance is something that you need to do with a Barrett's because it is a pre-malignant condition, UGI endoscopy, and 4-quadrant biopsy from every 2 centimeters of the disease segment annually. And that's the ACOG suggestion. 3 early if no dysplasia after 2 years. If it's a high-grade dysplasia, recheck biopsy with somebody who's a dedicated pathologist. Because if you have a high-grade dysplasia, that is definitely a pre-malignant condition. So endoscopic, you do an endoscopy, you reconfirm the biopsy, you do an endoscopic ultrasound to assess for any invasive component. If there's no invasive component, you can, there's an option for continuing surveillance endoscopy with intensive biopsy every 3 months. But most would actually go in for some sort of an endoscopic ablation if there's a high-grade dysplasia and no evidence of invasion. Would either go in for radiofrequency, could even do an endoscopic mucosal resection. Some people would do an APC, some people might do a cryo, but some sort of an ablation might be carried out. If there's invasion presence, then unfortunately you have to go in for. So short answers for directed towards your OSCEs.
Sir, what are the features on endoscopy?
Sorry?
What are the features on endoscopy?
You find, what you actually find is that there's an upward progression of the GE junction. So that is a classic esophageal mucosa. That is the stomach mucosa. It should have been dead at the GE junction. It has migrated above. And then particularly, and the important thing out here is to use a specific type of endoscopy called NBI, narrowband imaging, to see the vascularity. If you find regular vascular structures, that's absolutely fine. The moment you find irregular vascularity, that is the area that is likely to have dysplasia, and that is the area that you would target for an endoscopic biopsy. And if that shows, you take a ideal dictat is that every 2 centimeters you take a biopsy and take it from all the areas, because this is something, dysplasia can be at one point and not the other. So you do a geographical biopsy, and that's the classic description of a geographical biopsy. You do a geographical biopsy, if there's high-grade dysplasia, then you have to do something about that. So, okay. So what you need to do is biopsy from every 2 centimeters of the disease segment annually. Every year you've got to do that. If there's no dysplasia after 2 years, then you can do it 3 years. Get it?
Thank you, sir.
Okay, right. Osce 12. A drunk football fan is brought into an emergency with this drunk being kicked in the right loin during a fight in a bar. He is incoherent and shouting. His pulse is 128 per minute, but his blood pressure is 99/60. He has a bruising over the right loin. Routine tests have revealed that he has microscopic hematuria. What would you suspect? How would you grade the condition? How would you manage the patient? Again, for a minute. There's a short answer, so just for a minute, and then we'll discuss. Okay, so what would you suspect?
Traumatic kidney injury.
Yeah, absolutely. And you know the AAST classification. So there we are. You resuscitate the patient. Post-resuscitation, you do a CCT in 4 phases. You do a pre-contrast, you do an arterial phase, venous phase, and a collecting system phase. And the AAST classification is a great one is contusion and non-expanding subcapsular hematoma without laceration. So you don't have any laceration. So that's the important thing that you need to remember is that if you have the kidney, that's not the right kidney, that's the left kidney. So we need to draw the right kidney, and the right kidney is that. And you have a non-expanding subcapsular hematoma without any laceration inside. So that's the capsule which has been lifted up. So that's a grade 1. Grade 2 is a non-expanding perianal hematoma. And now with the hematoma, you can have a cortical laceration of up to a centimeter. So that's 1 centimeter. So that is grade 2. Grade 3, you have a cortical laceration, which is more than 1 centimeter, but there's no extravasation. Don't forget that what you have out here are the collecting system. So that hasn't breached the collecting system. So there's no extravasation. Grade 4 is laceration breaching the corticomedullary junction. So you have this being breached. So the moment that is breached, you have a chance of urine spending outside. So you might have extravasation. So you can have vascular segmental renal artery or venous injury with a non-expanding hematoma or partial vessel laceration or vessel thrombosis. So You need to remember that this is now that you have a vascular injury. Grade 5 is a laceration and a kidney with vascular renal or pedicle injury or even avulsion. So actually what has happened is there's been a lot of change in the type of management recently. So grade 1 non-operative treatment, active monitoring, active interventions like angioembolization or even ureteric stenting, both in grade 1 and grade 2. Grade 3 is a non-operative treatment. It used to be operative for us, but now because with the advent of interventional radiology, can go in for a non-operative treatment with active monitoring, interventions like angioembolization or ureteric stenting. You might have hemodynamic instability. If you do, then you go in for an aspiration. So that basic thing is still the same. If you need more than 2 units of blood, if you're needing platelets to his or her hemoglobin, then you have a hemodynamic instability on your hands, and then don't go in for angioembolization or ureteric stenting. You need to then cut your losses, go in and take that kidney out. Grade 4 is a non-operative treatment. Nowadays, surprisingly, again, active monitoring. You need a very aggressive monitoring. Interventions like angioembolization or ureteric stenting. Same thing. If you have a hemodynamic instability, you go in for a next grade. Grade 5, ideally going for a nephrectomy, and the predictors are with a motor vehicle injury. The injury is far more severe. If you have somebody whose age is above 55 years and the need for repeated blood and platelet transfusion, then you've got an indication for a nephrectomy on your hand. So guys, just remember that. Okay, right. So right now, I know you chaps have been at it for very long. We've got 13, 14 and 15. Shall we finish it? What do you think?
Yes, sir. Yes.
Okay. So if you're all right, I'm all right. So 13 is classified thoracic aortic dissection. How would you investigate a patient with a suspected thoracic aortic dissection and outline the treatment of this condition? So for a minute, okay? Okay, guys, so what are the classifications? The first way of classifying this is time to presentation. Can be acute if it's less than 14 days, chronic if it's longer than 14 days. You have the DeBakey. Michael DeBakey, Houston Heart Center, was the king of them all, the father of vascular surgery. So DeBakey type 1, where you have an ascending aorta, where you have involvement of the ascending aorta, and hang on, let me just get that color. Yeah. So basically, if you had an involvement of the ascending aorta, the arch and down below, you had a classification. A was when it was above the diaphragm. B was when it reached below the diaphragm. Okay. So remember that was the classification that Michael DeBakey gave. Michael DeBakey gave a type 2 where it was involving only the ascending aorta. DeBakey type 3 was the descending aorta up to the left subclavian. So that was the limit. So if the dissection extending up to here, not beyond. So up till this left subclavian, it was a type 3. And again, if it was above the diaphragm, type A, below the diaphragm, type B. So type 1 was all involvement, type A above or type B below. Type 2 was only the ascending. Type 3 was descending up to the subclavian, not crossing the subclavian, again type A or type B. So that was the DeBakey. He had a Stanford classification as well, and the Stanford classification was as follows. You had a Stanford type A, where you had the ascending aorta plus or minus the arch. So, and Stanford type B was a descending thoracic aorta distal to the left subclavian. So again, same. A is supra, B was infradiaphragmatic. So that was the classification, Stanford classification. So essentially you had these classifications, Stein, DeBakey, and Stanford. But you also had recently the classification which came from the Task Force on Aortic Dissection classification of the European Society of Cardiology, where last one was a classic aortic dissection where the intimal, let me clear that right, where you had the intimal flap creating the classic, the classic thing, you had the intimal flap being raised and the intimal flap being raised, so you had a false lumen and a true lumen. Okay, so true and a false lumen. In type 2, you had an intramural hematoma, with hemorrhage into the lumen. Okay, so intramural hematoma was type 2. Type 3 was an eccentric bulge at the tear site. So you had a bulge, so this actually moved it out. So you had a bulge at the tear site without a hematoma. So it was a bulging without a formal hematoma. Class 4 was a penetrating aortic ulcer, usually subadventitial, without a hematoma. So you had just an ulcer that extended up to the adventitia with or without a hematoma. So you could have a hematoma present out here, or you may not. And class 5 was an iatrogenic or traumatic aortic dissection. I personally find that this task force was a bit difficult to understand. So you're all right in remembering the first 3. Time to presentation, less than 14, more than 14. DeBakey, type 1, type 2, type 3. And Stanford, type A and type E. So just remember that the task force, I personally found that this was a very difficult one to remember, but there we are. So, right. So how would you manage? Medical stabilization of the dissection in ICU or HU with an arterial line to monitor the blood pressure. The target mean arterial pressure is 70 millimeter mercury using either intravenous GTN or sodium nitroprusside if needed. It had to desperately get the blood pressure down. The pulse is reduced to 60 to 70 per minute with using beta blockade, either with metoprolol or esmolol. Monitoring the coronary, cerebral, visceral, and lower extremity perfusion must. Do not forget that, because the dissection actually sometimes block the blood supply to all these structures. Imaging was with a CT or an MR, full angiography. What you mean by full angiography, don't leave out the femorals. So sometimes these dissections landed up extending into the external iliacs also. So, and also enriched with subtraction angiography and very important, an echocardiography, because you need to make sure that your heart was working all right and there wasn't dissection extending upwards. So the goals of surgery, closure of the entering tear and repressurize the false lumen and induce thrombosis. So basically, if you can well think that you had a dissection out here and that was filled up by blood. That was a false lumen filled up by blood. What you needed to do is that tear needed to be repaired out here. Now the problem of repairing that tear is one. I need to wipe that off. The problem of repairing that tear was you had a flap out here and that was the gap. Now, when you put in stitches, one of the most important thing in vascular surgery is if you put in a stitch from here and came out there, that has a tendency to lift up the flap. So it has a tendency for lifting up the flap. So you recreate that dissection. So the principle was always that if you had a leak and a dissection, the stitching should always go the other way around, which meant that you could go in from this end, take a bite through the mural, through the muscularity, and come out this way. So it is always, remember, when the flow is this way, your stitches always go in and come out this way. Even if you're doing an anastomosis, end-to-end anastomosis, always remember that. So as a result of this, when you put in a bite out here, that induces thrombosis and it settles down. Now that's perfectly all right, provided you don't have a very important structure somewhere leading out from there, where the blood supply is compromised. If that is compromised, then you also need to address that. Previously, there was something called a re-window operation, but that was not very good, because if you had a aneurysm like that, a dissecting aneurysm like that, what you tended to do is make a hole out here so that blood could actually flow in and flow out. That was a terrible operation, but it's been given up for better management. So preservation and revascularization of the end organs affected to prevent or reverse obstructive perforation. That's just what I was telling you about. Okay. Right. 14. A 63-year-old patient was brought in with features of intestinal obstruction. Resuscitation has started and the patient undergoes an abdominal X-ray, both erect and supine. What is being shown is in the X-ray, and what is the features eponymously called. So there are two parts to this slide. I'm going to leave you with just about 20 seconds for this, and then we'll go to the next. So before we go to the next, what is being shown on this X-ray?
Dilated bowel loops, step ladder.
Right. Okay. So which part of the bowel? But which part of the bowel? Yes.
These are ileum, so these are just characterless. So it leads.
This is not characterless. Hang on. This is not characterless. This is
okay. That is just
classic concertina effect. You're absolutely right. So step ladder pattern, multiple air fluid levels with a step ladder pattern. Let me choose this color that doesn't show up very well. The step ladder pattern. Okay. You have dilated loops of intestine, which shows a concertina effect. So why is it called concertina effect? Well, how does it form a concertina? It forms a concertina because of one structure inside. And what is that structure inside? Valvulae conniventis, which straddle the jejunum all the way across. So that is the characteristic of jejunum. If you have a dilated segment without anything, that's the ileum. And if you have hostrations where the edges don't match with each other, and you have incomplete segmentations. That is the colon, isn't it, guys? So eponymously, it's known as you quite rightly said, step ladder pattern, air fluid level, and concertina. I hope you know what a concertina is. Concertina is a musical instrument that used to be played, and the closest thing we have in India to that is something called the harmonium, isn't it? The valves of a harmonium. Okay, which sort of allows air to move in and out. So that's the concertina. So in Europe, there used to be people who play this music on the road, and that was called the concertina. Right. So now, had an exploratory laparotomy after resuscitation, and the following pathology is found. What is being shown in the specimen? Describe the different parts of the condition with an appropriately labeled diagram. Sometimes you're asked to do that. How would you treat this condition, and what is the commonest group of patients involved? So I don't think you need a lot of time for this, so may as well go ahead and discuss. We've been at it from 5 o'clock, so I've got to be kind. Yeah. So what is this? What is being shown? Interception. Very good, interception. So absolutely right. So this is these are concertina. We've just finished that. Absolutely fine. So we've got, this is called an interception, as you're quite right. And what are the different parts? The one that goes in is the interseptum. The one receiving it is the recipients, so intercipients. So that's how I've always remember that. One that receives as recipients and the one that goes in the septum. That is the apex and that is the neck. So how's the condition diagnosed? Usually on a straight abdominal clinical and presentation and finding. So what is a normal finding of let's say you have an IUIL or a jejunal as this, in this patient you have a jejunal interception. So what do you find on an abdominal examination? You find distension of the abdomen, isn't it? You find distension of the abdomen. But the commonest group that is often involved are young male, the male child. And there you have, sometimes if you're careful, you find a sausage-shaped lump. Why do you find a sausage-shaped lump? Why a sausage-shaped lump? If you think about the anatomy and you think about the blood supply to the intestine, it comes from there, isn't it? So now, if you have an intestine which is going to intercept, the curvature, it forms a curvature, and the curvature has to be with a curve, the concavity towards the center of the abdomen, towards the umbilicus, and the convexity to the outside. So it forms a sausage-shaped lump because of the vascularity. That's what it forms. So that's why you have a sausage-shaped lump in an interception. And the commonest group is a young male. Why is that? Why is it that males, young kids, males, at the time of weaning, at the time of weaning, they have interception? Why is that?
Inflammation of hair patches.
Sorry, yeah, absolutely. Very good. So you have inflammation of pairs, patches of the ileum, which are most prominent in the ileum, isn't it? So it forms a nidus. You have to have one swelling. So that acts as a food particle and gets pushed on. Okay, absolutely right. Well done. So inflammation of the pars. Why males? At the time of weaning. Please remember that the first part of the human body to have the maximum amount of sensation is the tongue. And you normally notice that all children put things into their mouth. That's a way of feeling. Your fingers, their fingers haven't got the amount of sensation that the tongue has. So the tongue is the first part. And boys are normally more mobile than girls. Girls are far more dainty and, sorry guys who are there, but male children move around a lot more, picking up things from the floor and putting it in their mouth to just to have a feel, because the tongue acts as the fingers. So that is how you swallow. They swallow a lot of infective material that causes inflammation in the Peyer's patches, causes a rise, causes a polypoid swelling in the intestine, and that gets pushed on. Okay, right. So absolutely right. Now we need to go on with this. Investigations are a straight extra abdomen. In a young child, you might even get away with an ultrasound scan. Sometimes you need a barium enema. The reason for putting in a barium enema, you won't have a barium enema nowadays, but in the older days, we used the barium enema. You will use the barium enema to sometimes push the interception back. So when you had a barium enema, you had something like a claw lesion. So that is a classic claw lesion. This is a ileocholic interception, and you can well imagine that sometimes you try to use a force of putting in an enema to try and push it back. It's been given up largely nowadays. You very rarely find, so I had to surf the net and find a picture for you people. But what you would find is nowadays you would, even with a non-contrast CT scan, you would find something called a target lesion. And this is the classic target lesion. You can see that that's a target has a center surrounded by another. So, because you can see out here that you have a lumen, one part of the intestine getting into the other. So that is the inside lumen, and that is the outside wall. So that is the interstitial septum, and that is the CPNs. Okay, so that's a classic target sign that you can nowadays see. And the treatment is that you, after exploration, you will try and reduce it. And the way to reduce it is to actually push it down, not pull it. The moment you pull it, sometimes it rips and tears. But you would inevitably do a resection anastomosis because, this gentleman actually had a gist of the small intestine. So, fortunate enough that he presented very early, and we were able to resect. It was a very small gist with less than 5/50 high power field. So resuscitation, diagnosis, conservative or surgery, sometimes in the younger age, at the age of weaning, you might even do a conservative if patient settles down, because Peyer's patches are, temporary things. And, they settle down. But in an adult, this gentleman was fairly middle-aged, so we had to do a resection. So the commonest group of patient is, as we said, youngsters. So 14. So how does the body react to surgical insult? What is the metabolic response to trauma? How are the following metabolites in trauma? Lipids, carbohydrates, and protein. So you can go ahead with the answers if it's all right with you. Is it all right with you? Or do you want to have a...
Yes, sir.
Go ahead with the answers?
Yes.
Okay. Right. So how does the body react to surgical insult? Sympathetic nervous system overdrive. Remember that you can actually write a book on this answer. So you have to do a point form. You have to get away. You have to be able to answer enough to get those 8 marks. So number 1, sympathetic nervous system overdrive, increased cardiac output and glycolysis. 2, endocrine response, ACTH, glucocorticoids. Acute phase response, cytokines, kinins, interleukins, TNF-alpha, interference, clotting cascade, elevated acute phase protein, and down-regulation of albumin and transferrin production. Vascular and endothelial response, lower tone and coagulation, platelet and leukocyte binding. What is the metabolic response to trauma? Classic phase, in phase, reduced energy expenditure, reduced metabolic rate. Flow phase, dramatic increase in metabolic rate. Catabolism often many days with negative nitrogen balance and impaired glucose tolerance. Anabolic phase, replacement of fat and glycogen reserves, and protein is synthesized. So lipid metabolism, lipids major source of energy after trauma, lipolysis stimulated by sympathetic overdrive, by all the anti-insulin hormones, ACTH, cortisol, glucagon, decreased insulin levels in effect. Ketones released, except there are some obligatory aerobes. The one that has to use glucose is brain and RBC and WBC. So all other structures in the body can use ketones. FFA and glycerol undergo gluconeogenesis in the liver to provide enough food for the brain and the RBC and the WBC. Carbohydrate metabolism, high glucagon and low insulin corticosteroid induced insulin effect. Glycogen stores mobilized to create a temporary hypoglycemia. Glycolysis for energy for CNS, leukocytes and RBCs, which have insulin independent mechanism. The glycogen stores deplete in 24 hours, and then you need gluconeogenesis from lipid breakdown and amino acid after protein breakdown. Protein metabolism, skeletal muscle releases amino acid. It's an anti-insulin effect. Requirement peaks after about 7 days, often prolonged, proportional to the grade of injury. The only source of exogenous protein is not provided by. Remember that can cause endothelial dysfunction and intestinal mucosal atrophy and loss of a barrier to bacterial translocation. If the loss is more than 40%, almost inevitably fatal. Remember that, guys. So guys, take a deep breath. It's just another exam. What we'll do is we'll take you through during our classes through the part of general surgery. It's been well thought out, the classes, so that, but for this particular session, for the OSCE session, we had to do a short presentation just to explain to you, give you the flavor of what OSCE is all about. As I said, I mean, that particular last question, you can actually write a 10 chapter book, 10 volume book on that. So you need to have enough and write enough to be able to grab that 8 marks from your examiners and get through. Okay, guys, any further questions? So if you don't have any further questions, you've been at it from 5. So I think 4.5 hours is very long. So take a deep breath, stay safe. I know most of you working in COVID wards, so look after yourselves. Right. So if you don't have any other questions, see you for the usual classes. And wherever you are, as I said, stay safe. So I'm going to come in with a topic which some of you might find slightly difficult, and sometimes it can be extremely boring. So we are going to discuss about that, because if your exams are around the corner,
Hello.
Hello.
Yes, Lajit.
Yes, sir.
Just a minute. Lajit, I will start when people are ready. Hello. Hello, can I start now? Hello.
Yes, sir.
Can I start now? Yes, I think we'll. No. A very good evening, everyone. We start with the last set of OSCEs, and believe me, my set is easy and it will be done quickly. So, can we start now? Hello.
Yes, sir. We can start.
Right, you can start.
Yes, sir.
The first question, again, all of them are for 5 marks. The first question shows you about a muscle that has been highlighted by red. And the first question is identify the muscle. Number 2 is what is the nerve supply of this muscle? Number 3 is for 2 marks, name an operation where this nerve can be injured. So if the muscle is very clear in front of you, so what is the name of the muscle, what is the nerve supply, and what is the operation that it can be injured? After you have completed, please say yes, and then we proceed to the next slide. Hello? Can I proceed?
Yes, sir.
A 52-year-old gentleman presented with a slow-growing soft swelling as shown in the picture. The swelling is soft with no node enlargement. What is the probable diagnosis? You have been shown 3 pictures. What is the investigation of choice for this patient? And what is the management that is planned? If you have completed, can I move? Hello?
Yes.
This is for 1, this is for 2, this is for 2 marks, right? Now, interesting picture of an ulcer which has progressed to develop into a sinus. So this is the sinus and this is the ulcer. Beautiful picture. So the only question to you is that describe the ulcer. I don't need the diagnosis. I need you to describe the ulcer for me. That means an ulcer is usually 5 points. And the examiner is asking you for an OSCE that what is your description of the ulcer. I think you can see the picture very closely in your screens. Okay, can you move on now? Okay, can you move on now?
Yes, sir.
Another picture of an ulcer. I think it is better to show you the picture of an ulcer. Describe the clinical findings for 4 marks and diagnosis 1 mark. The last question was only a description. This question talks about both description as well as diagnosis. Okay. Can I move on to the next one? Hello.
Yes, sir.
Now, this is an interesting question. This is a 57-year-old lady presenting with a 5 centimeter lump in the breast. I think you can see the outline of the lump in the mammogram. The question is not about, the question is about describe what are the mammographic features. Both of them are the same view, the right mediolateral oblique. And what is important is that the side view on this side is something called as a spot magnification. So this is something that has been magnified for you. That means this area has been magnified for you to look into. So describe the findings. Okay, please convey me when you are complete. Hello.
Yes, sir.
Done? Good. Now, this is an interesting one. This is an imaging modality that is used in the breast. Remember that I have shown you 3 pictures. Now, and what is the specific score that is used in this imaging? So, if you are acquainted with this type of imaging, definitely in this modern day of osce, this has been a new generation of questions. Complete. Complete. Hello.
Yes, sir.
Now, regarding breast again, this is a picture that is used to do something of a scoring in the immunohistochemistry of a breast cancer. What is the score that is used? This is a very simple question. Questions are very simple today. Done? Complete?
Yes, sir.
Good. This is a simple one. Let's say the next one. Now again, this is a simple picture. This patient presents with a neck swelling and you are being shown and CT scan image. The arrow points to the neck swelling. The question is not what is the neck swelling. The question is what are the complications that this neck swelling can produce. Complete?
Yes, sir.
Now, you are being shown a triangle which has been the location of an endocrine tumor. Now, what is endocrine tumor that is localized to this area that has been shown? And what are the common clinical presentations of this endocrine tumor? That means if you're thinking which area is it, then I will shade this area for you. This is the area. Okay. Right. What are the common clinical presentation? This is for 4 and this is for 1. Hello, complete? Okay. Hello. Right? Hello.
Yes, sir.
Right. Chalo. These are very simple set today. What is the eponymous I sign? And what are the muscles involved? Can I move to the next one?
Yes, sir.
Right. Now, you are being shown a bag of whole blood. The questions are three. What is the shelf life of this bag? Sorry, just a minute. Right. What is the shelf life? What is the anticoagulant that has been used? And what is the specific indication of infusion or transfusion of this bag? Shelf life, anticoagulant, and the specific indication of this one. Complete. Can I move to the next one?
Yes, sir.
Simply see the tracing. I will enlarge the picture for you. What is this tracing called as? And if the patient has an obstructive jaundice, what will be the abnormality? Complete? Complete? Can I move to the next one? Hello? Hello? Can I move to the next one?
Yes, sir.
Question 13. Identify the device. Complete. Yes, sir. Interesting one. Observe the picture closely. What is this bedside surgical procedure? What is the indication? Complete. Complete. Yes, I think we can. The last question is, what is the fluid requirement in 24 hours for a 50 kg male with 50% burn and the patient is aged 50 years? Use the modified Parkland formula.
Question number 15.
This is the question number 15, the last question. Complete. I think we'll start now. Hello. Hello. Complete. Yes, right? Right now. Good. Now, as you have completed this one, really nice. So what we'll try to do is that, so take a gulp of water if you have. So what we'll start to do is that, we'll go from the beginning. This was an easy set, I think, much easier than, hello? This was, I felt, as a much easier set. Okay. So whenever we start with it, ready? Chalo, let us start then. So what is the muscle that you have identified? Trapezius. Very good. So the muscle here is technically, as you can see, the shape looks like a trapezoid. And hence the muscle is called as a trapezius. Very simple question. I thought that this was the simple question to start the day with. So this is a simple question to start the day. Okay, so if you have this simple question to start the day, then what is important is, what is the nerve supply of the trapezius? Very good. So that is a spinal accessory. Name an operation where it can be injured.
Modified radical neck dissection.
Modified radical neck dissection. Again. Remember that the reason about giving this simple
Radical.
Okay, no, it can be injured. It can be injured. In a radical neck dissection, it is sacrificed. So, okay, you can use these terms. The simple thing is that starting from a posterior triangle lymph node biopsy. So, if you are thinking about an injury, it can be a posterior triangle lymph node biopsy in a level 5. It is sacrificed as a part of the procedure in a radical neck dissection. And you can mention that. If you have mentioned neck dissection, radical neck dissection, modified radical neck dissection, well, then you have to mention what is that. So please remember that. The modified radical neck dissection, okay, so type 1, type 2, type 3 are the 3 important things to keep in mind, right? Chalo. Now, what is a type 1 MRND? What is a type 1? Hello? Come on guys, quickly, what is a type 1 MRND? Which is preserved in a type 1 MRND?
Spinal accessories.
Very good. So the spinal accessory is the only thing that is preserved. What is a type 2 MRND? Both the spinal accessory and the internal jugular vein is preserved. In a type 3 spinal accessory, internal jugular vein and the sternocleidomastoid is preserved. So this is what you are required to know. Okay, right. So now this completes the first part. Simple question to start the day with. This question was also simple, I think. Okay, now to start with. What is the probable diagnosis?
Lymphoma, sir.
Well. The reason about showing you the pictures is slow growing soft swelling. Why should a lymphoma be soft? And you can see the patient is an elderly male. Swelling is bilaterally symmetrical. So what do you think can be a slow growing soft tissue swelling in this area with no lymph node? Do you think it is a territory of the submandibular gland, doctor? Very good. This is a classical picture of a Warthin's tumor. So please understand that this is a classical presentation of a Warthin's tumor of the parotid gland. Warthin's tumor, please remember, is a bilateral tumor in about 10 to 15% of the cases. Is usually seen in elderly, is associated with smoking. The smoking is not the etiology. People say that Warthin's is not at all a malignancy, but is said to be a hamartomatous lesion, where there is, so it is also called as an adenolymphoma. This is the other name for the Warthin's tumor. It is an adenolymphoma. So that you can understand that this is an inclusion of the lymphatic sac in the lymph node. And these are technically the parotid nodes. Now the parotid nodes are said to contain lymphatic sacs in between. That means they are known to contain the lymphatic sacs which contain the fluid, and this enlarges, coalesces together, and after it coalesces together, it forms a collection of fluid. So please remember this part. Now, if you have understood up till this part, please remember that this is just an adenolymphoma. It does not turn into a malignancy, number 1. Number 2, it can be bilaterally, as it produces a cosmetic defect, mild pain maybe. The treatment of choice will be a superficial parotidiectomy? This is a very standard question. What is the investigation of choice? And fine needle aspiration cytology should be the investigation of choice to diagnose this condition. Now, an MRI is not usually required until and unless you think of this to be a differential diagnosis with an acynic or an acynar cystic. So this is not a very common one. Acynar cystics are usually unilateral or associated with a nerve palsy. This is bilateral, elderly, slow-growing tumor. So what is the probable diagnosis? A Warthin's tumor or an adenolymphoma. Investigation of choice should be an FNAC and treatment should be a bilateral or a parotidiectomy, at least, or a superficial parotidiectomy. Now, this one. It's a very simple question. What is the etiology of this disease? Simple question. What is the etiology that you think? Excellent. Very good. So if it is this, then let us talk about the ulcer. What is the site of the ulcer? Interior triangle. Now, what is the area or the picture of the surrounding skin? Hello? What is the status of the surrounding skin? So the surrounding skin, yes, technically you may say majority of the surrounding skin is normal except for that around the ulcer, which has a little amount of hyperemia, probably suggesting of an inflammatory pathology. Now, the next one is, what about the margins? What about the margins? Now, which part is the margin? If you enlarge the picture, I think you can see the margin very, 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 very clearly.
So well defined, sir.
A very well defined margin. So please understand, this is the reason I gave this simple question, because there is still a lot of doubt around students around which one is the margin. So this margin is technically a well defined margin. Now, what is the floor that you see? The floor is filled up with a slough. So in between the margin and the floor, obviously, the edge is looking somewhat like this, and hence you cannot see the edge.
Punched out.
No, it is not punched out. It is an undermined or an inverted edge. Or it is not punched out edge, is something that will look like this. Is classical for a neuropathic ulcer, will not be seen in the neck. Remember that this one has an inverted margin. So this is very characteristic. Just imagine that this had a lymph node. Initially it was technically a lymph node, and then what happened was the lymph node underwent a caseous necrosis, as you can see, and everything came out. So won't the margin be an inverted like this that I have shown? So the margins are not inverted, edges are inverted, floor is filled up with slough. What about the base? What about the base?
Not seen.
The base is not seen, I know that, but if you are to describe for an OSCE, what will you write? Sir, the base will have a minimal induration, because remember this is an inflammatory pathology, but the base is, I am interested to know that if there is an underlying lymph nodes in the neck, the ulcer is probably fixed with the underlying nodes. So when you are palpating for the base, and so equally for the sinus, that means that if this is the finger that you are using to palpate for the sinus also, remember the underlying structure is the node in the neck. So maybe that the sinus may have been fixed up with the underlying node. Okay? Chalo. So this is all about the things which progress to a sinus. What stage of the disease will you call this to be? If this is a tuberculosis of the neck node, what stage will you call this to be? Hello?
Stage 4.
Stage 4. That means let us have a quick recon. What is stage 1? Stage 1 is lymphadenitis. What is stage 2?
Periadenate.
Very good. That means in a common word, It is also called as
Matting.
also matting. A nice one. Stage 3 is a caseous necrosis. Stage 4 collar stud abscess. And stage 5 is technically something that you have been shown in the picture, is a rupture that leads on to development of an ulcer, and that leads on to development later of a sinus. So this is the classical 5 stages through which a tuberculosis of the neck node will progress. Okay, so please remember that. So this completes the picture. Right. Now, the next one is again for an ulcer. Now, describe the clinical findings. That means, can you describe what is the site of the ulcer? What is the site of the ulcer?
Below the lateral canthus.
Very good. It is in the face, particularly. Can you mention anything? Very good, very good, very good. It is in sun exposed area below the lateral canthus of the eye. Anything more of interest in an examination? Come on, man.
Above Ogren's line.
Above Ogren's line, or what is the line that I am drawing?
Tears.
Tear line. Read the Bailey Love. So remember that this is classically in the area of the face. You can say the Ogren's line and the tear line of the face. Okay, number 1. Number 2. Now let us talk about what about the margins of the area. Oh, sorry. What about the skin? Sorry, I really missed that point. What about the skin? The skin more or less appears normal. I have not been sure about any actinic keratosis. Hyperpigmentation may be in this area. Okay, this area may be, but these are all maybe actinic keratosis. We do not very sure of this. Okay, but what about the margins?
So well-defined margins.
They are well-defined margins. Okay, agreed on that. What about the floor? What about the floor? Remember that if this is the margin, this is the floor.
The floor is essentially smooth with little
floor is
areas.
essentially
Smooth
what is
with
in the
little areas of ulceration.
Come on, man, you are describing an ulcer. So how can the floor can have an ulcer? What do you get to see in the floor of this ulcer?
Granulation tissue.
Very good. Floor is filled up with minimum amount of a granulation tissue, but please write the word minimal amount of granulation tissue. What I'm more interested is that if it said some amount of a scarring in the floor, okay, because there is little amount of scarring and granulation tissue in the floor. Now tell me, what about the edge of this? This is a classical edge.
Punched out edge.
No, sir.
Rolled out.
Rolled out.
This very good. So this is the classical appearance of something in which understand that yes, that this is the rolled out edge of a basal cell cancer. So this is the classic rolled out edge of a basal cell cancer. So please remember that. So you saw a tuberculosis with an inverted edge. You saw a basal cell cancer with not an inverted edge but a rolled out edge. So this is what you are asked. Now, in a viva question, examiners would have asked you, what is the difference between a squamous cell cancer and a basal cell cancer? Now remember that both of them are non-melanoma skin malignancies. A basal cell cancer, what is important is, the basic biology difference is that after it grows, the ulcer only penetrates deeper. So the only thing that it will do is that the cancer, as you can see in the picture that I have drawn, the basic biology is that the cancer is going to grow in deeper. The cancer grows in deeper like this. So if the cancer is growing in deeper like this, it is going to invade the tissue. But there is also associated intense desmoplasia in a basal cell cancer. Always remember that. Basal cell cancers are associated with intense desmoplasia. Now, this intense desmoplasia is said to block or choke the lymphatics. And hence, what is the telltale sign that is absent from a basal cell cancer? What is very good? Remember that squamous cell cancers invade nodes very quickly. This one does not invade nodes because of two reasons. The reason number one is an intense desmoplasia that occurs around the growing edge or the growing base of the ulcer. Number two, the cells of these are extremely large in size. So if they are so large, how can they travel through lymphatics? Now, this is the reason it tries to grow in and is called as a rodent ulcer. It is called as a rodent ulcer. Okay? Right. So done. Now, the next part is, on the other hand, if you think about a squamous cell, the squamous cell, remember, has a rapid growth phase. So, in a basal cell, it has only a vertical growth phase. We talk like the way in a melanoma. Whereas in a squamous cell, the basic biology is that it starts exactly like a basal cell, and a basal cell had initially started maybe as a nodule, and then the nodule grows in deeper. So if you understand this one, that this is also a part of a nodule, and this nodule gradually grows both in vertical as well as horizontal planes. So that means the main emphasis is there is a horizontal phase and there is a vertical phase. Now, in a squamous cell cancer, definitely the horizontal phase predominates rather than the vertical phase. And hence, if you see about the central part, obviously will undergo a necrosis because it cannot get the food. And while it cannot get the food, and this part then technically becomes somewhat like this because it is trying to grow. So this tumor, as you can see in the picture, is trying to grow out. So please remember that a squamous cell cancer, what is the age in a squamous cell cancer? Very good. So I hope we have now understood today why does a squamous cell cancer have an everted edge. Please remember that. Now, the depth of infiltration and the involvement of underlying tissues will always be there, agreed. But remember that before this, so what is very important is the involvement of the lymph nodes because they are richly supplied, and that means they will also have a lymphatics, and lymph node metastasis is a common phenomenon. So this completes what is about a basal cell cancer. Now, the treatment of a basal cell cancer, remember, is not wide local excision. Please remember, squamous cell cancers are treated by a wide local excision with about varying margins, about 1 centimeter on an average. A basal cell cancer, what is the treatment of choice or what is the nature of surgery? What is the nature of surgery for a basal cell cancer?
Wide local excision.
No, sir. This is the reason I told you. You do not go for a wide local excision in a basal cell cancer. Why not? Array, I told you now.
Post microscopic surgery.
Okay, now tell me, doctor, why don't you go for a wide local excision in a basal cell cancer?
Because it is not spreading.
Because what is the type of growth that I told you?
Vertical growth.
Yes, it is more of a vertical growth. So if it is more of a vertical growth, why should you be worried with a wide local? Wide local is taken because you are more interested about the peritumoral lymphatic spread in the stomach. Why do you take a 5 centimeter, 6 centimeter margin? Because you knew there would be spread in the submucosal lymphatics. So in a squamous cell cancer, the thing that you are seeing is the tip of the iceberg, and hence your technique of excision has to be somewhat like this. But in a basal cell cancer, the main issue is about growing it into the depth, and hence a excision of the tumor with a margin being negative, and hence the role of a Mohs micrographic surgery has come in a big way in this point. Okay, so this completes this part. Now, we come to the next question on the mammographic abnormality. I think that this question was a very straightforward, but let us see how many of you wrote. Now, what are the points that you write in any mammography? Number one is that, what is the view? The view is a right mediolateral oblique that has been written. Okay, so the number one point that you have written is the view. Okay, now, so mediolateral oblique. The next point is that you have all defined, what are the points to define? Number two is that if you have mentioned that there is a vague lump in the breast, then what are the margins and what is the architectural distortion? Like if you see that the margins definitely are not ill-defined, but there is no architectural distortion. Architectural distortion is technically not very, very appreciated. More or less, the breast parenchyma appears to have a good architectural pattern. Now, after I have talked about, now talk about the next important thing, that is this. What are these things that have been shown?
Microcalcification.
Okay, good. An undergraduate, I would have given him or her maximum marks, but for a postgraduate, excellent. This is what I was wanting. Please see these ones. These microcalcifications are clustered as well as various sizes and various shapes. Now, sizes doesn't mean the micro becomes macro. They are all called micro because they are of a size of around less than 3 millimeter in a various way. But remember that these are all clustered microcalcifications, which goes more in favor of which pathology? Malignancy. Okay, malignancy. Can you be more specific? They will go more in favor of and DCIS. And if you have thought about a DCIS, now can you comment upon how much is the extent of the DCIS in the specimen? Hello? Can you see that the DCIS is extending technically, or these clustered microcalcifications are extending more or less very widely? Okay, but definitely with one view, it will be impossible to comment upon what is the extent of the DCIS. But remember, that will be one of the important factors when you are deciding for a breast conservation surgery. The next of the things to decide after you have talked about the microcalcifications is talk about the nipple areola complex, talk about the pectoralis major, whose border is very clearly shown, and sometimes even the axillary nodes and the condition of the skin is commented. So let us have a review. What is the margin of the lesion? What is the architecture?
तुम कल सुबह 9 बजे जो है ना,
calcification, nipple areola
फाइल लेके आना, फोन किया था हमको,
pectoralis major. So,
ठीक है, हाँ सुबह 9 बजे.
Comment in your exam about something called bypass, because we are not a radiologist, we are not going to score this. But if you are so intent about
तुम्हारे पास जो भी है सब लेके आ जाना ना,
probable BIRAD in this patient,
सब सर्टिफिकेट और उसका एक जेरॉक्स, समझा? जो मांगेगा, जो नहीं मांगेगा
probable BIRADs
कल 9 बजे लेके आना, ठीक है ना?
Wow, God, I do not know about 4A, 4B, 4C. But
बना लो. आज जो है कॉन्ट्रैक्टर चला गया था, कल सुबह में आएगा, ठीक है ना? कल
either it is a BIRAD 4 or a BIRAD 5. Okay. And what is the next intervention that you will always do in this patient? Cut biopsy. Very good. I will go for the core biopsy. Very nice. Okay. Right. So this completes the first part. I'm really impressed with your knowledge. Talk about this one. This is the more advanced one. Talk about this one. This is the, what is this? Ultrasonography. Ultrasonography. Very good, sir. Very good. Anything that is beyond
Elastography.
Excellent. Very good. So that means, what is this one? This is technically called as an ultrasonography or an ultrasound elastography. So this is called as an ultrasound elastography. Okay. Now, in this one, so the question has been very straight. In an ultrasound elastography, what is the advantage of adding an elastographic principle to the ultrasound? Try to understand the question. What is the advantage of adding an elastographic principle to the ultrasound? Anyone kindly answer this one? Or what is the principle of use of elastography? What is the principle of use of elastography, sir? Hello?
To determine the amount of fibrous tissue in the...
Okay.
Determine the invasiveness.
Invasiveness. Okay, right, sir. Sir,
hardness of the tissue.
Excellent. So this is what the examiner is wanting to hear, is about the hardness of the tissue. That means in the breast tissue, which one do you think is the most softest that can be deformed and it can quickly come back to the shape that it was before? So fat. Definitely fat. And which one will be the hardest of the tissues that if you put a put a strain, it is going to get deformed and it is not going to come back? That is going to be a malignant tissue. So definitely remember that if you think over in a elastographic world, in an elastography, the basic idea is that fat is soft and cancer is very stiff. So if fat is soft and cancer is very stiff, a fibrous tissue definitely will inch more close towards this point, whereas the normal parenchyma of the breast will go more in towards the fat side. Now, what this thing does is that elastography is usually done either in a dynamic. So the radiologist will use these words. They will use a word called as a dynamic and they will use a word called as a static. Okay. And what they will do is that they are going to have the measurement of, so the basic idea is something that you have understood. Now, so in a real time ultrasound with an elastography, what the radiologist is going to talk about is technically about the size of the lesion and technically about the stiffness of the lesion. So the size of the lesion and technically the stiffness of the lesion. So very basic things that we should know. Okay. Now when you talk about the size of the lesion, now there is a very important ratio that is to be important. Now, what is important is think over that if we did not do an ultrasound, now think over. If we did not do an ultrasound, okay, that now understand a very important thing. Can you see this tissue? Oh, sorry. Okay. In this picture, can you see the tissue? Oh, sorry. The pathology? Hello. Can you see the pathology?
Yes, sir.
What will be the ultrasonographic interpretation of this one?
Hypoechoic lesion.
Very good. What about the margins, sir?
Well defined.
Not well defined, sir.
Not
Can you
well
see that
defined,
not well defined, and can you see that the margins are irregular?
Irregular, yes, sir.
Is it an homogeneous or is it an heterogeneous appearance?
Heterogeneous, sir.
Heterogeneous appearance. Very good, sir. And that means now, see, there is a measurement. Say, for example, the measurement is, say, 4 centimeter. So I'm just guessing. Maybe 4 centimeter is the measurement, this is the maximum size. Now, the parallel picture number B, is you apply some elastographic principles and this elastographic things that are shown by this color codings. Okay, it looks like the Doppler code like thing. Now, when you do this color coding, can you see that how much is this green and this tissue extending?
Yes.
Can you see that? Okay. That means that this green and this tissue for the radiologists, that means their color coding thing means whatever is the elasticity of the tissue, the color of the tissue takes that color. That means if we consider that the blue is the normal fibrous parenchyma of the breast, and now consider that this so-called this green-orange thing is a cancer, appreciate that the measurement number X and measurement number Y in this very simple picture, which one is more, X or Y?
Y, sir.
Very good. That means if this ratio Y greater than X, that means the size of the lesion on an elastographic picture is more than that of the real-time image on an ultrasonographic scan. Remember that is going to suggest you this thing to be more of a cancer. Or people say that if the ratio is greater than 1. So initially it was 4, now it is also 4. The ratio is 1 or less than 1. But if initially the size is 4, but the elastographic appearance tells it to be 10, definitely. So 10 divided by 4 is more than 1. So understand that the bottom line thing is that on elastography the size is more. Okay. Please remember that the basic idea is that so the size increases because there is a surrounding desmoplasia of the cancer. So if you do a core needle biopsy, every one of you have done a core, you know what is desmoplasia, and the stiffness of the tissue reflects that only. So that is called as a elastographic first principle. The second is something that is more difficult for us as surgeons to understand, is something called as the stiffness, which is now measured by radiologists according to their various parameters that they will do, in which you are not required to know that, but for your MCH exams, just remember a name called as the Tsukuba scoring system. The T is silent. It is called as SUKUBA. The Tsukuba scoring system is something in which it is technically the color thing that I have shown you is technically something called as the Tsukuba scoring system, and this is what majority of people will use for their color coding and to make the surgeon understand that what is what into this one. Okay, so this is the first part of the thing that you are required to know. The only point, if you are interested to know, is please remember the name. I do not know how many of you will be able to remember the name at the end of the class. It is called as a Tsukuba scoring system. How many points are there in BIRAD? How many points are there in BIRAD? 6. That means BIRAD 0, BIRAD 1, BIRAD 2, BIRAD 3, BIRAD 4, BIRAD 5, and BIRAD 6. Okay, right. Now, if that is so, remember that in the Tsukuba scoring system, more or less looks like a BIRAD. The score starts from 1, which means the tissue is very elastic. Tell me guys, if the tissue is very elastic, deformable, is it good or is it bad?
Good, sir.
Good. That means it is not cancer. If the score is 5, that means it is very stiff. That means, what do you think is this thing then?
Favor of malignancy.
In favor of malignancy. Now the patient has a cyst in the breast. Benign cyst in the breast. Which one do you think will it be? Cyst contains water. More towards 1 or more towards 5?
More towards 1.
1, very good. More towards 1. Because as I have said, these are usually this one. So good. So that means you have understood this one. It took me many years to understand what is an elastography. Have you understood what is elastography and what is the color coding system that is used in elastography?
Sir, is there any particular indication for this when we do it?
No. Well. Good one. Very good question. I was expecting this one. Now, doctor, at end of the day, see, we are surgeons. Okay. At the end of the day, the bottom line for us is that in a triple assessment, you did a clinical followed by radiology. After the radiology, what is the decision that you take? After the radiology, what is the decision that you take? Whether to go for a biopsy, yes or no, isn't it?
Yes, sir.
Right. Now, what is the thing that, see, we surgeons, we are not interested with this understanding mammography, okay, magnifying the picture. I'm least interested. There is only one word that I am interested with. It is called as birads. We surgeons are least interested with elastography and all these things. We are not interested. The only thing that we are interested is birads. Now, ultrasound, remember that mammography came first. And thus, if you see the American College of Radiology, which has coined this term birads, the mammography atlas is in its 10th or the 11th. I've forgotten which one is it. It is a 10th or the 11th edition. But if you think over with an ultrasound, something that is very commonly called as a sonomammogram. Have you heard the word sonomammogram? Sonomammogram. Now, it is not combining ultrasound with the mammography. It is the improving the technique of an ultrasound to match the outcome or a specificity of a mammography. Now, for a birad on an ultrasound, the edition is still in the 5th edition. So that means they are still lagging behind. So to increase the specificity of the test, that means it is a cancer, it is a complementary addition that your radiologist is going to do. So that means if it was a birad 3, maybe after they did the ultrasound elastography, it can be upstaged to a birad 4B or the vice versa. Have you understood the point?
Yes, sir. Thank you, sir.
Okay, right. So this is a new concept. So please understand that your questions in future or your NEET SS questions, see, ultrasound is something that you read in your undergraduate days. So there is nothing great. Every one of you know about an ultrasound of the breast. Elastography is something that you can be asked in a long case also if you are doing good. So please remember that a radiologist who is confused with an ultrasound, he or she will add something called as an elastographic principle. Okay. And what is the name of the scoring? What is the name of that scoring system that I told you? Let's see how many of. Wow, good man. Sukuba. Okay, good one. So you can change your WhatsApp DP to this one. Good. That's it. So good one. So now you remember this one. Another thing with breast. Okay. What is this thing? What is this score?
All red score.
Very good. So this is an all red score. What is the minimum score and what is the maximum score?
0 to 8.
Very good. So all red score is 0 to 8. Right. Now, how did you estimate the all red score, sir? How did you estimate the all red score? Very simple. All red score is done by adding the proportion score plus the intensity score. Very simple. You just have to add these two. Okay. You just have to add these two. So please remember this one. So proportion score versus this one is done. So this is what the pathology people are going to give you about something called as an all red score. Now, to do an all red score, the important question is to do an all red score. Okay, what is the way the tissue has to be processed for an all red scoring? This is a question that many of my students usually ask me. How do you process a tissue for this one? Hello.
So to send it in saline.
That is the point. I exactly raised the issue, sir. The all red score estimates what, sir? Estrogen receptor and progesterone receptor. Please remember this is an MCQ. People mark it wrongly. It estimates estrogen and progesterone receptor. Very simple question. In a cell, if this is the nucleus, where will you get these receptors? Cell membrane or the nucleus?
Sir, can you spell the scoring system? What is it called?
Cell membrane.
Sir, nucleus steroid.
Have you seen the Deverity ad? Na? Give me red. So this is not that one. So this is all red. Okay. Right. So this is all red scoring system. Right. Now, the question was, where are these receptors situated?
Nuclear.
Very good. Another MCQ point. Estrogen receptor and progesterone receptor are steroid receptors that are situated on the nucleus. So what the hell are you doing with the cell membrane staining, ma'am? Tell me that one. The important thing is that there are two units, the alpha and the beta unit. What this Aldred score does is that it is an IHC, immunohistochemistry from the tissue block. What is the specimen, or how do you send a tissue block? How do you send a tissue block?
So in formalin.
Always in formalin. Never, ever, ever in normal saline. So if you are sending it a normal saline, kindly never send it a normal saline. We need a formalin fixed tissue that also within 30 minutes after taking a biopsy. Within 30 minutes of taking a biopsy. Within 30 minutes, this is by the ASCO CAP guidelines. You are not going to delay this. So no normal saline business ever, ever, ever from tomorrow, please. Remember that. We used to do normal saline 20 years back when we used to quantify the number of receptors in femtomoles per liter. That has been replaced by this Aldred scoring, which, as I've said, is from the tissue block with an immunohistochemistry measurement. So please remember that one. As what is the how do you calculate the Aldred staining? Remember that Aldred staining is calculated by the proportion score and by something called as the intensity score. Okay, so it is the proportion score and the intensity score. I do not expect you to remember this one. Just remember at least these 2 points: proportion score and what is the other thing that I said? What is the other score, sir? What is the other score? What are the intensity score? Please remember that one. What are these components? I do not need you to understand. But if you have seen this picture, if you can remember the 2 words, proportion and intensity, what is the minimum? 0. What is the maximum? 8. That is enough that I will be happy with. So please remember this one. Okay. Now, the next point is a HER receptor, that means HER2/neu, is again done by IHC. And what is done in this IHC business is that this is something that I told you in one of the last OSCEs. I do not have really forgotten into that what is an HER positive and what is a HER negative tumor. I will just erase this part, just a minute. Okay, so can I erase this thing? Hello? Can I erase this thing? Yes, sir. Right. Now, I have told you this question does not talk about HER receptor. Hello? Yes. So this doesn't talk about the HER receptor, but if you are reading the receptor report, then remember, HER2/neu report is done by, if it is less than 10% of the cells, okay, which are reflecting the HER2/neu status, it is reported as a score of 0. If it is more than 30% of the cells, this is reported as HER3 plus. Okay. Now, if it is, remember that something in which there is staining more than 10%, okay, but it is very faintly staining in more than 10%, but less than 30%, it is called as a 1 plus. But if it is staining more than 10%, less than 30% of the cells, but it is more or the less a strong stain, better than 1, this will be called as 2 plus. So if you are confused, I will again repeat. What is HER0? Less than 10 staining. What is HER1? Greater than 10, less than 30, but just faintly positive. Both of these are called as HER negative. So you are going to treat it as HER negative tumor. Whereas if it is more than 30% of cells which have 3 plus, that means it is strongly staining. Remember that this is a strong positive stain. So please understand that. Greater than 10, less than 30 is a 2 plus. And if it is 2 plus, what is the test that you do for a 2 plus? What is the test that you do for a 2 plus? You go for a fluorescent in situ hybridization, and that tells you again, if there is a nuclear amplification, then either it is 3 or it is this. So this is something that you are required to know on this part. Okay, chalo, yes, we move on. Now, what is the complication? What is this pathology that has been shown? Hello, what is the
retrosternal goiter.
Excellent. It is a retrosternal goiter. What are the complications of a retrosternal goiter? You know, I think the complications of the retrosternal goiter. What are the complications? Yes. Very good. So that it can be usually done by either obstructive symptoms like obstruction of the bronchus and the trachea, or compressive symptoms. Compression of what structures? Compression starting from the very good, the superior vena cava, the esophagus and the recurrent laryngeal nerve. Please remember that. 3 structures: esophagus, the recurrent laryngeal nerve, and the superior vena cava. Right? Sure. Now, what is the endocrine tumor localized to this region? Simple question. What is the common clinical presentation thereafter?
Gastrinoma.
Very good. So you know that. So this is the Jollinger-Ellison syndrome or a gastrinoma. So what is the name of the triangle?
Triangle of Passaro.
Very good. So it is called as a triangle of Passaro because Passaro presented the paper. He was the first author. He was a lucky guy. Everyone knows why this. You do not know the second author. Okay. What is the boundaries of this one? What are the boundaries? Comes again as a common question. What are the boundaries?
So it is the second and third part of the duodenum.
Junction.
And the junction.
Okay. So it is the second and the third part of the duodenum.
And the head and neck of pancreas.
Head and neck of the pancreas and the junction between the cystic duct and the bile duct. Okay.
Cystic duct and
CBD. So these are the 3 sites. Now what people do is that people extrapolate a little bit and they join these 2. But technically they should have joined like this. So this is called as a triangle of Passaro. So the retroperitoneum sometimes around the duodenum is always included in the triangle of Passaro. So please remember that one. Okay. Now, what is the importance of this triangle of Passaro or the gastrinoma triangle? Is that because 90% of the gastrinomas are known to occur in this triangle. So where is the gastrinoma more commonly located? In the triangle, as you can see in the picture, there are 2 sites that the gastrinoma can happen, isn't it? So very simple. It can happen in 2 sites. What are the 2 sites that it can happen? 1, it can happen either in the duodenum or it can happen in the pancreas. Any of this can happen, either in duodenum or in the pancreas. Now, which one is more common, duodenum or pancreas?
Duodenum.
Very good. How much percentage? 60-40. In the duodenum, then the more you go down, the incidence decreases. That means the maximum occurs in first part, the least occurs in the fourth part. Okay. Now, what is the clinical presentation of a patient with a gastrinoma?
So repeated duodenal ulceration and diarrhea.
Okay. Very good. So the common pathology, now see time is short.
And the duodenal ulcer doesn't heal on medications.
Very nice. So the pathology, sir, is increased gastrin that is secreted, and the increased gastrin produces increased acid production from the stomach. Everyone knows that from your first year in BBS. Now, the main problem is that beyond this, we are not taught that there are also a lot of vasoactive amines that are liberated, which can be associated with diarrhea, etc. But people say that they are not important. Important thing is the volume of the acid that is secreted. Now, so both of these, the volume of the acid that will lead to a peptic ulcer disease, and the peptic ulcer disease is seen not only in the stomach and duodenum, but is also seen in the distal part of duodenum, jejunum, and the small intestine. So what is the most common symptom that the patient presents with? Is peptic ulcer related problem with an abdominal pain and a recurrent peptic ulcer disease. It can be bleed, it can be perforation. What is the second commonest clinical interesting feature? So the second commonest clinical interesting feature is diarrhea. Please remember that. Diarrhea and abdominal pain, if you read Sabiston, diarrhea and abdominal pain more or less have an equal frequency. If abdominal pain occurs in 70% of the patients, diarrhea is known to occur in about 60 to 70% of the patients. What is so peculiar about the diarrhea in this patient? Hello, what is so peculiar about the diarrhea?
Trials tube aspiration.
Excellent.
This is the day.
Why, sir? Why does that happen?
The diarrhea is because of the osmotic effects of the acids.
Osmotic effect of the acid and because of the volume of the acid. So if you put in a Riles tube and aspirate the stomach juice, basically it is said that, as you have said, the osmolality and the pH does have a big effect. In contrast, a VIPoma, the diarrhea does not stop. So this is all about the gastrinoma. What is the investigation of choice to locate a gastrinoma? What is investigation to locate a gastrinoma? Remember that it is somatostatin for all neuroendocrine tumors in the pancreas. It is always a somatostatin receptor scintigraphy, except for which tumor?
Insulinoma.
Except for an insulinoma. Always remember that. Okay? Right. So complete this one. Now, thyroid again. What is the eponymous eye sign? What is the eponymous eye sign?
Late leg.
Little lag. Very good. Eponymous means always, what is the name of the word eponymous? The word eponymous means the name. So it is called as not Stelvag, sir. See the finger in the test. It is technically something called as a von Graeff sign, not Graphy. It is called as a von Graeff sign. So always remember that it is called as a von Graeff sign, or technically called as a lid lag, if you have used the term. The question for this is that, what is the explanation for a lid lag? What is the explanation for this lid lag? You know that the muscle that opens the eyes, remember, is called as levator palpebrae superioris. It opens the eyes, it pulls the eyelid upwards. Okay? Right. Now, this muscle is supplied by two nerves. What are the two nerves that supply? One. What are the two nerves that supply? What are the two? Come on, man. What are the two nerves that supply? One is the third nerve, the oculomotor, and one is the sympathetic. So please remember this one. Whereas, what is the muscle that closes the eyelid?
Orbicularis oculi.
Very good. Orbicularis oculi. Okay, which is supplied by which nerve?
Facial nerve.
Seventh nerve, or the facial nerve. That means in a parotidectomy, if you injure the facial nerve, the patient cannot close the eyes. Remember this. So if you remember this one, what happens if in a thyrotoxic patient, if the sympathetic tone increases? And if the sympathetic tone increases, then the major point that goes by is there will be more contraction of the levator palpebrae superioris. If there is more contraction, this is either going to produce a lid retraction. If you ask the patient to look down like this chap has been doing, called as a lid lag. If you aggravate it more, it is going to lead to a Stelvag, thereafter followed by a Cocker sign. So these are all these things, okay? Now, anything to ask about it, this one, please? Hello? Hello? Anything to ask about in this one?
No, sir.
No? Thank you. Okay, this one for good students. Let me ask about you this one. What is a pseudo von Graef sign? Anyone, please? Okay. Anyone, please, with an answer? What is a pseudo von Graef? Von Graef is seen in thyrotoxicosis. What is the where is the pseudo von Graef seen in? The pseudo von Graef is seen in a third nerve palsy, which is in the way of recovering. So that means what is the third nerve? The third nerve is an oculomotor. What happens if the oculomotor nerve undergoes a paralysis? What if the third nerve undergoes a paralysis? It produces what condition? It is called as a ptosis. Remember that means there is a drooping of the eyelid. But if that eyelid is in the way of recovery, sometimes it undergoes so much amount of action that it produces a contraction of the levator palpebrae superioris. So that is called as a pseudo von Graef sign. So this completes your description of this one. Now this one, the question about blood. I think you know this answer. What is the shelf life of blood? This comes as in your those NEET PG question like things. But still is important as a DNB or an MS examination. What is the shelf life of this blood?
35 days.
Very good, 35 days. Right. What is anticoagulant used?
CPDA.
Full form.
Citrate, phosphate, dextrose, adenine.
Very good. Citrate, phosphate, dextrose. The A stands for
Adenine.
adenine. Good one. And anything that is stored in this one can be stored up till 35 days. Right? Good one. Now, what is the indication for this one? Oh, how much does it contain in one bag?
250 ml.
No, ma'am. Usually, it should be at least 350. In India, it is about 350. Maximum, it is around 400. Never beyond 450. Okay. So this is what is the content. What is the storage temperature? What is the storage?
2 to 6 degree.
2 to 6 degree or 8 degree. Good one. Really liked it. Okay. So, and the RBC that has been stored in this one, what is the half-life of that RBC? Normally an RBC will live till 120 days. Now if you transfuse the blood, how long will this RBC live?
So it depends on the time in which stage it has been.
Say I took it from the day it was born, then
70 days.
50 days is the maximum time. Please remember that zoo animals live much lesser. This is a zoo for this one. Okay. What is the indication for a whole blood transfusion?
Trauma with massive blood loss.
Very good. Very good. Really liked it. Trauma with massive blood loss. Okay. So please don't say this to be used during an elective surgery. This is trauma with a massive blood loss. For surgeons, this is what I am interested in. Good. Now, guys, what is this tracing?
Thromboelastography.
Good. Really liked it. I really liked it. So this is called as a thromboelastography. Okay. For those of you who know that, okay, good one. For those of you who do not know that, I will just take a minute to make you quickly understand what is this thing called as thromboelastography. Those of you who have said this thromboelastography, guys, do you understand the meaning of these words? What is MA? What is angle? What is K? What is R? What is LY30?
No, sir.
Not at all, sir.
No, sir.
Not at all. Okay, so just I'll try to give you a quick recall about, as a surgeon, what are the things that I understand? Remember that these are things that critical care guys do. But as a surgeon, what are the things that I understand? Now, what is this thing? What is the story about this thromboelastography? Now, the story about this thromboelastography is very straightforward. What they do is that they will take a container, and in this container they will keep the blood, and in this blood there will be this is called this spatula like thing. There's something that they are going to call it as a pin. Okay, so this spatula like thing is something that this guys are going to call it as a pin. Please remember this one. That doesn't look like a pin. Okay, this is called as a cup. The cup contains blood. What is important is it contains a wire. If you see your tech apparatus in your ICUs or in your OTs, this is done, and this is attached to something called as a transducer, which goes back to a computer. See, the basic logic is, and this will be on a board, like you have your microwave. There is a board which always is in a rotation or in an oscillation. Now, what you are going to do is that you are going to pour in some amount of blood in this. Now, while you pour in the blood, what will blood form? Blood is going to form a clot, isn't it? So blood is going to form a clot. And what does clot contain? Remember that clot contains a amount of fibrin. Now, when you are having this clot that contains the fibrin, the problem is that this thing is moving. This thing is oscillating. Now, that means that basically this wire is always under a stretch. This wire is always under a stretch. Once you are pulling it on this side, another time you are pulling it on that side. So that means if this elastic thing is considered to be like, say, your chewing gum. Now, if you consider that this looks like a chewing gum or a bubble gum, and imagine that this chewing gum or the bubble gum, I have a very crude way of making you understand. That means understand that if this is the time, this is taking to make the clot. Understand? So what is happening is that this is the time it is going to make a clot. Okay? And then after it has made a clot, you are going to stretch the clot until and unless the clot of the chewing gum is made complete, and thereafter it again undergoes a lysis. So please understand that. So this is a clot and this has undergone a lysis. Now, understand a very straightforward thing, guys. The basic thing is that if you look at this type of graph, the first value is something called as the R. The time that it is going to take, because remember that at the end of this one, what is important is that you are tracing this you are just exactly tracing this with the time. Okay. So time is what is the most important paramount factor in this one. Now, so am I with you guys or are you lost? Hello?
Following, sir, so far.
Following. Good one. Thank you. Okay. What is important is till you have this chewing gum made, this area is technically the area where the clot happens. Or I will not write clot. What I will write is that it is technically a coagulation. So this part of the graph is clotting. Once it has formed the clot, that means you have stretched this chewing gum like many things. This area, from the time this graph is going down, is technically the area where the clot dissolution is going to happen. Or in simple words, it is called as a fibrinolysis. Okay. So coagulation and fibrinolysis. Are you with me? Hello. Right?
Yes, sir.
Good. So if you are with me, this area where the clot has been stretched up to the maximum will be the firmness of the clot. How tough is the clot, isn't it? So this area is called as a MA, or maximum amplitude. So this is technically called as a maximum amplitude of the clot. Have I made you understand this part? Okay. As I've said, the x-axis is the time. Now, the next part is, so if you have understood this, so now understand from the beginning again. So the blood is allowing to clot. Now the time the blood is allowing to clot and the clot formation occurs is technically called as the R time. So have you understood this part? It is technically called as the R time. I'm going to ask you this again later. Have you understood this part? What is R time? The time that it takes to form the clot. That means, what is the pathology in which the R time will be prolonged?
Platelet thrombocytopenia.
Coagulation development.
Sir, understand that. Exactly. The main problem here is the clot formation. Understand? The main problem here is not platelets, sir. The main problem here is the coagulation is happening at this point. So that means a clot formation is going to happen. If you have a coagulation problem by any factor, sir, at this point, that means I'm going to ask you, what are the three mechanisms, what are the three pathways that we read in our physiology classes? Something called as intrinsic factor. Remember that intrinsic pathway,
Yes, sir.
extrinsic pathway and common pathway, isn't it? Okay, what is that factor that is, what is the test that you do to test the intrinsic pathway? APTT. Very good. APTT means, what is an intrinsic pathway? Very good. So that means all those tests. Oh, correct. What is the factor that is involved in extrinsic pathway?
3 and 7.
Is 3 and 7. Very good. What is the extrinsic 7 dependent upon? Where is it made and how is it made? What is it made? Come on, guys. You knew that. In obstructive jaundice, what happens?
Liver.
Very good. That means in an obstructive jaundice patient, what is the abnormality in? PT or APTT? PT or APTT? PT. Because remember, as I've told you, intrinsic pathway is seen by APTT. Extrinsic pathway is seen by PT, which is seeing factor 3, 7. Remember, fat soluble factors. If that is so, remember that there is a common pathway which talks about fibrinogen and fibrin. So that means very simply the R time takes about that how much time does it take for the clotting to happen. Okay, so please remember that R time takes into account how much time that it takes for the clotting to happen. Okay, so this is the first part that you are required to know. Now, the next part of this is that now talk about the second component. Now, as I've said, the maximum amplitude, say, is about 50 to 70 millimeter. But what is important is, remember that there is a time called as the K time. Now, there is a time called as the K time. K time means if the maximum amplitude, say, is 50 to 70 millimeter, you wait for the clot to become 20 millimeter or 2 centimeters. That means you are stretching the chewing gum, and in between the two threads, you are allowing the fibrin fragment and you are allowing it to go till 20 millimeter. Now, when you have 20 millimeter, that time I will use another color. This time is called as a K time. So what is the meaning of the word K time? The K time is technically the time that it requires to reach with an amplitude of 20 millimeter. Have I made you understand this point?
Yes, sir.
Good. At this point of time, now understand, there is a slope of the graph. I will again repeat. The graph is forming, and by this time, can you appreciate that there is an angle that is being made?
Yes.
Okay, some people are tired, man, long day. So this is called as an alpha angle. So the alpha angle will denote the slope of the graph. So what are the 4 parameters that we have? R time, K time, alpha angle, and the maximum amplitude, MA. And finally, remember that what becomes important is if you allow the clot to stay at one point of time, the clot is going to have a firmness. Now, if coagulation is done, what is the thing that allows the clot to form and be firm? Is all dependent upon platelets. Platelet is something that allows the clot to grow and have a form. That means if the patient has a platelet problem, the amplitude of the clot is not going to form. That is what is going to be a problem. The next issue is this one, is now the clot is undergoing a lysis, clot dissolution. If the clot is undergoing a lysis, please see the end of the graph. Okay, so please see the end of the graph. That means at 30 minutes, so please remember that what is important is, what is LY30? LY30 means that at 30 minutes after you have had the clot that is formation, or 30 minutes of the time, remember that what is the percentage of the clot that will undergo a dissolution. So please remember that. That means 30 minutes after reaching the maximum amplitude. Some people say that after reaching the maximum amplitude, if you go for 30 minutes, then what is the percentage of the clot that has undergone a dissolution? So if you have understood up till this one, so what I will try to do is that I will try to quickly summarize this by making a table so that you can understand what is a thromboelastography.
Sir,
and yeah. Hello? Yes, sir. Hello.
Sir, 30 minutes is from maximum amplitude.
From the maximum amplitude.
Okay.
Okay. Right. Now, what I will try to do is that I am taking too long. What I will try to do is that I will quickly summarize the story for you. It is difficult to write. What is R time? R time is the time that it took to form the clot. Okay, right. See the graph. What is R time? R time is the time that it took to form the clot.
Yes, sir.
Is right? What
Yes,
is the
sir.
normal time that it takes to form a clot? 5 minutes. Some people said 10 minutes. It is the maximum time. Okay. What is this clotting dependent upon?
Coagulation factors.
Coagulation factors. So if there is any problem of a coagulation factor, what is going to be the pathology of the R time?
It will be
going to
lengthened.
prolonged or lengthened. So what is the treatment if there is an R time prolongation?
Fresh frozen plasma.
Fresh frozen plasma. Like in a patient with an obstructive jaundice. Good. Now what is K time? K time is, as I have said, how much is the clot strength? The clot strength is up till how much? What is the time that I told you? 20 millimeter.
20 minutes.
Okay. How long will it take to do that after the clot forms? When you are stretching, is about 1 to 2 minutes. Now, how much is the strength of the clot after the clot has formed? Purely will depend upon the fibrinogen. Because fibrinogen forms a fibrin. So if there is a fibrinogen deficiency, what is the material that you are going to give? If there is a fibrinogen deficiency, the K time is going to be more prolonged. Okay. Now, what is the fibrinogen deficiency then? Is FFT, but better word is a cryoprecipitate. Right?
Yes, sir.
Right. Now, let us talk about the alpha angle. Okay. What about an alpha angle? The normal alpha angle is the time that in this K time, that means technically enough that it is a time for fibrinogen to form. The normal alpha angle is about 60 degrees. Looks like an isosceles good triangle. So if there is fibrinogen deficiency, the problem is that the K time is going to be more prolonged. Will the angle decrease or will the angle increase? What is your opinion? If the K time is prolonged, very good.
Decrease.
It will decrease. That means exactly the graph is going to go down. So sorry, the slope is going to go down. And if there is a fibrinogen deficiency, what is the treatment? A cryoprecipitate. That means you need. Now, what is MA? What is MA?
Maximum amplitude.
Maximum amplitude. That means maximum amplitude means the clot strength is dependent upon that, man. That means what is the clot's length in that? Is around 60 millimeter. So remember 60 degree, 60 millimeter, and it is totally dependent upon the platelets. So if there is a platelet problem, remember that this
It will reduce.
length. Yes, exactly. So this is going to get reduced. So what is LY30? I don't have space to write here. What is LY30? LY30 technically means that at 30, what is
30
going to
minutes
happen
post.
in this one? At 30 minutes post the maximum amplitude, what is going to form in this area? Okay. So this is more or less the story about this one. Remember that normally it is about that the LY30 should be the normally remember that what is the LY30 story? The LY30 story is that percentage of the lysis at 30 minutes into this. Okay. Now the normal time of this one is that within 30 minutes maximum is about 10% of the clot should be dissolved. So if there is more amount of clot that is getting dissolved or the LY30 is getting reduced, you can use drugs like tranexamic acid to in this part. So sorry, I have written it in this one. You can use tranexamic acid in this part. Okay, so the normal is less than 10%. Clot is dissolved within 30 minutes. So it took a long time. So this is something called as the interpretation of the tech. 5 parameters: R time, K time, alpha angle, maximum amplitude, and the LY30. So the next time now you can see your Bailey law or your Saviston. I hope you will understand some working principles about what is called as the tech. Okay guys? Hello?
Yes, sir.
Right. The last 2 questions are simple ones. What is this device called as? This is called as a tunnel port or tunneled or a catheter. Okay. What is the specific advantage of this device?
To give chemotherapy.
I know that to give chemotherapy. It avoids line-related infections. There has been a subcutaneous line. It avoids technically line-related infections. Okay. So this is called as a chemo port device, right? Now this one. What is this bedside procedure? Very good. Is it not fasciotomy?
Sure.
Fasciotomy.
Or
No,
is
it is
sclerotomy?
escharotomy.
Yes, come on guys. See the bond. See the bond leg, na? Okay, so this is technically an sclerotomy that has been done in this. What is the indication? Indication has been a circumferential burn in the limb with an impending compartment syndrome. Okay, so this is about, but if the compartment syndrome is impending with a circumferential burn, patient is immobile. This is one of the causes of reasons of doing an sclerotomy. Like the last one is the Parkland formula. What is the modified Parkland formula?
4 ml per kg per percentage of burn in first 24. Body surface area.
Okay. Or the body surface is it? Very good. Is it the body surface area or is it the body weight? So remember that the percentage is the body surface area involved, which can be maximum taken as 50, and the body surface body weight is what is the actual weight. The original Parkland had 4, which was divided into crystalloids as 3.5, colloids as 0.5. We now have removed this colloid concept. In the modified Parkland, this is a pure crystalloid formula in which we talk about 4 into percentage of the body surface area involved. And remember, this is the total body surface area. Okay. A patient has a 1st degree burn, 2nd degree superficial, 2nd degree deep, 3rd degree burn, and a 4th degree. How do you calculate the percentage in this one? Please remember, first degree is something that we exclude. Okay? Chalo. So this completes your description into this part. Any more queries, please?
Sir, in the last question, can you please tell the final figure in this patient, which was 50 kg?
Final figure, sir. What will be the final figure? Bolo. 4. I'm bad in mathematics. 4 into 50 into what is the percentage of burns? 50. What is the body weight? 50. So, sir, let us calculate it again.
10 liters. 10 liters.
10 liters. Very good. Now, this 10 liters are to be given in 24 hours, isn't it? 24 hours from what time?
The time of burn.
From the time of burns. Very good.
From the time of burns.
Okay, and then if it is the time of burns, you are going to divide the 24 hours or 10 liters into 2 groups. 50% of the fluid is 5 liters, is given in the first 8 hours, and next 5 liters are given in the next 16 hours. So this is how you give the fluid. Okay, what happens in the next 24 hours? This is the first 24 hours. What happens in the next 24 hours?
Maintenance fluid. Normal maintenance.
No, sir, absolutely not. The percentage calculation becomes 2 into percentage into the body weight or the maintenance fluid, whichever is greater. What happens from the day 3 is 1 into percentage into the body weight or the maintenance fluid, whichever is greater. So please remember that. So the Parkland formula, the modified Parkland is this one. Right? Okay, chalo. Okay, so we have had a long discussion today. Questions and queries, please.
Sir, what is the ideal fluid for bones?
No one knows, man. What is the ideal fluid depends upon which hospital you are, how much amount of colloids you are required to use in that. Number 2 is that this is a very tough question. The commonly used formula, as I've said, is the modified Parkland daily lab data. The commonly used crystalloid is Ringer's lactate. But definitely there are multiple controversies like use of normal saline, use of Ringer's acetate, Hartmann solution, etc. But that depends upon the age of the child, the choice of reference in the burn center, etc. Number 2 is that use of colloids also. Okay. Right. Thank you. Okay, any more queries?
Sir, can you please show the chemo port slide?
Chemo port. I'm not happy with the chemo port. You have said it was a chemo port.
In the chemo port, we don't insert these triple lumens.
This is something. I stayed silent. Okay, but everyone said it was chemo port. I said, okay, chalo for an osce. You don't insert a triple lumen for this. This is technically a tunneled subclavian catheter, or something that we something called as a Hickman, and it's a tunnel subclavian catheter that we use. The main reason for a tunnel subclavian catheter is to avoid the infection. Okay. Chalo. Any more queries, please? Okay, so if there are no, then we'll have the
Thank you, sir.
off. Thank you. Thank you, everyone.
Thank you, sir.
Thank you.
Thank you, sir.
Thank you, sir.
Thank you, sir. Thank you, sir.
Thank you, sir.
The important thing is, what you chaps need is to have my typing didn't, match up with my thought processes, but that was me.
Okay. Right then.
Okay, right, there you are.
Okay. So, right. Okay. So, let me have the screen sharing option. Okay, guys, a very good evening to all. Okay, everyone. Let us start with the second one. So let me have the screen sharing option. Just a minute. Yeah. When did they have a break? Because everyone will be asking me, sir, we need a 5 minutes break.
Actually, unfortunately, I didn't give. I had to take some questions as a result, which I was scared I'm going to make you very late. So I managed to.
No issues.
I managed to make up.
So because my discussions today are not going to be too long because they're very simple OSCEs. Okay.
So very interesting. I've seen all your questions.
Right. So they are because someone told me said that your OSCEs were very high level. We felt that it is an easier option to write. Okay. So let us.
I unfortunately took them through the entire gamut of surgery, general part of general surgery down to vascular, the works, urology, and everything.
Right. So today we shall be having little bit of super specialties and some bit of general surgeries with lumps. Okay. So if you can have some time, so please stay along with some discussions.
Yeah, I have a meeting again, the TASIC meeting which we are having tomorrow.
Okay, right. Yes,
I have to prepare that.
Right. Okay then. Okay. So everyone, a very good evening. So we start with the OSCE. Ready, ladies and gentlemen? Hello.
One chance if you're ready, just
hello. Ready? Okay. Let us start. Okay, the first one. 26-year-old lady presented with a swelling in the floor of the mouth, as you can see in the picture. Describe your findings. So the first question is a few words. The second question is what is the treatment plan? 2 questions. So tell me when you are complete so that we can move on to the next one. So today my set of OSCEs are going to be very, very easy. You will feel that they are undergraduate.
So Ramanuj, what I did was I gave them 4 minutes per OSCE, and in some I went into 3 minutes. So just I told them that you have to get used to it.
I think that I will be giving a little less, 2 minutes maximum. By the time you can cook Maggie, you have this time, 2 minutes. Okay. Because in OSCEs, because we are preparing for you for the whole gamut and whole spectrum of OSCEs. Because maybe that there can be 30 questions with 2 minutes. So you never know the timing. Okay. Kindly don't write your answers in the chat box. So please write your answers in your own copies. Okay guys, when you're complete, give me a time. I think we'll be giving 2 minutes. Okay. Okay guys, I think we'll be going to the next slide. Okay, can you go to the next slide? Hello, can you go to the next one?
I think Ramanuj, you just take 2 minutes and go ahead. Otherwise,
right. That's the better option. Okay, this one is a 34-year-old gentleman presented with a painless lump in the finger, now which bleeds profusely to touch. Mind my words, bleeds profusely to touch. It is a painless swelling that's not increased in size over the time. So this is the swelling in concern. Question number 1, describe your findings of this swelling. Question number 2, what is your diagnosis? And question number 3, differential diagnosis. If I give you, so that means if there is 5 marks, okay, kindly mute your audio. Someone has the bike. Okay, so if there is 5 marks, I will be giving again a 2 and a 1 and a 2 marks in this one. Okay. Right. Okay. Guys, we move on to the next one. This is very simple. Identify the instrument for 1 marks. Use of this instrument for 4 marks. That means I expect at least 4 users from you guys. Am I audible, everyone? Hello. Okay.
Yes, sir.
Mm-hmm. Okay, we move on to the next one. If you have completed, we move on to the next one. This one is from radiology. You can see an X-ray in your screens now. The question is very simple. What is your diagnosis? 1 marks. And what is the management outline for 4 marks? Hello? Am I audible, guys? Hello?
Yes, sir.
Yes, sir. Good. Go on to the next one. Another X-ray. You can see an X-ray in front of you in your screens. X-ray of the abdomen. Questions are very simple. 1 marks is an undergraduate question. However, this is not an undergraduate question. What are the investigations? So this is for 1 marks and this is not for 2 marks. This is for 4 marks. Okay, chalo, we move to the next one. The next question is this one. An instrument that may have seen in your specialty rotations is this one. Questions are: identify the instrument 1. I'll give it 2 marks in this one. Common uses, I will give you 3 marks. That means I need 3 uses of this instrument. Am I audible, everyone? Hello?
Yes, sir.
Okay. Okay, chalo. Okay, guys, we complete. Go to the next one. Another instrument. Now, important questions. Identify this instrument for 1 marks. Common uses 2 marks. Common complications due to the use 2 marks. So this is basically a consortium of this instrument. You must have used this one as a postgraduate. This is a very common question that I'm asking you. Very easy question. Okay, right. We move to the next one. Okay, guys, am I audible? Hello?
Yes.
Hello? Right. "57-year-old presented with this finding. Describe the findings." It is not the diagnosis. Describe for 2 marks. And treatment plan for 3 marks. Okay, guys, can you move to the next one? I think we can. 8 done. Now, go to the next one, 9. This is an interesting one. Okay, guys, am I audible? Hello? Am I audible?
Yes.
Right.
Yes, sir.
An 8-year-old boy, mark the age, was bought by his parents with a painless swelling in the buttock that has been enlarging for the last 6 years. That means it started from the age of 2, is now the boy is around 8. Now, this swelling is found to be soft and transilluminant. The questions are not what is your diagnosis. The questions are what is your differential diagnosis. This is what should give you 3 marks and your investigations 2 marks. Okay, I think yes, time is up. Okay. Guys, is the screen visible? Hello? Hello? Is the screen visible? Right.
Yes, sir.
So, 6-month-old male child brought to you in the outpatient department with a reducible groin swelling. Again, the questions are, what is your differential diagnosis? What is the treatment that you have planned? Okay, right. This is a very simple one, as you can see. This is an interesting one. I took up this one because all of you are surgeons and this looks like very simple. You should identify the device. This one. Okay. I need the specific name. What is this device called as? Okay. Number 2, if you use this for a minimal access surgery, say like lap chole, what are the complications of this device? The question is complications of this device. There are around, I will give you 1 marks in this one and 4 marks, meaning that there are 4 complications. Okay, right. I think we will now move to the next one. This is a simple one. I took this picture from the internet because I did not have this. Identify the instrument. I will give you 3 marks on this one. And use of this device is for 2 marks. Okay, chalo, we move to the next one. Another simple instrument. Identify for 2 marks. Use of this device for 3 marks. Okay, we move to the next one. Second last question. Identify the instrument. I will give you 3 marks on this one and use of this device for 2 marks. Okay, is the screen visible, everyone? Hello? Yes, sir. Right. Okay, guys, I move to the last question of the day. Right. Is the screen visible? Hello.
Yes, sir.
Right. Now, mind you, the question says in this one, principles of the use. This is an important part. Okay, guys, I think the time's up. We start with the discussions now. Hello. Hello.
Yes, sir.
Am I audible, everyone? Right. Good. Chalo. Am I audible? I think we'll start with the last ones because this came out before. So I think that we'll start with this one and then we continue. No, I think we started always with the first one. Okay, chalo. We start with the first one. So how was this set of OSCE? Is very simple, isn't it? Hello? How was this set of OSCE? Very simple. Come on, guys, feedback.
Yes, sir.
Very easy, na? Very good. So you scored as one. You score 100 out of 100 in this one? Or 75 out of 75? Okay. Chalo. Let us start with the first one. Describe your findings. What is your diagnosis in this case?
Ranula plunging.
Is it lanula? No, sir. This is the point that I wanted to say. And now, what is a plunging ranula? A plunging ranula will mean that what is basically a ranula? Now, there are a few things to understand in a ranula. Point number one is that this is the frenum linguli, the thing that you have in screens. Frenum linguli. This is the tongue. Which surface of the tongue? This is the dorsal surface of the tongue. Okay. And this is the under surface of the tongue. Okay. Right. So what happens is it is exactly at this point that the duct of the submandibular gland opens. Now the sublingual glands, what is important for everyone to understand is that are always located by the opening of the submandibular duct. Either they will drain directly or they will drain. So they have duct of Bartholin, duct of Rivinus and all those things. Now, so the one school of thought that a ranula has something to do with the sublingual salivary gland. So this is what people thought. But now we have known that no, probably this is not the scenario. Okay, so the basic idea is that there are various minor salivary glands in the floor of the mouth, and the minor salivary glands, they go by multiple names and etc., usually form a small cyst-like dilatation, and the cyst-like dilatation, what happens is that it ruptures, and when it ruptures, all the mucin comes out and accumulates into the floor of the mouth. So this is called as a mucus extravasation cyst. So a ranula is nothing but a mucus extravasation cyst. So the question that was given was describe your finding. Okay, so what is usually the typical finding in a ranula? So the typical finding in a ranula is that usually occurs in the floor. So first of all, location. See, the examiner is asking for a very specific, describe your finding. So site, size, shape, surface, skin or mucous membrane, surroundings, okay, and scars. So 1, 2, 3, 4, 5, 6, 7 points. Site is in the floor of the mouth. Size is, say, for example, 3 by 4 centimeters. Shape is ovoid. Surface is smooth. Skin and mucous membrane is stretched, giving it a very peculiar color. What is the color? Color always is said to be a pale blue color because of the refraction of light through the mucin. The surrounding tissues are normal and there is no scar. Now, that means what happens is that if this is the floor of the mouth, okay, the muscle that forms the floor of the mouth is always the mylohyoid. Now, if you consider a ranula is always will occur above the floor of the mouth. Now, what the more important part of the story is that as it occurs above the floor of the mouth, okay, some amount of mucin comes out, digs out through the mylohyoid, and when it digs out through the mylohyoid, the mucin goes down and the mucin accumulates in this area. So this is technically enough, the collection of mucin beyond the mylohyoid, usually in the digastric triangle. Okay, so this is all about, so this is not a plunging ranula. A plunging ranula usually is found in the digastric triangle. Okay, so the next question is, what is the treatment plan? What is the treatment plan, guys, of this one? Hello, what is the treatment plan? Marsupilization. Very good. So examiner is understanding what marsupilization. Okay, that means that you deroof the ranula and all the mucin that comes out is in this. Now, when there is a recurrence of the ranula, people do something called as an excision, which is a very difficult thing to understand because they do not know what to excise. I can deroof. There is another group which says that no, you should always take out the sublingual gland. Now, guys, as I've said, how can you take out the sublingual gland? It is so small, it is not seen. So what people do is that they find the submandibular duct, they find the criminal sublingual gland, and they take out both the sublingual as well as the submandibular gland. But again, so that is too much of a kill. What I feel, you may take out the the sublingual gland. But majority of the times, what happens is, depending upon your first operation, the amount of the tissue that you have excised at the floor of the mouth, this is usually what happens. Okay, so this is all about ranula to begin the day with. Any questions or any queries? Okay, right. Any questions or any queries, please? Hello.
Sir, why cystic swelling always give blue color, sir?
Very simple, na? Not always, sir. The mucus gives a refraction of light. Okay, so it is basically the clear mucin which refracts the light and it appears as a blue. But provided, remember that there is a thin mucous membrane. Say, for example, you get a mucus retention cyst under the skin, okay, or under the lip. Does it appear blue? No. But it appears blue in a ranula because the overlying skin is so thin and the mucus produces a refraction. That's it. No. So let us go to this one, the second OSCE. This is a very simple case until and unless you have seen such one. What is your diagnosis, everyone? What is your diagnosis in this one?
Pyogenic granule.
Very good. So this is called as a pyogenic granuloma. Good one. Few quick questions to know because I made this presentation because I know that you will be exhausted by this time. Simple questions. Describe your finding. Can you describe your finding in this one? As I've said, site, size, shape, surrounding, skin, scar, surface maybe. Okay. What is the site, guys? The site is in the finger. Which aspect of the finger is this one?
Palmar aspect.
Again. So please remember, so some simple thing. A finger doesn't have a lateral and a medial. If you're using this terminology, no, you are not doing the right things. It is not a good one. On the contrary, use a term called as radial and ulnar. So which is a much better term than using this one. So it is a radial and a ulnar, the term which is to be used. So the second point of concern is that shape, size, etc. something that you do, the skin down here may have a scar because of a history of a healed trauma, and a pyogenic granuloma is usually the name is a misnomer. I hope you know that from your undergraduate classes. Now, why is it called as a misnomer? Can anyone of you tell me why is it called as a misnomer? Okay, right. Now, so the pyogenic granuloma story that starts is, if you have seen that size, etc. Hello, guys, am I audible? Because if you don't describe, when I feel sometimes scary, right? Now, so Rocker says that, as you can see, the color of this one, or the skin color, appears to be again purple to red. So it depends upon what type of this one is. This scar is usually present. Surface is smooth to small nodulations or small. The shape is usually a round one. Now, the name is a misnomer. Can anyone of you tell me why is the name a misnomer? I stopped at this one. Why is the name a misnomer, guys? Hello? Why is the name a misnomer?
It's not purulent, sir.
Number one, it is not purulent. Neither does it arise from an infected wound. Okay. Why is it not called, or what's the wrong about being called as a granuloma? Because it is not associated with a specific granulomatous disease. Now, so that means examiners will ask you, okay, doctor, so this is pyogenic granuloma. So what is exactly the origin of this one? What is exactly the origin of this one? So if it is not pyogenic, if it is not granulation tissue, so what the hell is this one? Anyone with an idea, please? Hello? Come on, this was so simple. Anyone with an idea, please? Where does the pyogenic granuloma start from? Hello?
Sir, because of the trauma. So because of the trauma, the epithelial, sir,
Granulation tissue.
the epithelial will go inside.
Well, sir. That is the reason I caught you. What did I tell you? The name is a misnomer. There is no granulation tissue story in this. No inflammatory tissue. This one, sir, is a benign angioma. This one is a real benign neoplasm of the developing capillaries and small arteriole. Now, till to this date, we really do not know why does it form, or what is the etiology of forming with a trauma. But yes, this is a benign angioma to remember. So remember that this benign angioma, that means it is a neoplasia. So if this is a neoplasia, until unless you eradicate one, you are going to get this thing back. So what is the differential diagnosis? We're coming to the treatment. What is the differential diagnosis in this case?
Sir, why is the scar present?
So the scar is indicative of a trauma or an abscess or whatever you have drained. Now, this is the reason I brought this question, so that this is such a simple question, but again, people get so confused. So, sir, what is your differential diagnosis? Number one is a hypertrophied granulation tissue. But remember that hypertrophied granulation tissue, the only simple difference is that they usually regress with time and they do not increase. This is the gross difference. But both of them usually will bleed. Number two, anyone with any other example? Any other differential diagnosis? Pardon, please? Squamous cell carcinoma. So do you think squamous cell carcinoma is very common to arise in the finger? Hand, okay. Palm, okay. There's no doubt on that one. Papilloma, very good. I really liked it, sir. But does a papilloma bleed profusely to touch?
No, sir.
So any other? Come on, guys. I told you, this is benign. So what is the malignant counterpart of an angioma? Come on. That is not at all a neoplasm, sir. Hemangiomas are hamartomas. Remember, that means they are not. What is a neoplasia? Neoplasia is a tumor. It is a benign tumor. So an angioma is basically neoplasia that arises a benign neoplasm. Do you know of any malignancy that looks like this?
Yes, sarcoma.
Very good, very good, very good. Can I again repeat, ma'am? Can I again repeat?
Sarcoma.
Angiosarcoma. Very good. I really liked it. Okay. Can you mention any small, exactly thinking in the lines of a sarcoma that occurs in the peripheries in immunocompromised individual? Exactly like this.
Kaposis or Kaposis.
Very good. Really liked it. And presents exactly like this. Okay. Now, talking about a skin malignancy. Do you know of any skin malignancy that looks like this as an extremely poor prognosis?
Amelanotic melanoma.
Exactly. I really appreciate that one, sir. It's an amelanotic melanoma. Can you be more specific on this one? This is called as a acral
Lentiginous.
acral lentiginous, which makes it extremely poor prognostically bad. So please remember that a pyogenic granuloma, okay, is usually it increases in size and sometimes does mimic these findings. So clinically, to the clinician, it can be a very difficult differential diagnosis, particularly remember with a melanoma. Always mind you, so all pyogenic granulomas, if you do excise, must be sent to the histopathologist with these notes. That this is the finding, so please look into that findings and then think. Okay. So this completes your pyogenic granuloma story. Now, how do you treat a pyogenic granuloma? How is a pyogenic granuloma treated? It is usually treated by application of excision. Very good. You don't need to take any margin, or by application of chemical cautery or thermocautery. Right? Okay. Now we go to the next one. Okay, what is this instrument? This is an undergraduate question. We'll be taking just a minute in this one. Come on, man. What is this instrument? What is this instrument? Come on, man. I made this so easy today. Is this? What is this instrument?
Alice tissue.
Tissue holding forceps. Uses 1, 2, 3, 4. Come on, uses 1, 2, 3, 4. 1. During a neck dissection, it is used for holding the flaps so as with a thyroid. Number 2, during a hernia surgery for holding the external oblique aponeurosis. Okay. Anything more with an Alice tissue forceps? Anything more? Okay. During the rectus sheath, during an abdominal wall closure. Very good. I appreciate that. And anything more for excision of small lumps and bumps. Example, if you have taken a sebaceous cyst or a lipoma and that lipoma and the sebaceous cyst needs to come out, you hold the lipoma with an Alice. So these are the 4 things. Remember, questions are as simple as that. But what the examiner is trying to test you is what is your span of knowledge. So with this one is this question. Okay, right. Now this question is so simple. Diagnosis. Okay. What is the diagnosis from this one? Hello. Right. Right. So please remember that my diagnosis, if this is the right side of the body, is the right renal calculi. Okay. Which are all radio opaque. Please remember that. In this aspect, just a point to add, I have described it in previous classes also. Can you mention a few radiolucent kidney stone?
Uric acid, xanthin.
What is the mnemonic that I taught you? What is the full form of this one? What does the T stand for? Triamterene. What does the I stand for? What does Zen stands for? And what does U stand for? What does S stand for? Usually people take antacids into that. So please remember the mnemonic. So the mnemonic is Ixus is a radiolucent calculi. Now, will you call this calculi to be a staghorn calculi? Hello? Okay, hello. Will you call this to be the staghorn calculi? Come on guys, don't sleep. Okay, so we have a long way to go. Right. When can we call it as a staghorn calculi? Come on, I taught you all this. Okay, no, I did not teach you all of that. No, when the shape of the calculi looks like a stag. Okay, do you know what is a stag? A stag is a male unmarried deer, reindeer deer, so that is called a stag. So this is a stag. Now the main issue is that when do you call a staghorn calculi is when the stone, now see the picture of the stone. When the stone takes the shape of the pelvis and at least one major calyx, two major calyx out of the three major calyces. So that means to call it as a staghorn calculi, it has to occupy the pelvis and at least two major calyces. So please mind you. Okay, so this is all. Now guys, tell me, what is the chemical type of the stone in this picture? Any guesses? I know that it is not a very appropriate question, but still, any guesses into that? Hello? So many multiple stone. So many multiple triple phosphate. Very good. Sir, they are dense, white, triple phosphate. So now tell me, doc, so if this is a triple phosphate stone, true white stone, okay, say for example, this is a triple phosphate stone. What are your treatment modalities for this patient or management treatment? Come on. What is the management algorithm? The patient comes to you in the OPD. Then, what is the set of investigations that you advise for this gentleman? Come on, guys, don't sleep. What is a very simple undergraduate question? What is the set of investigations that you go for this patient? We go for something called as the renal function test that includes urea, creatinine, blood urea, nitrogen, followed by a CT scan, which is both a contrast and a non-contrast. And then we tell our radiologist, please give us something called as a CT urogram. And now based on the CT urogram findings, you take a call. Okay, if the kidney is viable, which it is, then what is the nature of surgery that you are going to do to remove the calculi? Hello? What is the nature of surgery to the kidney? Is a percutaneous nephrorectomy. Very good. Why don't you do an ESWL, sir?
Size.
Number one is size. Number two, less than 2 centimeter. Number two, anything more. Now this is calls for a bit of exactly. Very, very nicely said, sir. See, this kidney, if you think over, now I'm teaching you virology also. Okay. Now, if you consider this kidney, do you know what will happen if this stone breaks? All the debris are going to collect into this area, which is not going to come out. So if you consider that this is the shape of the major calyces, it is not an ESWable stone given the location of the stone. Hence, you should go for a PCNL. So this completes the description of this one. So this is the PCNL. Okay, right. So this completes this one. The CT urography also tells you the status of hydronephrosis in the kidney. Right? Right. Now, we go on to the next one. Now, this question, guys, I think for a postgraduate, this is just a very take away question. Okay. The simple question is, what is your diagnosis? My diagnosis is a chronic calcific pancreatitis. Okay, so your diagnosis is a chronic calcific pancreatitis. Remember that in this picture, there is ductal calcification. That means if I consider that this is the duct, okay, that there will be ductal calcification as well as calcification in the parenchyma, and hence I gave it a name as a chronic calcific pancreatitis. Okay, and hence I give the name as a chronic calcific pancreatitis. So this completes your description. Now tell me guys, what is the investigations that you are now? This is what I need from a surgeon. The diagnosis is so simple. What are the things that I need from a surgeon? Investigations before planning the operation.
Namaste, please.
No audio, sir.
Shilajit, kindly give me the screen sharing option.
Sir, enable.
Okay, thank you. Okay, very good evening, guys. My Zoom had crashed, so sorry, I could not. Right. So, do you have the screen now? Hello? Hello? Do you have the screen with you guys?
Yes, sir.
Yes, sir. Okay. Yes, sir. Right. So, now, we're talking of this one, so I'll be a little fast now. So, in this one, chronic calcific pancreatitis, as I have said, okay, what are the investigations that you would like to do before the operation? Okay, can anyone of you help me some idea what are the investigations that you would like to do in this patient before the operation? Hello?
MRCP, sir.
Number one is that investigations to locate the ductal diameter. So write it like this one. Investigations to locate the ductal diameter, basically the ductal anatomy. Okay. The first investigation is usually a CT, which tells you the segments of the ducts which are done, and it also tells you the amount of the parenchyma. Okay. Now, MRCP is a good investigation, but remember, MRCP tells you about the ductal strictures. Okay, but MRCP is not a good one to tell you the location of the stones. So what usually will be done is that people will do usually a combination of both CT as well as an MRCP. Now, for early onset disease, now this is not usually for this patient. You can use an endoscopic ultrasound. Remember, there is a criteria called as the Rosemont criteria for a diagnosis. Okay, but what is important is for an established case like this, I will be believing on a CT scan to tell me the parenchyma and the location of the calculi, because when I have to plan my operation, an MRCP tells you the presence of the strictures along with this. Now, the second one is that see for any endocrine associations, so like diabetes, I will like to do a postprandial blood sugar, a fasting blood sugar, and definitely an HbA1c. Okay. Point number 3. If I want to see for now the exocrine insufficiency, I have multiple tests to do. Okay. So I have a fecal elastase content can be one simple test to be done. The next one is that there can be investigations for local complications of the disease. Example, can any one of you mention any local complication of a disease? Of a chronic pancreatitis?
Pseudocyst, sir.
Very good. So pseudocyst is imaged by what investigation, sir? Is usually done by an CT scan or an MRI or an MRCP. Last one, rare complication can be a portal vein thrombosis, which will be manifested by a collaterals that will develop around the splenic hilum on the greater curvature of the stomach. So if you ask me, sir, what are the scheme of investigations that you are going to do for ductal anatomy, for endocrine problems, for exocrine problems, for local complications, I will like to do an upper GI endoscopy to rule out any gastric varices or not. So guys, this completes your answer for something in this group. Okay, chalo, it's all done. Now, this one. Can anyone if you tell me what instrument is this? I'll hurry a bit because I do not know when this next Zoom crash is going to happen. Okay, so what is this device or instrument is? Hello?
Rib retractor.
This is called as a rib, not retractor, sir. This is not retractor. See the instrument. This is called as the liver. Okay, these are called as the blades. So this is called as the rib spreader, or better called as a phenocheto rib, not retractor. It is called as a rib spreader. Okay, do you know of any operation in which you use a rib spreader? Sorry, I will use a black ink, right? Do you know of any operation where this rib spreader is used?
Thoracotomy.
Very good. It is used for doing a thoracotomy. Okay, right. In this, you will be asked about what are the various types of thoracotomy. Please remember, of the various types of thoracotomy. It can be a midline thoracotomy, commonly called as a sternotomy. It can be an anterolateral thoracotomy, which is less commonly done. But what is more commonly done is a posterolateral thoracotomy. Remember that a posterolateral thoracotomy usually starts from the angle of the scapula, continues usually in the fifth intercostal space, and goes up till the nipple line or the nipple point. So this is called as the posterolateral thoracotomy. Okay, right. Now, so any other operation apart from a thoracotomy where this is used? Any other operation? So thoracotomy is a very nice answer. Any other operation where this is used? Come on, man. For an open exposure of the kidney. Remember, this is a very beautiful, versatile instrument, particularly if you have taken the subcostal approach or the transcostal. That means through the 12th rib approach, if you have taken, this suffices as a very beautiful instrument to do that. Last one, if you are giving a human examination, what is that reason in which the thoracotomy was done? What is the example that you have seen for which the thoracotomy was done?
CABG.
Fundoplication needed a thoracotomy. Holy God.
CABG.
Which type of fundoplication? CABG. But CABG did they use as a retractor? I don't think so.
No, sir.
Then?
Lobectomy.
Lobectomy. Okay, good answer, sir. Lobectomy for what? Come on, man. Carcinoma. I will give a very simple answer today.
Some bullectomy.
Bullectomy. Have you seen this operation?
Yes, sir.
Okay, the question is who does
Carcinoma is of lower end.
Oh, एक minute. Who does the CTVS? I know that, man. Oh, I'm very amazed, very nice with this. Okay, I know that CTVS guys do that.
People do the operation.
Anesthesia people do the operation. Why? Because hydatid phase does not form a pericyst. Remember that. So the only thing that this anesthesia chaps have to do is that you have to do the thoracotomy, expose the pulmonary parenchyma, which is always like a collapsed balloon, and then just incise the visceral pleura, tell the anesthesiologist to inflate the lungs, and wow, it comes out like a football, intact, and everyone smiles. So that is okay. Apart from that, as all of you have said, you can do this for what kind of esophagectomy? What route of esophagectomy will you use this for? So, come on, man, simple name. Ivor-Lewis. Okay. Now in an Ivor-Lewis, which space is opened for exploring the thoracic esophagus? Hello? Which space is open for exploring the thoracic esophagus? On the right side. Okay. So remember that Ivor-Lewis requires two incisions. One on the right fifth intercostal space and another one in the midline. Right. Now, this one. This one is a very simple one. All of you have used this. What is this instrument called as? Hello? What is this instrument? So this is the reason I give you this question. This one is called as the knife, or better called as a skin grafting. Now, I have an objection in using the word knife. Hence, I use the word handle, which fits along with the knife. The knife, remember, is a disposable one, whereas the handle is not. Combined together, this goes by multiple name like Humphrey's knife. We have Benedict's knife, which looks like a smaller version of this one. Okay, but this is used commonly called as a skin grafting handle with a blade. So in an exam, if you are given this is called as a skin grafting handle with a blade. Now, what is the common use you know of? So this is used for taking what kind of a skin graft? This is used for taking what kind of a skin graft? This is used for taking a split thickness skin graft. Okay. What are the complications due to use of this instrument? Very specific question. What are the complications that occur due to use of this instrument? Very specific question. Sir, you can produce subcutaneous fat, muscle, sometimes even vessel injury if you are not very careful about the depth of the thing. So how to prevent a deeper injury while you are using a skin grafting handle or blade?
By adjusting the blade.
Sir, 2 points. Very good. Very, very well said. It is usually the distance that you need to adjust. Point number 1. Point number 2. You need to lock this point. So this is the lock point. Okay. But what is most important is if you have done this, if this is the thigh of the patient, this is the leg. Remember, the surgeon always moves like this. Okay. And the assistant always applies a counter traction. So it is always by a traction and a counter traction. So if you don't have a counter traction, remember the knife will immediately slice through the subcutaneous tissues. So always remember that one. So first of all, adjust the blade thickness. Number 2, the knob should be or the lock should be inserted. Number 3, traction and counter traction, which should be an uniform traction. As much as the surgeon, so much so for the assistant. So please remember that. Now, this one, something again from plastic surgery. What is this condition called as? Dupuytren's. Very good. This is the bilateral Dupuytren's contracture. Okay. Which finger is it involved on the right side? This is the base of the 4th digit. On the left side, this is both the 4th and the 5th digit that is involved. Now, what is the treatment plan for this patient? Please don't say alcohol abstinence.
Z-plasty in series.
That is the reason, sir. If you have done a plastic rotations, I'm not a plastic guy, but still, points to know are, see, Z-plasty will only be effective if it is across a joint. That means if it is across a joint, your Z-plasty is going to be effective. But the minute it is involving this palmar fascia, okay, remember, like this one, as you can see, it is involving a thickness of the palmar fascia. You must go for an excision of the palmar fascia, and then you need to thereafter for the finger for the metacarpophalangeal joint. So this area is treated by the Z-plasty. Whereas if there is a thickening or a band, which is usually more than 1 centimeter on the palmar fascia, you need to go for an excision of the thickened palmar aponeurosis or the palmar fascia, whatever you call that to be. Okay, so this is all about the principle that we have to know as general surgeons regarding the treatment. Right. Now, this OSCE is interesting. So guys, what is your differential diagnosis? This was an interesting one. What is the differential diagnosis? Come on, quickly. Meningocele. Okay. Why do you feel it is meningocele? Okay. See, number 1 is that it is soft and transilluminate, isn't it? So this is the reason. Sir, I felt it is meningocele because this is close to the midline. Okay. Now, can you tell me what is exactly a meningocele? If this is the spine, what is exactly a meningocele? Come on, what is exactly a meningocele? What is exactly a meningocele? Can anyone of you tell me what is exactly a meningocele? So meningocele is a type of spina bifida aparta where occurs what is, that is, this is the spina bifida, and then this, the spinal cord and the nerve are there present in the spinal column, but what is absent in the spinal column is the posterior processes of the posterior arch component. Okay, so this is called as a meningocele. Agreed in that, but remember that meningoceles are usually seen in the midline. So this is just away from the midline. So I will always think of meningocele as a differential diagnosis. Anything more that can have this kind of a picture? Come on. Sir,
Cystic hygroma.
Exactly. This is what I wanted you to come out. Is a cystic hygroma, though this is not a common site, and a lipoma. So if the examiner is asking you, give differential diagnosis, he is asking you 1, 2, 3, meningocele, cystic hygroma, lipoma. I really liked it. So sacrococcygeal teratomas are formed to heart. They will not be in the DD. What is the investigation that you will do to know this? Sir, very simple. I will think about
X-ray, LS spine.
an X-ray of the lumbosacral spine. Nowadays, people will shrug away from doing an X-ray, but this is a good investigation. If you need much more than an MRI of the lumbosacral spine, will be a good investigation to tell you and to rule out a meningocele. That's it. Because these are the two that can be operated by a general surgeon. The meningocele will be probably requiring a help of a neurosurgeon. So that is the point of the difference that needs to be understood. Any questions or any queries? Now, if the history is of a much smaller duration and the patient complains of pain in the or a low back pain, what is the differential diagnosis that you shall have? Hello? Sarcoma is soft? No. So I will omit the word transilluminant. Sarcoma can be, but remember that always keep a cold abscess in the back of your mind. Okay? Right. So this completes this part. OSCE 10. What is the differential diagnosis? I have not asked you this one because everyone knows what is this one. This is a left-sided involved. Sir, this is a reducible groin swelling. Reducible groin swelling. What is your first answer? It is a congenital hernia. What is your second differential diagnosis?
Undescended testis.
Undescended testis. Anything more?
Cystic hygroma.
Undescended testis.
Okay, chalo, ठीक, undescended testis. ठीक है, happy. You cannot see the baby, chalo, ठीक है. Anything more? Someone said that. Is an encysted hydrocele of the cord. But sir, encysted hydrocele of the cord does not appear to be a inguinal swelling. Encysted hydrocele of the cord is a scrotal swelling. Remember that. So, can you name of any other kind of swelling? Yes, sir, I can. If this is a congenital, not hernia, but a congenital hydrocele. Okay, what is the difference between a congenital hernia and a congenital hydrocele?
Content.
Content and anything more than the content? Yes. So the fluid. A congenital hydrocele contains only peritoneal fluid, whereas a congenital hernia is known to contain both peritoneal fluid as well as the contents like an intestine. Okay, so this is the so I will have congenital hydrocele. Anything more? Really, yes. There is a variety called the funicular type of a hydrocele, which is a processus vaginalis remnant. So what is the differential diagnosis? Hernia, UDT, congenital hydrocele and funicular type of hydrocele. Now, if it is a congenital hernia, tell me, what is the operation that you are planning to do? Herniatomy. Okay, herniatomy. Okay, good one. Open or lap? Open or lap? Laparoscopy. Sir, in a practical examination, particularly for MS and DNB, always say that this I will do for an unilateral hernia. I will always do an open because this is considered to be a daycare procedure. You can do for a bilateral hernia lab, but remember, there is a big school which is that you can also do a laparoscopy, ligation of the sac from the inside the peritoneal cavity for a bilateral hernia or an unilateral hernia. But in an exam, I will be preferred to say the word open because it makes my life much easier. Now, if it is an undescended testis, in which I will be taking a class on undescended testis to tell you details. Remember, as the scrotal sac is well made, okay, will you call it as an undescended testis or is this terminology okay or should I change it to any other word? This is better called as, no sir, this is better called as an ectopic testis. Okay, undescended retractile testis is a type of an undescended testis. So we'll not go to those terminologies. What is descending testis, ascending testis? But remember, if it is a testis well descent, the treatment of choice is an orchidopexy. In this case, open, not laparoscopy, because it is a palpable testis. Now, how will you treat a funic or congenital hydrocele? Sorry. How do you treat a congenital hydrocele and a funicular variety of hydrocele? What is the treatment for both? What is the treatment for both? Is again herniatomy.
Herniatomy.
Okay. That is also by open, not lap. Right. This completes. Finally, the last of the couple of them. This is everyone, every first year who final year, everyone has used this so many times per day. Sorry. Okay. So now tell me guys, what is this one? What is the specific name for this? Hello? What is this device, man?
Monopolar diathermy.
Do you think this is monopolar diathermy? Come on, this is the reason I told you. The monopolar diathermy unit is something that is there in the box and has those plugs and sockets. It is something that takes in the electricity. In this plug and socket, what is something that you put in? Is called as an active electrode or better called as a diathermy pencil or diathermy active pencil or active pen. So better the real thing is it is called as an active electrode, also commonly called as a monopolar probe. So it is also called as a monopolar probe. Is this one? Now, I have not asked you for an open surgery. I have asked you for a minimal access surgery. What are usually the complications that happen in a minimal access? What is the group of complications that happen? See, the first group of complication that is going to happen is very simple. You are using this one. Say, for example, this is the hook. Okay. So this is the hook and this hook directly produces an injury into that. That means, say for example, your hook was going on with the liver and by this time a loop of intestine came into your view. This injury that it is producing, what is this kind of an injury called as? Hello, what is this kind of an injury called as? This is called as a conductive, okay, coupling. No, this is not capacitive coupling. This is called as a conductive coupling or a direct coupling. Okay, so please remember that. Type not type 1. So do not know about type 1 injury. So this is called as a direct coupling. A indirect coupling will mean that this is the hook which is touching the liver. Now, this hook is also touching now some another instrument which in turn is being touched by a piece of a bowel. So that means that is called now to be an indirect form of coupling. So these are the two common ones. The third one will be that if you use a port and this port has a plastic jacket but the sleeve is made out by plastic. Now what occurs is that the minute you introduce this diathermy, and this is the hook of the diathermy, this is going to discharge a lot of electrons in this area if there is a leak from the Teflon sheath. These electrons are usually dissipated outside like this. In this example, as you can see, these electrons could not get dissipated and they accumulate in this area until and unless you get a loop of a bowel which has a zero charge. This is the negative charge and looks like a capacitor. So this is called as a capacitive coupling. So I've told you what is a capacitive coupling. So capacitive coupling is only seen when there is a plastic jacket to the metal to the metal trocar. If for a plastic trocar, you don't get a capacitive coupling. So for a metal trocar with a plastic sleeve, you get this complication. Okay, right. So these are the things to know about in this minimal access problem. So there can be other problems which are not specific to minimal access, like the surface area. If this is 1, the return electrode, something that completes the circuit, should have an area of 100. That means your return electrode should have a surface area at least 100 times more than this one. So please remember this one. So there are many other complications, but for minimal access, remember direct coupling, indirect coupling, capacitive coupling. So please remember these three.
Sir, can you repeat the return electrode concept?
The return electrode concept, sir, is very easy. Is that, see, let that thing go. Yeah. Return electrode, sir, is that if this is the machine, okay, this is the monopolar. So this monopolar, what it does is that it is bringing in the electricity. So this is the electricity that is being brought out. So this is the AC plug. Now you are taking some electricity from there. This is the handpiece. This is the patient. And to complete the circuit, remember, the electricity has to get, the circuit has to be completed. And it has to come like this. So if this is the way it goes, this is the way it comes. So if this is 1, this has to be 100. So have you understood this one? So this is called as the return electrode. And this is called as the active electrode. Okay, right. So this is the monopolar device. Any questions till now? Sorry, any questions still? No. Hello, any questions still? No. No, I think. Chalo. Now, what is this? What is this strange looking instrument? This is something that your generation will be less seeing because staplers have come into. But still, with staplers, this is something called as a LAR clamp. Very favorite instrument with GI guys, where you apply it at least 1 centimeter below the tumor and go in for an operation called as low anterior resection. Okay, so this is the only use of this instrument. You can do this for a Hartmann's procedure also, but it's usually not required. So this is very specifically used for a low anterior resection for a mid-rectal tumor, where you apply the clamp at least 1 centimeter below the tumor margin. Chalo. Now this one. What is this device? What is this device?
Mayo stripper, sir.
Very good. So this is a varicose vein stripper. Okay. As you can see, these are things called as olive. Now, few simple things to remember in this one. When you talk about a varicose vein stripping, what is important is that this is the great saphenous vein. Okay. This is the femoral vein where I have done the flush ligation. So remember, this is the femoral vein. What I will do for you guys is that I will shade the femoral vein for you guys. What I will do is that I will shade the femoral vein. I will shade the femoral vein with this deep blue color. Now, my question is, in which direction do you introduce the stripper? In which direction do you introduce the stripper? Above downwards like this or below upwards like this? Which one? A or B?
Above downwards.
Okay. Why not B? Why not B? Okay. Both can see. Both can happen. So that's a diplomatic, beautiful answer, sir. You see, you don't do B because the problem is that if you can go by, the stripper can enter like this, and then it can again come like this, and it can again come like this. That means through the perforators, it can enter the femoral vein. That chances are much less. It is not that they cannot happen. If you go it from above downwards, it can happen. But those chances are much less because you are tracking the subcutaneous part of the vein. This is the only answer that I still could get from my cardiothoracic colleagues. Believe me, my whole life, I started by doing B. Then when I became a surgeon, someone told me that, no, you are not doing things right. I read Kirk's surgical operations. Kirk says I don't do those things. And I started doing from back downwards with this logic. Have I made this point clear? Hello? Yes, sir. Okay, right. And what is important is that whenever you introduce the stripper, the first thing that you attach at the end is not the olive. This is called as an waist pin. After it comes out in this region, that means when you get the palpable, this one, you do a small venesection, you do a small venous cut down. Through this point, the pin is removed and the pin is replaced by the term called as olive. So this is the olive. What is the picture? Yes. Sorry. It all went off. Sorry. This is the picture. Yes. So this is the olive. Sorry, guys. So this is the olive. Okay. Chalo. Okay. And then what you can do is that you can just pull, you can need to put in the olive, and after they put in the olive, you just pull it like this. Remember, the vein comes out everted. The vein comes out everted. Okay, right. Completes the job. Chalo, the last one. Oh, what is this device, guys? What is this device? Hello?
Rectal manometer.
This rectal manometer. Wow. This is called as a rigid sigmoidoscope. What is the use of this instrument?
It's a decompression.
Diagnosis of rectal pathologies like cancer, solitary rectal ulcer. Nowadays has been changed by colonoscopy, has taken away the glamour from this instrument, believe me. But when we used to have this in our OT, well, taking a rectal biopsy was so easy. Okay. When you treat it for therapeutic purpose, the only important thing is for a volvulus, you can attempt for a derotation with this. So these are the two things that have still remained with a rigid sigmoidoscope in that. The length of a rigid sigmoidoscope from this to this is 30 centimeters. When you introduce it in the patient, remember 5 centimeter juts out. So that means basically you have 25 centimeter that is inside the patient. 25 centimeter should be able to tell you you are in the distal part of the sigmoid. Remember, the anal canal is 4 centimeter, sigmoid is 16, so 16 and 4 is 20. So that means your sigmoidoscope shows you the distal part of the sigmoid. Completes the job. Right. Now, the last question. Everyone knows what is this suture. This is a PDS or a polydioxazone 2. Now, what is this important is that what are the principles of use of this in abdominal surgery? Okay, what do you think is the PDS used for?
So abdominal rectus closure.
Mask closure.
Very good. Is used for a mask closure of the abdominal laparotomy wound for abdominal wall. Now you'll be asked about simple MBBS like questions about what is the Jenkins rule. That means the 4:1 rule. Some people say it is 5:1, but I will go for 4:1. Number 2 is that if this is all, then there has been newer developments like far and near sutures, X sutures to close the abdomen. But what has stood the test of time is the Jenkins rule of not only 4:1, but remember that the 1 centimeter rule has still remained in practice. 4:1 is the length of the suture, and 1 centimeter is the gap between the margins and the gap between the two sutures. So these are the two things that you are required to know in the abdominal wall closure. Okay, so guys, we had a brief OSCE. I thought that today I'll be taking something lighter, so that apart from doing it every day with some heavy questions, let us have this. So any of the queries from any of the topics, please. Hello, any queries from any of the topics?
Sir, can you please describe the different parts of that rigid sigmoidoscope?
The rigid sigmoidoscope. Just give me a minute, sir. Let me erase all things. See, the main thing in this rigid sigmoidoscope is this instrument. Remember, just a second. See, the first is that this instrument has two basic attachments. Okay, one, you can attach to this one. Now, there are two things that you require to understand. A rigid sigmoidoscope, remember, needs you to put your eye in this point. So this is technically called as an eyepiece. So there is a glass mirror in this. So this is the glass mirror. Not mirror, sorry. Not mirror, this is a glass, transparent glass. Now, the next part of this one is that there is an attachment of a light in this. Parallelly, this is an insufflation cable. This is the sphygmomanometer cuff, which you use it for insufflation of this one. So remember that this balloon acts as a reservoir balloon. So this is usually the reservoir balloon, and then this is insufflation cable. And when you put it inside the rectum, the basic idea is that it will be going up till this. The rectum is capacious. All the air that you are putting in is going to distend the rectum. And by the time you come out, any pathologies like a cancer, etc. can be seen. And then you can see and take the biopsy. So this is the basic idea about doing this one. Okay, right. Hello, any more questions?
Sir, could you please repeat the investigation part of CCP, sir?
Investigation part of CCP. Investigation part of CCP is that to see the anatomy, you need to have a CT scan done or an MRI done or an MRCP done, which tells you the ductal anatomy. Which tells you the ductal anatomy and the parenchyma. Particularly stones are better seen on a CT scan. MRCP tells you about a stricture. Now, to see the endocrine problems like diabetes, etc., you need to have a sugar investigations and HbA1c. To see for exocrine problems, you can go for fecal elastase, though this is rarely done. Now, to look into complications like local complications like pseudocyst, etc., your CT scan and ultrasound is good enough to tell you. Whereas the final one is, if you want to look for the portal vein thrombosis, you can need to go for an upper GI endoscopy. Okay, right. Any more queries and questions, please?
Capacitive coupling, sir.
Capacitative coupling. Which coupling, sir? Which one?
Both, sir.
See, direct is one. If this is the hook, you are touching the liver, and bowel wall comes in front of that, and as you can see, the bowel wall gets electrocuted. So that is a direct coupling. And indirect coupling is, this is the hook. The hook is now touching a trocar, or the hook is touching a trocar, and there is an insulation breach, and this trocar is in turn touching a part of the bowel. So this is called as an indirect coupling. Whereas a capacitative coupling will mean that this is the sheath, this is the plastic hub which is not conducting the electrons. Now what happens is that if you put a laparoscopic hook, the electrons which are leaking out from the hook, from the insulation breach. Remember that this is an insulation breach that is leaking out these ones, and when it leaks out this one, all the electrons are getting accumulated at around this port. If they're getting accumulated at around this port, if it was a metal, it would have been conducted. As it is not a metal, all of them get joined together, and then the bowel has a negative charge and the bowel gets electrocuted. So that is called as a capacitative coupling.
Sir, when both are plastic, why it doesn't happen?
Because very simple. Because electrons will not get conducted. That's it. Electrons, after they come out from the metal instrument, now they need to accumulate someplace. Plastic is never a good conductor of electrons. That is the reason. Okay, right. Okay. So with this, ladies and gentlemen, we finish the OSCE day for the OSCE for this day. Okay. Thank
Sir,
you.
what is the depth, sir? Depth during a mass closure?
Depth, I could not understand. So the depth will be all the mass closure means from the subcutaneous tissue to the peritoneum. That is a mass closure. Okay.
Thank you.
Okay then. Thank you very much.
Thank you, sir.
Okay.
Thank you, sir.
Thank you, sir. Thank you.
Thank you, sir.
Okay, so electrocautery, Bowie and pace, right.
Good night.
Good night.